peaking at approximate 6 weeks and lower spikes occurring episodically thereafter. Transaminase levels follow the pattern of HCV RNA with a slight delay of approximate 1 week. Antibody production begins at 2 months after infection and plateaus at approximate 4 months, thus not corresponding to HCV RNA and transaminase levels. Copyright Embellished. X. Rotavirus infection. Rotaviruses are a common cause of viral gastroenteritis in infants and young children and are transmitted via the fecal-oral route. After a short incubation period of 1 to 3 days, patients present with symptoms of variable severity, which may include vomiting, watery diarrhea, high-grade fever, and malaise. Most patients with rotavirus infection receive a clinical diagnosis of acute viral gastroenteritis. Diagnostic studies are usually not necessary, as they do not alter management. For patients with severe disease or in whom the diagnosis is uncertain, rotavirus infection can be confirmed by antigen detection in the stool. Treatment is supportive and mainly involves fluid replacement and managing symptoms as needed. Rotavirus infection can be prevented by vaccination. Embellished. Epidemiology. A major cause of severe diarrhea in infants and children in the U.S., especially during the winter. A leading cause of severe diarrhea among infants and children worldwide, although all age groups are susceptible to infection. Most commonly occurs in daycare centers and kindergartens. Epidemiological data refers to the U.S., unless otherwise specified. GVO2 shared note. Etiology. E-pathogen. Rotavirus is a non-enveloped, segmented, double-stranded RNA reovirus. Scent transmission, fecal-oral route, example by contact with hands, objects, food, water contaminated with the virus. POV references 2I3. Pi. Pathophysiology. Scent mucosal damage and villus atrophy in the gastrointestinal tract impair absorption of sodium and loss of potassium. Non-bloody, watery diarrhea. VAOLOE. Clinical features. E. Incubation period, 1 to 3 days. E. Fever, malaise. E. Abdominal pain. Scent vomiting and watery diarrhea. O. Can be severe, 10 loose, watery stools within 24 hours. O. Usually lasts 3 to 7 days. Scent mild to severe dehydration. See clinical signs of significant dehydration. References for OOES. Diagnostics ** antigen detection, via enzyme-linked immunosorbent assay, ELISA, or immunochromatography 1.5 cent PCR-CA. 7. X. Rotavirus infection. Clinical features. E. Incubation period, 1 to 3 days. E. Fever, malaise. E. Abdominal pain. Scent vomiting and watery diarrhea. Copyright can be severe, 10 loose, watery stools within 24 hours. O. Usually lasts 3 to 7 days. E. Mild to severe dehydration. See clinical signs of significant dehydration. References for L. OS Eurot, OEA. Diagnostics. Antigen detection, via enzyme-linked immunosorbent assay, ELISA, or immunochromatography * PCR-CI. O. I. Differential diagnoses. Scent norovirus infection. Scent bacterial gastroenteritis * food poisoning. The differential diagnoses listed here are not exhaustive. OOFA, so. Treatment. Plus treatment is supportive, example fluid replacement, electrolyte repletion, antiemetics, IL-8. Copyright children, see treatment of infectious gastroenteritis in children. O adults, see supportive therapy for gastroenteritis. Scent patients with severe gastroenteritis or signs of significant dehydration may require inpatient treatment, including for fluid resuscitation. LOLs, scent for outpatients. Educate patients and / or caregivers on, copyright the expected duration of illness or return precautions. 1. Copyright prevention of rotavirus transmission. 7. FO, XO. Prevention. Rotavirus vaccination, 1I131. Plus general characteristics, 3LL10 live attenuated oral vaccine copyright 2 versions are available, RV1, monovalent, and RV5, pentavalent, plus indications, recommended for all infants unless there is a contraindication, 41L13 plus contraindications to rotavirus vaccination, 4IL13O severe combined immunodeficiency, SCID, O history of intussusception, rotavirus vaccine is associated with intussusception. O other general contraindications for vaccination, example allergy, scent schedule, see ACIP immunization schedule for details on routine and catch-up schedules. 7. Back collapse fine text outline. Rotavirus infection, 1/1. Rotavirus VV. Transmission electron microscopy, TEM, spherical particles, rotavirions, with globular structures, capsomer proteins, on their surfaces can be seen. Source, ID #178, CDC/Dr. Erskine Palmer, Brian Skinner, Centers for Disease Control and Prevention licensed under public domain. Further notes, Public Health Image Library, Phil, 1D178. X. Osteomyelitis. Osteomyelitis is an infection of the bone. It occurs following hematogenous, seeded from a remote source, or exogenous, expansion from nearby tissue, spread of pathogens, most commonly Staphylococcus aureus. Individuals are at increased risk of osteomyelitis following trauma, placement of surgical implants or hardware, or if they are immunosuppressed or have poor tissue perfusion. Osteomyelitis can be either acute or chronic and manifests with signs of local inflammation, including swelling, pain, redness, and warmth. Systemic signs, such as fever and chills, are more common in acute infection. Diagnosis is supported via laboratory tests, imaging, and/or biopsy. In most cases, antibiotic therapy should be delayed until culture results are obtained, so as to better tailor treatment. Empiric antibiotic therapy for osteomyelitis is reserved for patients with signs of sepsis or rapidly progressing infections. Surgery may be necessary to remove necrotic bone, abscesses, infected foreign bodies, or fistulae. Osteomyelitis in adults often assumes a chronic course and requires prolonged treatment, whereas children typically make a quick and full recovery. The diagnosis and management of vertebral osteomyelitis are described in Spinal Infections. W.A. C.E. Definition. Scent osteitis, a general term for inflammation of the bone. Scent osteomyelitis, infection of the bone. He. C.E. Epidemiology. Plus incidence, 20 per 100,000. 1. Scent hematogenous osteomyelitis EO more common in children and adolescents. Copyright incidence is increasing in adults, driven by a rise in vertebral osteomyelitis. 1-2 Scent exogenous osteomyelitis, more common in adults. Epidemiological data refers to the U.S., unless otherwise specified. OO. OQO. Etiology. Roots of infection. 31. Scent hematogenous osteomyelitis, endogenous osteomyelitis caused by hematogenous dissemination of a pathogen. Exogenous osteomyelitis, caused by a spread of bacteria, typically multiple pathogens, from the surrounding environment. 4. Post-traumatic, infection following deep injury, penetrating injury, open fractures, severe soft tissue injury. Copyright contiguous, spread of infection from adjacent tissue equals secondary to infected foot ulcer in patients with diabetes equals iatrogenic. Example. Postoperative infection of a prosthetic joint implant. Risk factors for osteomyelitis. 5. E. Local copyright poor tissue perfusion. Copyright open fractures. O. Severe soft tissue injury. E. Systemic EO immunosuppression. O. Systemic diseases, example diabetes mellitus, atherosclerosis, OE4 drug use sent microbial, highly virulent pathogens. Most HY5 pathogens commonly affected groups * children and adults sent individuals that recreationally use 4 drugs. 6. Staphylococcus aureus, most common cause, sent patients with vertebral lesions v. Back collapse. Find text outline. Most H.I.L. E pathogens commonly affected groups children and adults individuals that recreationally use 4 drugs. 3. Staphylococcus aureus, most common cause, patients with vertebral lesions, patients with prosthetics. M7 diabetic patients with foot ulcers and pressure ulcers. Staphylococcus epidermidis patients with prosthetics. Diabetic patients with foot ulcers and pressure ulcers. Streptococci 5 is neonates and infants. Persons who inject drugs. 6. Pseudomonas aeruginosa plantar puncture wounds, especially if wearing rubber-soled footwear. Salmonella patients with sickle cell anemia. Enterobacteriaceae. Klebsiella * patients with UTIs. Mycobjum tub * C tuberculous spondylitis, pot disease. Pasteurella multocida. Bites from dogs and cats. Immunocompromised patients, individuals that recreationally use 4 drugs. Fungi, example Candida. Y. And. Clinical features. Acute osteomyelitis and subacute osteomyelitis. 5. Scent onset, within days or weeks, associated with acute bone inflammation plus duration. Features of underlying disease, example peripheral neuropathy. Signs of peripheral arterial disease, may be seen in both acute and chronic osteomyelitis. Chronic osteomyelitis. Onset, develops slowly, over months or years, following acute infection. 1. Scent associated with avascular bone necrosis and sequestrum formation, necrotic bone fragment that has become detached from the original bone. 9-degree duration, typically 6 weeks. Scent symptoms, recurrent pain lasting weeks to months, may be cyclical. A3. Scent possible localized findings. Swelling, redness. Deformity. Copyright impaired healing of overlying wounds. Copyright local sinus tract formation, perhaps draining pus. Copyright positive probe to bone test. 19. Scent systemic findings, typically absent, may include low-grade fever, malaise. Copyright a positive probe to bone test is strongly suggestive of osteomyelitis, especially in diabetic patients with risk factors for osteomyelitis. IOT1. Copyright the symptoms of chronic osteomyelitis may be subtle and the diagnosis may only become apparent when late complications occur, example pathological fracture, loosening of implants. 2. OO and diagnostics. The following recommendations are for non-vertebral osteomyelitis. Diagnostics for vertebral osteomyelitis are detailed separately in spinal infections. Approach, 0LL5. Signs of sepsis present, start management of sepsis without waiting for diagnostic test results. Routine studies, CBC, inflammatory markers, blood cultures, and an X-ray v. Back collapse. Find text outline. Approach high of. Scent signs of sepsis present, start management of sepsis without waiting for diagnostic test results. Scent routine studies, CBC, inflammatory markers, blood cultures, and an X-ray. Scent suspected hematogenous osteomyelitis, consider additional studies, example urine culture, chest X-ray, based on clinical presentation. Imaging findings and blood cultures inconclusive, consider bone biopsy with cultures to confirm the diagnosis. In stable patients, defer antibiotics until blood cultures and/or bone biopsy have been taken. Do not delay antibiotic administration in patients with signs of sepsis. Laboratory studies 0. Scent routine studies ECBC, thrombocytosis, possible leukocytosis, 50 inflammatory markers, TCRP, TESR, sensitive but not specific, 12O blood cultures equals may be positive in hematogenous osteomyelitis, C causative pathogens in osteomyelitis, equals typically negative in exogenous osteomyelitis and additional studies, as needed, O features of sepsis present, full diagnostic workup for sepsis copyright purulent wounds/sinuses, consider culture of purulent material. 0 imaging. Routine imaging, 1LL 130-114. Scent X-ray, low sensitivity and specificity for osteomyelitis 15 copyright indication, initial evaluation as can also exclude differential diagnoses of osteomyelitis copyright characteristic findings equals acute osteomyelitis, typically no pathological findings 5 equals subacute/chronic osteomyelitis, bone destruction, sequestrum formation, periosteel reactions 15 plus MRI with and without 4-gadolinium, most sensitive study, 15-degree indications equals suspected acute osteomyelitis, evidence of inflammation. Can be seen. Copyright X-ray is the recommended initial imaging modality because it is inexpensive and can rule out differential diagnoses, however, it may miss acute osteomyelitis as findings are typically visible only 10 to 14 days after symptom onset. Fragate 3. AEIML. Imaging in special circumstances, 15. 510E recent surgery or fracture, labeled leukocyte scintigraphy sent surgical hardware, affecting MRI image quality triple phase bone scintigraphy bone biopsy, 0LL14. Scent indications, imaging findings and blood culture inconclusive scent specimens for, E-gram staining and cultures copyright histology. Copyright bone biopsy with cultures is the confirmatory test for osteomyelitis and should be performed unless there are characteristic imaging features of osteomyelitis and positive blood cultures. OOE. Differential diagnoses. V. Back collapse fine text outline. Differential diagnoses. Scent septic arthritis copyright infection of the joint. In contrast to osteomyelitis, involvement of the metaphysis is rare, copyright may occur secondary to osteomyelitis in infants, bone tumors, example Ewing sarcoma, osteoid osteoma, scent avascular bone necrosis scent benign bone tumors, example bone cyst, scent fracture. The differential diagnoses listed here are not exhaustive. Treatment. The following recommendations are for the treatment of non-vertebral osteomyelitis. For treatment of vertebral osteomyelitis, see treatment of spinal infections. Copyright acute hematogenous osteomyelitis can typically be treated with antibiotic therapy alone. Management of acute osteomyelitis due to contiguous spread and chronic osteomyelitis usually requires surgical debridement of infected tissue. 2118. Antibiotic therapy /LL211L18. Scent empiric antibiotic therapy is rarely required. Scent start most patients directly on pathogen-directed antibiotics based on culture results. Plus consider switching to oral antibiotics after an initial 4-course. Duration of therapy is normally 4 to 8 weeks. 1 Hajades 21. Empiric antibiotic therapy for osteomyelitis. Scent indications copyright signs of sepsis copyright severe or rapidly processing infection copyright consider in diabetic foot osteomyelitis. Plus empiric regimens for adults should cover 22 OS aureus, example with vancomycin, O and gram-negative bacilli, including Pseudomonas. Recommended regimens include Va18 equals meropenem equals or cefepime plus metronidazole. Scent for empiric regimens in children, see osteomyelitis in children. Copyright avoid giving vancomycin with piperacillin tazobactam, while the combination provides cover against both S. aureus and Pseudomonas, it has a high risk of nephrotoxicity. 221. Pathogen-directed antibiotics. Path I antibiotic therapy for litis C2 molds at 8I5, Pathogen first line nafcillin methicillin susceptible S. aureus, MSSA, or oxacillin staphylococcus species or cefazolin. Methicillin resistant S. aureus, MRSA, 24 vancomycin. Cefepime or piperacillin tazobactam pseudomonas aeruginosa cent plus ciprofloxacin. Clindamycin anaerobes argig or ticarcillin clavulinate. Consider adding R in patty with igical hardware / foreign bodies. Che. Surgery 21I25. Manage patient factors that may have impacted healing prior to surgery, example anemia, poor nutrition. Continue antibiotic therapy after surgery, even if bone has been successfully debrided. Fa. Pygical interingitis 0121 surgical intervention chronic osteomyelitis * debridement of necrotic bone and tissue amputation may be considered in severe disease. Acute osteomyelitis refractory to antibiotic treatment B. Back collapse fine text outline. Chronic osteomyelitis acute osteomyelitis refractory to antibiotic treatment infected prosthetic joint or foreign body. Post-traumatic osteomyelitis. Overlying abscess. Poor wound healing or limb ischemia. OOCE. Subtypes and variants 261. Brody abscess. Gical interions in Yelitis 10 LL21 surgical intervention debridement of necrotic bone and tissue amputation may be considered in severe disease. Removal to promote remission. See treatment of prosthetic joint infection, debridement of grossly infected wounds. Removal of surgical hardware may be required. Incision and drainage. Revascularization, see peripheral artery disease, amputation may be considered in severe disease. Scent definition, subacute osteomyelitis characterized by an intraosseous abscess, commonly affects the distal femur and proximal tibia. Scent pathophysiology, hematogenous seeding of a distant infectious focus. Subacute or chronic pyogenic infection of the bone fibers and granulation tissue formation around pyogenic focus. Localized abscess. Scent clinical features O frequently asymptomatic or only mild symptoms. Copyright localized pain. Scent diagnostics, well circumscribed, thick-walled cystic lesion. In the metaphysis and epiphysis of long bones on X-ray and contrast-enhanced MRI. Scent treatment, surgical drainage and antibiotics. WAY. OOXE. Complications /31 L161. Scent infectious O abscess O sequestrum E recurrent or chronic osteomyelitis. Copyright pyarthrosis, infiltration of nearby joints. Copyright sinus tracts. Copyright cellulitis. Degree sepsis. Scent mechanical. Copyright progressive destruction of bone. Copyright pathological fractures O pseudarthrosis, abnormal bone healing E malignant, development of Marjolin ulcer. We list the most important complications. The selection is not exhaustive. VAFO, OA. Special patient groups. Osteomyelitis in children, 191 L271 I10. Overview, 19. Most common form, acute hematogenous osteomyelitis. Scent epidemiology, typically occurs in children. Back. AO. Collapse fine text outline ALET. Osteomyelitis in children, 19 LL271 I10. Overview 19. Most common form, acute hematogenous osteomyelitis plus epidemiology, typically occurs in children 3 months, immunodeficiency, sickle cell disease. Common pathogens include, copyright Staphylococcus aureus. Copyright group A Streptococcus. Copyright King A species, typically in children. Clinical features 28. Scent fever, scent limb pain, which may manifest as eolimpy reduced range of movement. Copyright refusal to use the limb, pseudoparalysis, scent in infants, multiple sites may be affected. Diagnostics. Scent similar to diagnostics for osteomyelitis in adults. Treatment, 101L19. Stable patients. Most children can be managed with antibiotic therapy alone. 10-cent initiation of antibiotics can be delayed up to 72 hours to allow tailoring of antibiotics to culture results. Plus duration of antibiotic therapy, 3 to 4 weeks, 0LL19. Signs of sepsis or rapidly progressive infection. Obtain blood cultures and start immediate empiric antibiotics. Urgent consultation with infectious diseases specialist for choice of empiric antibiotics plus urgent referral for debridement of infected bone and/or drainage of any abscess. 1/9. Complications 27. Similar to those seen in adults, see complications. The following are more common in children. Copyright increased risk of septic arthritis. 28 Copyright impaired growth and long-term limb deformity. Copyright pyomyositis. 28 Copyright DVT and PE1 27. Copyright maintain a high index of suspicion for osteomyelitis in children. Delayed diagnosis and treatment can have detrimental effects on bone development, affecting growth and causing severe long-term impairment. 4A. Prognosis. Acute osteomyelitis. Copyright quick, full recovery is common in children who receive appropriate antimicrobial treatment. 130 Copyright acute osteomyelitis in adults often transforms into chronic osteomyelitis. Chronic osteomyelitis. Copyright difficult to cure. Copyright often requires repeated surgical and antibiotic treatment, over years to decades. Copyright in patients with diabetes or vascular insufficiency, the probability of complete resolution is particularly low. 31. V. Back collapse. Fine text outline. Overlay. Lytic lesion in long bone from subacute osteomyelitis. A. Overlay. Lytic lesion in long bone from subacute osteomyelitis. VV. X-ray left knee, AP view, of a patient with clinically suspected osteomyelitis. The lytic lesion, circled green, seen in the proximal tibia has a partially sclerotic margin, green shaded area. In conjunction with clinical suspicion, this appearance is compatible with subacute or chronic osteomyelitis, Brody abscess. Differential diagnoses include various malignant and benign bone lesions. Brody abscesses typically occur at the ends of tubular bones. They may occur in the metaphysis or epiphysis and can cross an epiphyseal plate. The margins of a Brody abscess may be sclerotic or non-sclerotic. Source: Copyright IMPP. Uroosteomyelitis, 2/4. Overlay. Osteomyelitis. X-ray left foot, dorsoplantar view, marked bony destruction, examples indicated by green overlay, involving multiple metacarpals and phalanges is accompanied by deformities and solid periosteal reaction, examples indicated by red overlay. Degenerative changes, particularly involving the great toe metacarpophalangeal joint, are also visible, indicated by arrowheads. Source: Osteomyelitis worse by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 4.0. Uroosteomyelitis, 2/4. Copyright overlay. Osteomyelitis X-ray left foot, dorsoplantar view, marked bony destruction, examples indicated by green overlay, involving multiple metacarpals and phalanges is accompanied by deformities and solid periosteal reaction, examples indicated by red overlay. Degenerative changes, particularly involving the great toe metacarpophalangeal joint, are also visible, indicated by arrowheads. Source: Osteomyelitis worse by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 4.0. Uroosteomyelitis, 3/4. Overlay. Bony sequestrum VV. X-ray leg, left, AP view, of a child. A fragment of bone, green overlay, has separated from adjacent bone and is surrounded by a lucent rim, red outline. A bony sequestrum is devascularized bone that may be seen in the setting of chronic osteomyelitis. A sequestrum may act as a nidus for ongoing infection. Source: Bony sequestrum in a child femur by Sarindam 7, Wikimedia Commons, licensed under CC by SA 3.0. Modifications: arrow removed. Copyright overlay. Bony sequestrum VV X-ray leg, left, AP view, of a child. A fragment of bone, green overlay, has separated from adjacent bone and is surrounded by a lucent rim, red outline. A bony sequestrum is devascularized bone that may be seen in the setting of chronic osteomyelitis. A sequestrum may act as a nidus for ongoing infection. Source: Bony sequestrum in a child femur by Sarindam 7, Wikimedia Commons, licensed under CC by SA 3.0. Modifications: arrow removed. And osteomyelitis, 4/4. Foot ulcer with abscess and osteomyelitis VV. MRI foot, sagittal plane, fat suppressed, left, T2 weighted, right, T1 weighted post-contrast, of a patient with diabetes on the plantar surface of the first toe, great toe, big toe. An ulcer is visible, from which a peripherally enhancing, hyperintense, sinus tract, right, short arrow, extends toward the interphalangeal joint. An abscess dorsal to the head of the first metatarsal is seen as a hyperintense fluid collection on the T2 weighted sequence, left, long arrow, and as a peripherally enhancing collection on the post-contrast T1 weighted sequence, right, long arrow. The first metatarsal, right asterisk on both images, and proximal phalanx, left asterisk on both images, show hyperintense edema, left, and contrast enhancement, right, indicative of osteomyelitis. Source: Fig 3, in Diabetic Foot Infections, The Diagnostic Challenges by Lori C., Leone A., Cavallini M., Signore S., Giurto L., Ucchelli L., Journal of Clinical Medicine, licensed under CC by 4.0. Marjolins ulcer. Erythematous, purulent, ulcerating tumor with multiple sites of petechial bleeding on the elbow, distal upper arm, and proximal forearm. Source: Marjolin ulcer, Raj, 0509, Wikimedia Foundation, licensed under public domain. X. Septic arthritis. Septic, infectious, arthritis is an infection of the joint space, which can occur in a native joint or a prosthetic joint. Patients with underlying joint diseases, example rheumatoid arthritis, are at an increased risk of septic arthritis. Routes of infection include hematogenous spread, most common, direct inoculation, example iatrogenic, penetrating trauma, and contiguous spread. Patients with native joint infections usually present with an acutely swollen, painful joint, limited range of motion, and fever, whereas patients with prosthetic joint infections, pools, usually have a milder, chronic course, which often makes diagnosis more challenging. All patients with suspected septic arthritis should undergo prompt arthrocentesis for synovial fluid analysis. Early administration of empiric antibiotic therapy and therapeutic arthrocentesis is indicated for native joint infections to prevent cartilage destruction. PJLs typically necessitate surgical debridement, including removal of the prosthesis in some cases. Empiric antibiotics are not recommended unless the patient is critically ill. Targeted antibiotics should be initiated in all patients once culture and sensitivity results are available. Idioton B. Obmaet with 4. WA. And etiology. Routes of spread. Hematogenous spread, most common, O from a distant site, example abscesses, wound infection, septicemia, copyright disseminated infection, example gonorrhea, scent direct contamination. Degree latrogenic, example joint injection, arthrocentesis, arthroscopy, eye copyright trauma, example open wounds around the joint, penetrating trauma, contiguous spread, example septic bursitis, osteomyelitis. Risk factors for septic arthritis. Prosthetic implant interventions, example intra-articular injections, underlying joint disease, especially rheumatoid arthritis, immunosuppressed state, diabetes mellitus, age 80 years, chronic skin infections for drug use, endocarditis, polyarticular septic arthritis. Causative organisms. Scent Staphylococcus aureus EO, most common in adults and children, 2 years, copyright, frequently found in patients with arthritis following invasive joint procedures. 2. K. kingi, most common in infants and children. Yofei, Cs. Clinical features. Acute onset scent, classical triad of fever, joint pain, and restricted range of motion. Scent arthritis O, usually monoarticular, O, most commonly affected joints, knees, followed by hip, wrists, shoulders, and ankles. Copyright joints are swollen, red, warm, and painful. V. Back collapse, fine text outline. Subtypes and variants. Prosthetic joint infection, PJL, IIS. Scent etiology O, early onset, 12 months of placement, most commonly S. aureus. Scent clinical features O, usually prolonged, low-grade course O, minimal swelling, with or without a sinus that drains. Pus. Copyright can present acutely. See clinical features above. E. management, see diagnostics and treatment sections. 6. In order to avoid infection, strict aseptic precautions should be ensured in any procedure that involves penetration of the joint space. Bacterial coccitis, 61. Scent description, septic arthritis of the hip, rare, etiology, S. aureus and group A. Streptococcus account for the majority of cases. 1. Scent clinical findings. Copyright joint pain, may be referred to the groin or knee. Copyright patient's hip is often flexed and externally rotated, this decreases intra-articular pressure and alleviates pain. Copyright see clinical features above. Scent management, see diagnostics and treatment sections. 6. Bacterial coccitis is an orthopedic emergency that requires urgent management to avoid joint destruction. Gonococcal arthritis. Scent gonococcal arthritis is the most common form of arthritis in sexually active young adults. Scent see purulent gonococcal arthritis and arthritis dermatitis syndrome. See targeted antimicrobial therapy for septic arthritis. In a young, sexually active adult presenting with classic symptoms of septic arthritis, gonococcal infection must be ruled out. Lyme arthritis. Scent see Lyme arthritis. Diagnostics. Arthrocentesis, 121. Scent definition, a diagnostic and/or therapeutic procedure in which synovial fluid is aspirated from a joint using a sterile needle. Scent indication, all patients with suspected septic arthritis. Scent additional clinical applications. Copyright synovial fluid analysis, to determine the etiology of joint effusion, example septic arthritis or crystal arthropathy. Copyright suspected hemarthrosis, by confirming the presence of blood within the joint. Therapeutic arthrocentesis, to decompress an effusion or hemarthrosis. Scent important considerations. Copyright skin or subcutaneous infection, example cellulitis, surrounding the affected joint is an absolute contraindication. 12. Copyright consider specialist input prior to arthrocentesis in patients receiving anticoagulants. Copyright consider inoculating synovial fluid into blood culture bottles to improve the sensitivity of cultures. Infection of the skin overlying the affected joint is an absolute contraindication to arthrocentesis due to the risk of introducing pathogens into the joint. 7. Do not delay joint aspiration in suspected septic arthritis, as early detection and treatment are imperative to prevent cartilage destruction. FN 3. Synovial fluid analysis, SFA, in septic arthritis. Scent appearance, often yellow-green and turbid, nonspecific, 7 cell count copyright TWBC count, example 50,000/mm3, 22911 T70 neutrophil, PMN, dominance of 90% scent glucose levels, lower than blood glucose levels V. Back collapse fine text outline. Scent glucose levels, lower than blood glucose levels * gram stain, 1LL7IL14 copyright to guide empiric antibiotic therapy for native joint infection OE. A negative gram stain does not rule out septic arthritis. Scent culture and sensitivity testing, to guide targeted antibiotic therapy, 7. Copyright synovial fluid WBC count may be much lower in PJI than septic arthritis in a native joint. WBC count 1100/mm. 264%, should raise suspicion for PJL11. Copyright neutrophil predominant leukocytosis on SFA may also be present in crystal arthropathy, example acute gout flare. Interpret SFA in close conjunction with clinical features and risk factors. Laboratory studies, 91I1127. Scent blood cultures, for aerobic and anaerobic organisms, copyright patients with fever or acute onset of symptoms 8 copyright positive in 25 to 50% of cases of septic arthritis and 25 to 70% of cases of gonococcal arthritis, 11, scent CBC, CRP-ESR, leukocytosis and elevated inflammatory markers may be seen, nonspecific. Uric acid levels have no diagnostic value in the evaluation of swollen joints. 9. Copyright inflammatory markers may be normal in septic arthritis. 11. Imaging of the affected joint, 15I11I7. Imaging findings of septic arthritis are nonspecific and should be interpreted in conjunction with the clinical picture. May be useful to evaluate for other causes of acute joint pain, example fractures, osteomyelitis, chondrocalcinosis. Ultrasound and fluoroscopy is also useful to guide arthrocentesis in difficult joints, example hip, sacroiliac joint. 5. X-ray. Plus indication, preferred initial imaging modality, prosthetic and native joints. 17 cent supportive findings O may be unremarkable in early septic arthritis. Copyright soft tissue swelling, gas within periarticular soft tissue, and synovial effusion may be seen. 12 Copyright radiothense foreign bodies can be detected. Copyright osteolysis may be seen in concurrent osteomyelitis, 2 to 3 weeks after onset. 16 LL15 Copyright loosening of the prosthesis and periosteel reactions may be seen in PJLS. Ultrasound. Copyright joint effusion with or without synovial thickening. Copyright inflammatory changes in periarticular soft tissue. Copyright effusions and small collections. Copyright can detect radiolucent foreign bodies, if present. CT or MRI. Copyright similar to ultrasound findings. EO bone marrow edema. Copyright can detect intra or periarticular foreign bodies. Copyright nuclear medicine studies cannot distinguish between septic arthritis and inflammatory arthritis and are hence not recommended in the diagnostic workup of septic arthritis in a native joint. INS. V. Back collapse fine text outline. Differential diagnoses. Based on clinical features and imaging. See also differential diagnoses of inflammatory arthritis. Viral arthritis. Etiology, parvovirus B19, hepatitis B virus, hepatitis C virus, rubella virus, HIV. Pathophysiology. Copyright direct invasion of the virus, example rubella, enteroviruses, O immune complex formation, example hepatitis B, hepatitis C, parvovirus, Scent clinical features: O symmetric involvement of multiple small joints. EO sudden onset. Copyright possibly accompanied by rash and fever. Copyright usually no destruction of the joint. Scent diagnostics. Copyright history and clinical findings are the mainstays of establishing a diagnosis. Copyright serology, antibodies against the suspected virus. Copyright synovial joint analysis equals very variable, can be normal or inflammatory, equals not routinely used since viral isolation is usually not successful. Copyright for other diagnostic tests, see diagnostics above. E-therapy. Copyright supportive treatment only, usually self-limited. Copyright C. Hepatitis B, hepatitis C, rubella, parvovirus B19 associated arthritis, and HIV associated arthritis. Fungal arthritis 19. Etiology, histoplasma species, Sporothrix skenkii, blastomyces species, coccidioides species. Scent clinical features. Copyright very variable with acute and chronic courses. Copyright often with symptoms of disseminated infection, example pulmonary symptoms. Scent diagnostics. Copyright synovial fluid analysis may show normal, inflammatory, or septic findings. Copyright synovial fluid culture. Copyright possibly serologic studies, positive antibodies against the pathogen, example in coccidioidal arthritis. Scent see also, overview of fungal infections in the general mycology. Miscellaneous. Avascular osteonecrosis, including Legg-Capperth's disease in children. Bursitis. Based on synovial fluid analysis. 1. Synovial fluid analysis comprises a group of tests that examine synovial fluid to help differentiate between subtypes of arthritis. Type of arthritis: no arthritis. Non-inflammatory arthritis, e.g., osteoarthritis. Inflammatory arthritis, e.g., rheumatoid arthritis, SLE, gout, pseudo-gout. Septic arthritis F11, e.g., caused by bacterial infections. Hemarthrosis 24, e.g., caused by trauma. Back. Appearance: transparent, clear and viscous. Transparent, yellow and viscous. Translucent, opaque, yellow and watery. Cloudy, opaque, yellow or green with variable viscosity. Red with variable viscosity. Synovial HCT can be compared to simultaneous serum HCT to determine the amount of blood in the synovial fluid. Interpretation of synovial fluid analysis. WBC count, PMN. 200-2000/mm. 2000/mm equals 50%. 50,000/mm equals 75%. Asterisk prosthetic joints, 1100/mm equals 64%. Variable difficult to rule out a concurrent inflammatory process based on SFA alone. Equals Na collapse. Degree: 11. Gram stain: negative. 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 Positive in 60 to 80% of cases of non-gonococcal septic arthritis. Positive in negative 24. Crystals: none. Calcium phosphate crystals, appetite present in 30 to 60% of osteoarthritis cases, 241. Monosodium urate crystals, gout, 21. Calcium pyrophosphate crystals, pseudo-gout, 22. None, unless the patient has concurrent gout. 23. None. A. Fine text. Glucose levels, compared to blood glucose levels. Asterisk nearly equal. Cent nearly equal. Ed. Asterisk nearly equal. O. Outline. The differential diagnoses listed here are not exhaustive. OSOE. Treatment. 6. Evacuation of purulent material from the joint and systemic antibiotic therapy are the mainstays of treatment in septic arthritis. Joint drainage. Native joints, degree 1. Scent therapeutic arthrocentesis, drain to dryness, is indicated in all patients. Scent repeat arthrocentesis as often as needed, SFA should be performed at each aspiration. Scent signs of improvement include a reduction in synovial fluid volume, cell count, and percentage of PMNs with each aspiration. 917 * consider surgical drainage if symptoms persist despite serial arthrocentesis. 1. Examples of surgery include 101. Copyright serial lavage via arthroscopy or tidal irrigation system. 17. Copyright arthrotomy and open debridement. 1/117. If effusion persists beyond 7 days of arthrocentesis, arthroscopic or open drainage is indicated. Prosthetic joints. 8. Surgery to remove pus and infected tissue from the affected joint is typically required. Examples include debridement of infected periarticular tissue with retention of prosthesis, scent exchange arthroplasty, example 1-stage exchange arthroplasty, 2-stage exchange arthroplasty, scent arthrodesis. Empiric antibiotic therapy. Scent indication, septic arthritis of a native joint, after diagnostic arthrocentesis has been performed, FN. Empiric antibiotic therapy is not routinely recommended for pools. Adult patients. Empiric antibiotic therapy for adults with septic arthritis of native joints. 311 causative pathogen suggested regimens gram-positive cocci vancomycin ceftriaxone srant co-ed. Or aminoglycosides, example gentamicin, cefepime gram-negative bacilli or meropenem ceftriaxone or cefotaxime or ceftazoxime. If chlamydia has not been excluded, add oral doxycycline. Concern for gonococcal arthritis. 825. Gram stain negative vancomycin plus either. No concern for gonococcal arthritis, degree ceftriaxone degree or cefepime. Intra-articular injection of antibiotics is not recommended. 3. Pediatric patients. 51. Empiric antibiotic therapy for pediatric patients with septic arthritis of native joints. 3. MRSA unlikely, MRSA possible. Cefotaxime v. Back collapse. Fine text outline. X septic arthritis. Adult patients. Empiric antibiotic therapy for adults with septic arthritis of native joints. 3. F11 causative pathogen suggested regimens. Gram-positive cocci * vancomycin. Ceftriaxone gram-negative cocci. Or aminoglycosides, example gentamicin. Cefepime gram-negative bacilli S or meropenem. Ceftriaxone or cefotaxime or ceftazoxime. Concern for gonococcal arthritis. 25. If chlamydia has not been excluded, add oral doxycycline gram stain negative vancomycin plus either. No concern for gonococcal arthritis, degree ceftriaxone. Copyright ORSFPMA. Intra-articular injection of antibiotics is not recommended. 3. Pediatric patients. 3. Empiric antibiotic therapy for pediatric patients with septic arthritis of native joints. 3. MRSA unlikely, MRSA possible. Cefotaxime scent plus either. Infants. Infants 3 months and children up to 14 years of age. Cefazolin. Targeted antibiotic therapy. Switch from empiric antibiotic therapy to culture-specific antibiotics once antibiotic sensitivities are known in patients with native joint infections. Initiation of targeted antibiotic therapy directly, i.e., without preceding empiric therapy, is sufficient for PUI. Specialist consultation is advised especially in patients with PJLS. Targeted antimicrobial therapy for adults with septic arthritis, native joint infection and PJL, L microorganism. Example regimens penicillinase resistant penicillins, example nafcillin, MSSA or cefazolin or ceftriaxone, Staphylococcus aureus vancomycin, MRSA 26 cent or daptomycin. Ceftriaxone or cefotaxime or ceftazocine treat all patients with chlamydia trachomatis co-infection with either and gonorrhea. 83 degree azithromycin. Copyright or doxycycline 3 evaluate sexual partners. See also diagnostics in gonorrhea. F. WA. CE. Complications. Plus joint destruction 1, 28, cent osteomyelitis e sepsis cent children, growth arrest. We list the most important complications. The selection is not exhaustive. V. Back collapse. Fine text outline. Septic arthritis, 1/1. Knee effusion VV. The right knee and area around the knee is markedly swollen and slightly erythematous. Source: Knee fusion by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Modifications: arrow removed. Synovial fluid analysis in septic arthritis VV. Synovial fluid predominantly shows neutrophils. Source: Copyright IMPP. Overlay. Left hip joint effusion. MRI pelvis, T2 fat saturated or stir sequence, coronal plane, of an 11-month-old boy with a mildly elevated temperature and painful left hip. There is a left-sided hip joint effusion, red overlay. The soft tissues surrounding the joint demonstrate increased signal intensity, green overlay, indicating an inflammation surrounding the septic joint. The main differentials for these imaging findings are septic arthritis and transient synovitis. It is often very difficult to differentiate these two conditions on imaging alone during the early stages. Bone marrow edema in the femur or acetabulum, or extensive soft tissue edema around the joint is more suggestive of septic arthritis but is not always demonstrated early, and aspiration of joint fluid may be required to aid diagnosis. This is an example of septic arthritis. Source: Copyright IMPP. Copyright. Overlay. Left hip joint effusion. MRI pelvis, T2 fat saturated or stir sequence, coronal plane, of an 11-month-old boy with a mildly elevated temperature and painful left hip. There is a left-sided hip joint effusion, red overlay. The soft tissues surrounding the joint demonstrate increased signal intensity, green overlay, indicating an inflammation surrounding the septic joint. The main differentials for these imaging findings are septic arthritis and transient synovitis. It is often very difficult to differentiate these two conditions on imaging alone during the early stages. Bone marrow edema in the femur or acetabulum, or extensive soft tissue edema around the joint is more suggestive of septic arthritis but is not always demonstrated early, and aspiration of joint fluid may be required to aid diagnosis. This is an example of septic arthritis. Source: Copyright IMPP. Septic arthritis, 3/3. Overlay. Left hip joint effusion VV. MRI hips, axial view, T1 weighted, with contrast, of an 11-year-old boy with a painful left hip and a fever. The synovium of the left hip is thickened and there is a joint effusion. As this is a T1 weighted image, fluid appears hypointense and therefore the effusion demonstrates hypointense signal, blue overlay. The synovium of the hip demonstrates hyperintense signal due to enhancement, green overlay. A large area of soft tissue around the left hip enhances, demonstrated as hyperintense signal around the hip joint, red overlay. This is due to inflammation of these soft tissues. The main differentials for these imaging findings are septic arthritis and transient synovitis. It is often very difficult to differentiate these two conditions on imaging alone during the early stages. Bone marrow edema in the femur or acetabulum, or extensive soft tissue edema around a joint is more suggestive of septic arthritis but is not always demonstrated early, and aspiration of joint fluid may be required to aid diagnosis. This is an example of septic arthritis. Outlines: sartorius M, rectus femoris M, tensor fasciae lati M. Septic arthritis, 3/3. Copyright. Overlay. Left hip joint effusion VV. MRI hips, axial view, T1 weighted, with contrast, of an 11-year-old boy with a painful left hip and a fever. The synovium of the left hip is thickened and there is a joint effusion. As this is a T1 weighted image, fluid appears hypointense and therefore the effusion demonstrates hypointense signal, blue overlay. The synovium of the hip demonstrates hyperintense signal due to enhancement, green overlay. A large area of soft tissue around the left hip enhances, demonstrated as hyperintense signal around the hip joint, red overlay. This is due to inflammation of these soft tissues. The main differentials for these imaging findings are septic arthritis and transient synovitis. It is often very difficult to differentiate these two conditions on imaging alone during the early stages. Bone marrow edema in the femur or acetabulum, or extensive soft tissue edema around a joint is more suggestive of septic arthritis but is not always demonstrated early, and aspiration of joint fluid may be required to aid diagnosis. This is an example of septic arthritis. Outlines: sartorius M, rectus femoris M, tensor fasciae lati M. Acute septic arthritis VV. Knee arthroscopy of a 26-year-old patient with Staphylococcus lugdunensis septic arthritis after arthroscopic anterior cruciate ligament reconstruction. 3 successive arthroscopies were carried out for irrigation and debridement. Initial arthroscopy, left hyperemia of the synovial membrane, indicating synovitis, and opacity of the synovial fluid with purulent material. Third arthroscopy, 10 days later, right reduced hyperemia, and a clear view with no purulent material source. Fig 2 and 3, in Staphylococcus lugdunensis septic arthritis following arthroscopic anterior cruciate ligament reconstruction by Kama C.S., Bidirya, Ut C.J., Colosimo A.J., Hindawi, licensed under CC by 4.0. Modifications: images combined and cropped. X. Meningitis. Meningitis is an infection of the meninges in the brain or spinal cord. Common causes include viruses and bacteria, although fungal, parasitic, and non-infectious causes of meningitis are possible. The most common bacterial pathogens: N. meningitis, S. pneumoniae, H. influenza, Group B streptococcus, and L. monocytogenes, vary depending on age and underlying medical conditions. Enteroviruses and herpes simplex virus, HSV, are the leading causes of viral meningitis. The classic triad of meningitis, fever, meningismus, altered mental state, occurs in less than half of adult patients, and meningitis in infants and children frequently presents with nonspecific symptoms. Advanced infection includes signs of increased intracranial pressure, ICP, neurological deficits, altered mental status, and seizures. Diagnosis is confirmed with CSF analysis and microbiological studies, example PCR, culture. If increased ICP is suspected, a CT of the head is recommended prior to lumbar puncture. LP. Antibiotic therapy should not be delayed for diagnostic testing. Bacterial meningitis requires rapid initiation of empiric antimicrobials and sometimes glucocorticoids to prevent complications, which include neurological deficits, example hearing loss, and end organ damage, example Waterhouse-Friderichsen syndrome in patients with meningococcal meningitis. While most cases of viral meningitis are self-limiting, herpes virus infections, example HSV, VZV, must be promptly recognized and treated with 4-acyclovir to prevent serious complications and death. Prevention is through vaccination against common causes of meningitis, and chemoprophylaxis for exposed contacts. VAOE. Epidemiology. Asterisk in the pediatric population, meningitis most often occurs in children. Epidemiological data refers to the U.S., unless otherwise specified. WA. 05. Etiology. Common causes. Scent otitis media, scent sinusitis, scent CSF leak after head trauma or neurosurgery, scent maternal group B streptococcal infection during birth, scent sepsis. Risk factors. Immunocompromise, example due to AIDS, asplenia, heavy alcohol use disorder, chronic illness, cancer, sickle cell anemia, old age, pregnancy, scent crowded occupational or living conditions, example college dormitories, military barracks, retirement homes, kindergartens, scent close contact with an infected person. Most common causative agents of bacterial meningitis by age group and underlying condition 4-5. Patient population pathogen by age. Streptococcus agalactiae, Group B Streptococcus, most common cause of early onset bacterial meningitis, felt gram-negative bacilli, Escherichia coli, very common, Klebsiella species, Enterobacter species, Listeria monocytogenes. Streptococcus pneumoniae, Neisseria meningitidis, meningococcal disease, first peak. Haemophilus influenza type B, if not immunized, 10. Neisseria meningitidis, second peak, 16 to 20 years of age, 9 to 50 years, 2 at 11, Streptococcus pneumoniae, most common in adults. Streptococcus pneumoniae, most common, aerobic gram-negative bacilli, example Escherichia coli, Listeria monocytogenes. Haemophilus influenza type B, if not immunized, Neisseria meningitidis 50 years, 2F2. Group B Streptococcus. By underlying condition. Listeria monocytogenes, Streptococcus pneumoniae, Haemophilus influenza type B, gram-negative bacilli, example Escherichia coli, Salmonella species. Back collapse, find text outline. Immunocompromise 13. By underlying condition, Listeria monocytogenes, Streptococcus pneumoniae *, Haemophilus influenza type B, gram-negative bacilli, example Escherichia coli, Salmonella species. Immunocompromise 13. Streptococcus pneumoniae, Haemophilus influenza type B * group of beta hemolytic streptococci, basilar skull fracture, 12. Staphylococcus aureus penetrating trauma F12 * coagulase negative staphylococci, example Staphylococcus epidermidis, aerobic gram-negative bacilli, including Pseudomonas aeruginosa. Coagulase negative staphylococci, example Staphylococcus epidermidis, Staphylococcus aureus gram-negative bacteria, example Pseudomonas aeruginosa, Enterobacter cloacae, Serratia marcescens, Klebsiella species. Propionibacterium acnes, healthcare associated, 41. Less common bacterial pathogens. Scent Borrelia species, Lyme meningitis, Scent Treponema pallidum, syphilitic meningitis, Mycobacterium tuberculosis, tuberculous meningitis, Scent Actinomyces israelii, Scent Leptospira, leptospirosis. Other etiologies. Scent viral meningitis, often associated with encephalitis, meningoencephalitis. Enteroviruses, especially Coxsackie viruses and echoviruses, the most common cause of all types of meningitis in all patient groups. 15. Herpes viruses, HSV, meningitis is more commonly caused by HSV2 than HSV1, CMV, EBV, VZV. Copyright lymphocytic choriomeningitis virus, LCMV, mumps virus, measles virus. Copyright some arboviruses, example West Nile virus, TBEV in Eurasia, Copyright poliovirus, non-paralytic poliomyelitis, aseptic meningitic form, copyright St. Louis encephalitis virus, copyright California encephalitis virus O Western equine encephalitis virus, copyright influenza virus O HIV OJC virus 16E fungal meningitis, copyright coccidioides, copyright Candida spp. Copyright Aspergillus spp. Scent parasitic meningitis O helminths, example Echinococcus species, Strongyloides stercoralis, Angiostrongyliasis cantonensis, Baileys ascaris procyones, O protozoa, example Naegleria fowleri, Acanthamoeba, E non-infectious meningitis, copyright sarcoidosis, copyright tumor metastases, meningeal carcinomatosis and meningeal leukemia. O medication, example NSAIDs, sulfa drugs, 7. Causes of meningitis in immunocompromised individuals. Scent bacterial. Copyright certain immune deficiencies can predispose to certain types of meningitis. 18 equals defects in humoral immunity, including splenectomy, encapsulated bacteria, and meningitis, S. pneumoniae, H. influenza, etc. Equals defects in cell-mediated immunity, example in HIV, drug-induced immunosuppression, M. tuberculosis, L. monocytogenes. Copyright immunocompromised individuals are at increased risk of recurrent bacterial meningitis compared to those with intact immunity. 13. Viral risk is higher in individuals with cell-mediated immune deficiencies, example in HIV infection. 19. O herpes viruses, CMV, EBV, VZV, and HSV6, 1, O HIV EO adenovirus OJC virus, and 64. Scent fungal risk is higher in individuals with cell-mediated immune deficiencies, example HIV infection. 20. Copyright Cryptococcus species, copyright Candida spp. E. histoplasma capsulatum, copyright Aspergillus spp. Scent protozoal, Toxoplasma gondii, rare, 21. V. Back collapse, fine text outline. Pathophysiology. Pathways of infection. Most pathogens that cause meningitis colonize the nasopharynx or the upper airways before entering the CNS via O. hematogenous dissemination. 22. Copyright contiguous spread of infections in nose, eyes, and ears. O. retrograde transport along or within peripheral or cranial nerves. Direct infection, example due to trauma or head surgery. 23. Incubation periods. Bacterial meningitis, usually 3 to 7 days. 24. Scent viral meningitis, usually 2 to 14 days, depending on the type of virus. References 24 LL 25. Y. Or. Clinical features. Clinical features of bacterial and viral meningitis are similar, although viral meningitis is less acute and usually self-limiting within 5 to 14 days. 26. Symptoms of meningitis for LLE1. Plus classic triad of meningitis, 271-28 IL-6 LO fever. O meningismus equals headache equals neck stiffness equals photophobia. O altered mental state, nausea, vomiting, scent malaise, scent seizures. E neonates and young children often present with nonspecific symptoms. See also meningitis in infants and children. Pathogen-specific symptoms. Patients with N meningitis, signs of meningococcemia. Copyright myalgia, more common in children. Copyright possibly petechial or purpuric rash, more common in children. Copyright possibly Waterhouse-Friderichsen syndrome, more common in adults. Scent patients with viral meningitis. Copyright prodrome with flu-like symptoms equals low-grade fever, malaise and fatigue equals myalgia. Upper respiratory symptoms, example sore throat. Degree pharyngitis, herpangina, and slash or rash. Copyright less than half of adult patients have all three features of the classic triad of meningitis. The percentage is even lower in neonates and young infants, who typically present with nonspecific symptoms. Copyright subarachnoid hemorrhage manifests with the classic triad of meningitis, but it typically has a more sudden onset and affected individuals often lose consciousness. Physical examination 29130. Scent signs of meningeal irritation O neck stiffness copyright Kernig sign copyright Brudzinski sign copyright E systemic signs of inflammation O fever O hypotension copyright tachycardia signs of increased intracranial pressure. Back collapse fine text outline. Scent signs of underlying infections copyright bulging and redness of tympanic membrane, acute otitis media copyright skin manifestations 2 equals cutaneous petechiae in meningococcal meningitis, suggestive of meningococcemia equals maculopapular rash in some viral meningitis types, example West Nile virus, enterovirus, non-blinking rash, raises suspicion for meningococcal meningitis or Rocky Mountain spotted fever, see subtypes and variants. Features suggestive of meningoencephalitis 331L24. In addition to the features of meningitis, meningoencephalitis is characterized by signs of inflammation of the brain parenchyma, encephalitis. Focal neurological signs, example paresis, extrapyramidal symptoms, aphasia, seizures, focal onset or generalized, scent behavioral changes, psychosis altered consciousness. 2GOE. Initial management. Scent bacterial meningitis is a medical emergency and requires immediate treatment. Diagnostic and treatment steps should be initiated simultaneously and empiric treatment should not be delayed for diagnostic steps. If the patient is stable and has no LP contraindications, perform LP as soon as possible before starting empiric antibiotics. If the patient is unstable, requires neuroimaging, see criteria for imaging prior to LP in suspected meningitis, or has relative contraindications to LP, example coagulopathy defer LP and start empiric antibiotic treatment, see empiric antibiotic therapy for bacterial meningitis. 5. Diagnostics. Approach 35 36 27 28 5. Obtain samples immediately for blood cultures, routine laboratory tests, and screening for organ dysfunction. Confirm the diagnosis with LP and CSF analysis, if no LP contraindications are present. See also meningitis in infants and children. Copyright start empiric antibiotics immediately after obtaining blood cultures and CSF samples. If LP is delayed for any reason, example the need for a CT or hemodynamic stabilization, obtain blood cultures and administer antibiotics until it can be performed. Laboratory Studies 51L27-28I5. Scent routine tests copyright blood cultures, 2 sets obtained before starting antibiotic therapy degree CBC equals normal/TWBC count in severe infections, WBC count and thrombocytopenia OBMP, blood glucose is needed to analyze CSF glucose. Equals common finding, mild electrolyte disturbances, example hyponatremia from SIAD, equals in critically ill patients, possible signs of acute kidney injury. OARP, elevated C_35V. Back collapse fine text outline. OCRP, elevated, A, sent additional tests E assess for organ damage and complications. Equals coagulation panel, especially if there is suspicion for disseminated intravascular coagulation, example petechiae, purpura, equals blood gas, metabolic acidosis may be present in critically ill patients. Copyright consider testing for atypical infections, neuroimaging, 51L36LL23. Imaging is not necessary to establish the diagnosis of meningitis in most patients and should only be considered in patients with significant risk factors for complications. Scent indications copyright to assess the risk of brain herniation precipitated by LP. 35 Copyright identify abscesses or other localized lesions, example in post-surgical patients in whom infection is suspected, 23 copyright suspected healthcare-associated ventriculitis/meningitis. 23 copyright patients with devices, example CSF shunts. 23 plus recommended criteria for imaging prior to LP in suspected meningitis. 35 IL-3E1 L37O focal neurological deficits. Copyright altered mental status. 86 copyright immunocompromised status, example HIV, post-transplant, taking immunosuppressants. Copyright papilledema o history of CNS disease, example mass, stroke, abscess. Copyright seizures, new onset, 1/35 cent modalities. Copyright CT head, with or without for contrast before LP if increased ICP is suspected. 1/38 OMRI brain with for contrast and diffusion, especially useful in patients with devices or after surgery. 23 Sent supportive findings usually normal or showing mild meningeal enhancement. Copyright may identify predisposing factors for the infection, example fractures, mastoiditis, or complications, example abscess. Copyright see subtypes and variants for characteristic findings of specific pathogens. To remember the indications for imaging before LP, think of LP fails, focal neurological deficits, altered mental status, immunocompromised, or TICP, lesions, space-occupying lesions in the brain, seizures. Cerebrospinal fluid analysis. Lumbar puncture is indicated in all patients with suspected meningitis. See lumbar puncture for details on indications, LP contraindications, procedural steps, and complications. Routine testing, 251 I36 Li 37. Cerebrospinal fluid analysis in meningitis, $1.5 LL 37. Normal bacterial meningitis, viral meningitis. Appearance clear fluid, cloudy, purulent fluid, clear fluid. Elevated cell count with significant pleocytosis, leukocyte count 1000/mm3, variable cell count, leukocyte count 10, cell count 80%. Cell count and differential A, T lymphocytes. Opening pressure 39*5 to 18 cm H 20 degree I*, normal or T. Lactate 36. Copyright 1.2 to 2.1 mol/LTT*, variable. Protein *15 to 45 mg/dlbf*, normal or T. Glucose *40 to 75 mg/dlIV/NQD*, normal. Positive gram stain and culture Fa 3637. Copyright meningococci, gram-negative diplococci AOE pneumococci, gram-positive diplococci. No organisms. Gram stain and culture 36137 present no organisms present. Copyright listeria, gram-positive rods 13637 OE Haemophilus influenza, gram-negative coccobacilli. Atypical pathogen testing. Atypical pathogen testing is not necessary for all patients and should be performed as directed by clinical suspicion. V. Back collapse. Fine text outline. Atypical pathogen testing is not necessary for all patients and should be performed as directed by clinical suspicion. Cerebrospinal fluid analysis in meningitis due to atypical path. CB tuberculous meningitis 401 Lyme meningitis 41 cryptococcal meningitis 42. Appearance * clear fluid with a spiderweb clot 1 * clear fluid * cloudy fluid * variable cell count 3300/mm3 140 * variable cell count 10-1000/mm plus variable cell count 20 cell count and differential X300 cent pleocytosis, predominantly lymphocytes but also granulocytes and plus pleocytosis, lymphocytes, mononuclear 200/mm. For a mononuclear cells, O cent pleocytosis, lymphocytes, 42. Opening pressure ITT degree. Lactate, 86, F * variable F. Protein 7. Copyright normal or T410, 421. Glucose OW * normal or J. Y42. Additional microbiological testing. Sent special microbiological stains acid fast staining, if there is suspicion for tuberculous meningitis O India ink preparation, if there is suspicion for Cryptococcus copyright right or Guiamsa stain, if there is suspicion for toxoplasmosis sent special cultures 37 copyright viral culture not typically recommended may confirm enterovirus, herpes simplex virus infection copyright M tuberculosis cultures, results can take up to 6 weeks. 137 O fungal cultures, for the identification of Candida species, Cryptococcus species 871 O for patients with CSF shunts or drains, extend CSF cultures for at least 10 days. J plus PCR for viral meningitis and specific bacterial subtypes 135 IS cent degree indications equals confirmation of viral meningitis/encephalitis, example HSV, equals detection of intracellular bacteria, example TB, rickettsial infections, JO disadvantages equals no antibiotic sensitivity data for bacterial infections equals not readily available for unusual pathogens, especially bacteria. E-latex agglutination test, 35. Copyright bacterial antigen detection 1 not routinely used because of variable accuracy, 35 L equals consider in patients in whom there is strong suspicion for bacterial meningitis despite negative gram stain or culture after 48 hours copyright fungal latex agglutinations, especially relevant for cryptococcal antigen testing, see cryptococcal meningitis. 7 degrees. OE. Treatment. Approach. Scent apply appropriate isolation precautions. Scent stabilize the patient as needed. Administer empiric antibiotics as soon as possible, preferably within 1 hour, see empiric antibiotic therapy for bacterial meningitis. If LP can be performed rapidly, administer antibiotics and adjuvant therapy, example dexamethasone, after obtaining CSF. If LP is delayed, example because neuroimaging is required, administer antibiotics and adjuvant therapy, example dexamethasone, immediately. Copyright add other antimicrobial therapy, example antivirals, antifungals, as needed, see subtypes and variants for details. Scent tailor antimicrobial therapy once the pathogen is identified. Provide post-exposure prophylaxis for close contacts if indicated, see post-exposure chemoprophylaxis for bacterial meningitis. See also meningitis in infants and children. Copyright do not delay administering antibiotics if neuroimaging is indicated prior to LP. Obtain blood cultures, start antibiotics and steroids, if needed, immediately, then proceed with the CT and LP. V. Back collapse fine text outline. Immediate stabilization for meningitis. Airway management, secure the airway, example intubate, if GCS. Antimicrobial therapy. Empiric antibiotic therapy 5. The choice of initial empiric therapy depends primarily on the prevalence of organisms in certain age groups and individual patient risk factors for resistant organisms. Factors to consider, epidemiological factors, example local flora, resistance patterns, copyright bioavailability, antimicrobial agents should cross the blood-brain barrier and higher doses may be needed. Copyright individual patient risk factors and comorbidities. Empiric antibiotic therapy for bacterial meningitis 35 patient characteristics recommended regimen age. Vancomycin *+1 of the Ig third. IHAL RI age 18 to 50 years equals copyright ceftriaxone, preferred, copyright cefotaxime. Vancomycin plus ampicillin plus 1 of the following third generation cephalosporins, age 50 years degree cefotaxime degree ceftriaxone. Vancomycin plus ampicillin plus 1 of the following, immunocompromised 643. Copyright cefepime. Copyright meropenem. Copyright ampicillin is added if patients are at risk of Listeria species infection, example newborns, pregnant women, adults 50 years of age, or immunocompromised patients, because cephalosporins are ineffective against Listeria spp. Empiric therapy for viral meningitis, 441I45. Most cases of viral meningitis, example caused by enteroviruses, can be treated supportively. Specific antiviral therapy is only warranted if viral encephalitis is also suspected. See HSV encephalitis for further details. Scent indications. Copyright concern for HSV encephalitis, for example, equals suggestive clinical features, example focal neurological deficits, altered mental status, seizures, behavioral changes, coma, imaging findings, example temporal lobe enhancement, CSF, TRBCs despite a non-traumatic LP, suggestive of hemorrhagic encephalitis, concern for other herpes viruses, example VZV, EBV plus recommended empiric antiviral agent, acyclovir. 1. Copyright continue treatment if either HSV or VZV is detected. Otherwise discontinue. Copyright treatment with acyclovir should be started in all patients who present with typical clinical signs of viral meningoencephalitis and only discontinued after PCR and antibody tests are negative for HSV and VZV, even if CSF is initially normal. Pathogen-specific therapy. The decision to narrow therapy should be guided by final culture and sensitivity results, as well as local resistance patterns. We list a few examples of antimicrobial agents that may be used against specific pathogens. P-specific therapy in meningitis 5L9L. Pathogen examples of antimicrobial agents. S. Penicillin raceyi strains, MRSA * vancomycin. S. Epidermidis H. influenza * 3rd generation cephalosporin, example cefotaxime or ceftriaxone, and meningitis SEA sent for E. coli in neonates, add gentamicin. E. coli L. monocytogenes * ampicillin. S. agalactiae * consider the addition of gentamicin. V. Back collapse. Find text outline. Path P. Ific Th pi in meningitis 10, pathogen examples of antimicrobial agents. SSIE, penicillin raceyi, strains, MRSA vancomycin S. epidermidis H. influenza 3rd generation cephalosporin, example cefotaxime or ceftriaxone, and meningitis AGS for E. coli in neonates, add gentamicin. E. coli L. monocytogenes ampicillin consider the addition of gentamicin. S. agalactiae gentamicin enterococcus SPR, plus either ampicillin or vancomycin. P. aeruginosa * cefepime. R. rickettsia sent doxycycline. Herpes viruses * acyclovir. Less frequent example MC neoformans, B. Burgdorferi. C. subtypes and variants. Corticosteroids 341L50. Scent indication, suspected or proven meningitis due to S. pneumoniae or H. influenza E. mechanism, reduces the local and systemic inflammation seen in bacterial meningitis and improves outcomes. Recommended agent, dexamethasone. Copyright should be administered before or concomitant to antibiotics for optimal results. 86. Copyright discontinue if a pathogen other than S. pneumoniae or H. influenza is identified. Plus disadvantages, side effects, example hyperglycemia, GL bleeding degree, sent for pediatric use, see meningitis in infants and children. 3. Do not delay antibiotics to administer adjuvant therapy. If dexamethasone is not readily available, start antibiotics immediately. WA. OE. Subtypes and variants. Tuberculous meningitis. E. pathogen, Mycobacterium tuberculosis. E. incubation period, approximately 2 to 8 weeks. Scent risk factors, Immunocompromise, example HIV infection, sent clinical course O subacute course over several weeks or months. Copyright gradual manifestation with intermittent fever. Sent clinical features. Copyright typical symptoms of meningitis, including fever, headache, neck stiffness, and altered mental status. See clinical features section above for details. Copyright focal neurological deficits, example hemiparesis, due to hematogenous dissemination of cranial arteritis. Copyright cranial nerve deficits are most commonly seen in basal meningitis and predominantly involve the abducens nerve. 51 cent diagnostics degree CSF fluid equals presence of acid-fast bacilli on CSF gram stain. 4OL37 equals culture is the gold standard for diagnosis, but results may take weeks. 37 equals analysis of adenosine deaminase, ADA, activity equals TTTT activity in CSF of individuals with tuberculous meningitis compared to CSF of individuals with other types of meningitis, example cryptococcal or bacterial meningitis, equals for the differentiation of tuberculous from other types of meningitis. Combining serum and CSF ADA activity can increase sensitivity and specificity. 2 equals however, reported sensitivity and specificity vary greatly in the literature. Confounding factors include the CSF ADA cutoffs, assay types, and comorbidities, especially HIV. 53. OCT/MRI, possible hydrocephalus, basilar meningeal thickening, tuberculosis, edema, infarcts. 40 cent complications. Copyright communicating, malabsorptive, hydrocephalus, copyright pituitary gland insufficiency. Cent treatment OC treatment in tuberculosis. Adjunctive glucocorticoid therapy with dexamethasone or prednisolone tapered over 6 to 8 weeks. 54. V. Back collapse. Fine text outline. Cryptococcal meningitis. Pathogen, Cryptococcus neoformans, a type of encapsulated yeast. Scent risk factors. O AIDS. O exposure to pigeon droppings. Scent clinical course, subacute onset with low fever, fatigue, and headaches. Scent clinical features. Copyright see section on clinical features above. O meningeal symptoms are often absent. Scent diagnostics. 55. Copyright cryptococcal antigen testing of CSF and serum highly specific and sensitive. 5 equals typically performed via latex agglutination or enzyme immunoassay. OCSF culture, Saburad agar, OCSF gram staining, India Inc., clear halo, mucicarmine, red inner capsule, OMRI, gelatinous pseudocysts, soap bubble appearance, plus treatment. 54. Degree induction, intravenous amphotericin B plus flucytosine for at least 2 weeks. Degree consolidation, fluconazole for at least 8 weeks. Degree maintenance, fluconazole for at least 1 year. Degree manage raised ICP with therapeutic lumbar puncture. A degree important consideration, delay initiation of CART for 4 to 6 weeks after starting antifungal therapy to reduce the risk of immune reconstitution syndrome. Tick-borne diseases. North America. E. Lyme meningitis, C. Lyme disease. C. Rocky Mountain spotted fever, RMSF. E.C. ehrlichiosis. Eurasia, tick-borne meningoencephalitis. Scent pathogen, tick-borne encephalitis virus, TBEV. OTBEVs are part of the Flaviviridae family and occur predominantly in parts of Europe, Russia, and Asia. Copyright TBEV is very closely related to the Powassan virus in the US and Russia, which is a rare cause of encephalitis. Scent route of infection, tick-borne. Copyright Ixorid tick acts as a vector, therefore, transmission is predominantly in June/July and September/October. Copyright occasional transmission via unpasteurized dairy products from infected livestock. Incubation period, usually 7 to 14 days. Scent clinical features, nearly 90% of cases are asymptomatic. Biphasic course, initial flu-like symptoms and fever, followed, after 8 days, by a fever-free interval and subsequent increase in temperature, which is associated with the onset of meningoencephalitis. Scent treatment, symptomatic prognosis, copyright. Full recovery is common, particularly in children and adolescents. Copyright in symptomatic disease, residual symptoms may occur. Plus prevention, a vaccine is not available in the U.S. Copyright active immunization with an inactivated TBEV, inactivated vaccination. Large-scale implementation of this vaccination is not generally recommended. Degree: the CDC's Advisory Committee on Immunization Practices, ACIP, recommends the vaccination only for individuals living, traveling, or working in high-risk areas, laboratory staff exposed to TBEY, foresters, etc. Primary amoebic meningoencephalitis 571. Pathogen, Naegleria fowleri, colloquially referred to as brain-eating amoeba, found in warm fresh water, example ponds, hot springs. Route of infection, via contaminated water entering the nose, example while swimming, invades the CNS directly via the olfactory nerve, perforates the cribriform plate, JV. Back collapse. Fine text outline. Primary amoebic meningoencephalitis 571. Pathogen, Naegleria fowleri, colloquially referred to as brain-eating amoeba, found in warm fresh water, example ponds, hot springs. Scent: route of infection, via contaminated water entering the nose, example while swimming, invades the CNS directly via the olfactory nerve, perforates the cribriform plate. 4. Scent clinical features, causes fulminant meningoencephalitis with rapid onset. Scent diagnosis: OCSF analysis. Percent findings similar to those of bacterial meningitis, example neutrophilic pleocytosis, hypoglycerakia, increased CSF protein, equals CSF erythrocytosis, due to hemorrhagic necrosis, equals microscopy shows trophozoites. Scent treatment, amphotericin B, miltefosine plus prognosis, nearly always fatal, 158. 4. References, Slsalarl 2 idea IE4. VA your note. 0 red knot. Complications. Neurologic. Most common, sensorineural hearing loss, transient or permanent, focal neurological deficits 1, 65 seizures 1 cognitive impairment spasticity or paresis cerebral edema and elevated ICP communicating hydrocephalus, cerebrovascular disease, rare, brain abscess, subdural empyema, arteritis, risk of cerebral infarction and cerebral venous sinus thrombosis, ventriculitis, cerebritis. Waterhouse-Friderichsen syndrome. Scent epidemiology, predominantly affects small children and asplenic individuals. Scent description, acute primary insufficiency of the adrenal gland most commonly caused by adrenal hemorrhage. A dangerous complication of a number of diseases but most commonly associated with meningococcal meningitis. Rarer causes include DIC, endotoxic shock, and septicemia due to other pathogens, example S. pneumoniae. Scent pathophysiology, coagulopathy triggered by endotoxins, which often leads to hemorrhagic necrosis of the adrenal glands. Scent clinical features: O fever, myalgia, non-blinking, petechial rash, mostly on trunk and legs, in severe cases, even purpura fulminans with extensive necrosis of the skin, severe malaise, hypotension or even shock, findings of disseminated intravascular coagulation, findings of acute adrenal gland failure, respiratory failure. Degree. Scent treatment, copyright treatment of the underlying cause. See empiric antibiotic therapy for bacterial meningitis and pathogen-specific therapy in meningitis. O parenteral fluid therapy and management of disorders of sodium balance. Copyright coagulopathy treatment. Scent prognosis, fatal without treatment and often fatal even with treatment, particularly if associated with meningococcal infection. 40% mortality rate, 66. 1 PN. V. Back collapse. Fine text outline. Prognosis. Sent bacterial meningitis O fatal if left untreated. Copyright prognosis in treated patients depends on age, overall condition, immune status, and the pathogen. Involved. Sent viral meningitis O resolves spontaneously in the majority of cases. Copyright residual symptoms such as sensorineural hearing loss, epilepsy, and cognitive deficits are rare. Fungal meningitis copyright associated with neurological sequelae and a high mortality rate. Copyright treatment adherence is very important to avoid relapse. References, 68 LL 69. OSOE. Prevention. Primary prevention, 7 degree. Sent follow recommended ACIP immunization schedules, particularly for copyright meningococcal vaccine OE pneumococcal vaccine EO Haemophilus influenza type B vaccine promptly treat infections that can spread to the CNS, example mastoiditis, sepsis. Meningococcal vaccine, 71L9. Sent there are 3 types of meningococcal vaccine. O meningococcal ACWY vaccines, protein conjugate, 71, O meningococcal B vaccines, protein-based, 71 copyright pentavalent meningococcal vaccine, MEN ABCWY, 721. Asterisk the meningococcal vaccination schedule varies widely between countries. Copyright in the U.S. vaccination is recommended for adolescents 1 equals individuals with risk factors for meningococcal disease. O for further information, see ACIP immunization schedule. Copyright individuals for whom both the meningococcal ACWY and meningococcal B vaccine are indicated at the same visit can be offered the pentavalent meningococcal INE 72 vaccine. Prevention of onward transmission. Plus follow empiric droplet precautions and then adjust based on the identified pathogen. 175th. Sent provide post-exposure chemoprophylaxis for close contacts. 9. Meningococcal disease is a nationally notifiable disease. Other etiologies of meningitis may also be reportable depending on local state law. 174. Post-exposure chemoprophylaxis, 75. Administer chemoprophylaxis as soon as possible, preferably within 24 hours of symptom onset in the index patient. A9. Prophylaxis, for bacterial meningitis, *LL75 pathogen indications recommended regimens, 9 plus rifampin C2 copyright sent all close contacts within 7 days of symptom onset, i.e., or ceftriaxone 19 copyright household members 1 or ciprofloxacin, should be avoided in 9 N-Menas velo copyright individuals exposed in a child care setting copyright pregnant patients, ceftriaxone is preferred, degree individuals directly exposed to respiratory secretions copyright children, unless there are contraindications to other options. 178. Copyright passengers on long flights copyright patients residing in areas where fluoroquinolone-resistant N meningitis has been detected 91. Close contacts I all household contacts if anyone in the household meets any of the following criteria, copyright. Back collapse fine text outline. Prophylaxis for bacterial meningitis M1751. Pathogen indications recommended regimens, 9. Rifampin, 2 degree L all close contacts within 7 days of symptom onset, i.e., or ceftriaxone 9 copyright household members 1 copyright individuals exposed in a child care setting 76-9 or ciprofloxacin, should be avoided in N meningitis V7 copyright pregnant patients, ceftriaxone is preferred, copyright individuals directly exposed to respiratory secretions copyright children, unless there are contraindications to other options, 78, copyright patients residing in areas where fluoroquinolone-resistant N. meningitis has been detected 91 copyright passengers on long flights. Close contacts 1 all household contacts if anyone in the household meets any of the following criteria, copyright. ZO. CE. Special patient groups. Meningitis in infants and children 6I9Li7. Etiology ALL9. Scent bacterial copyright. Copyright rates of bacterial meningitis in infants and children are declining due to a combination of vaccination against HIV and Streptococcus pneumoniae and prenatal GBS screening and prophylaxis. 7 degrees. Clinical features 61 L80 Children. Copyright changes in vital signs equals temperature instability, hyperthermia, hypothermia equals abnormal breathing patterns, tachypnea, apnea equals heart rate changes, tachycardia, bradycardia. Scent for children equals 2 years of age. See clinical features of meningitis. Diagnostics for meningitis in children, registered degree. Scent diagnostics for meningitis do not differ significantly between adults and children. Treatment for meningitis in children, 8411801. Scent initial management of meningitis does not differ between children and adults. Scent for unstable patients, initiate immediate stabilization for meningitis. Scent start empiric antimicrobial therapy as appropriate. V. Back collapse. Find text outline. Special patient groups. Meningitis in infants and children 6I91I71. Etiology 8 Scent bacterial copyright. Rates of bacterial meningitis in infants and children are declining due to a combination of vaccination against HIV and Streptococcus pneumoniae and prenatal GBS. Copyright screening and prophylaxis. 70. Clinical features /6180 LL81. Scent children. Diagnostics for meningitis in children 8 degrees. Scent diagnostics for meningitis do not differ significantly between adults and children. Treatment for meningitis in children 841,180. Initial management of meningitis does not differ between children and adults. Scent for unstable patients, initiate immediate stabilization for meningitis. Scent start empiric antimicrobial therapy as appropriate. Empiric antibiotic therapy. Plus neonates. Copyright always initiate empiric antibiotic therapy. Recommended empiric antibiotics are ampicillin plus either or both, IL-461 gentamicin 9. Equals cefotaxime. Scent infants and children equals 29 days of age. Copyright suspected bacterial meningitis, start empiric antibiotic therapy with vancomycin plus ceftriaxone. Suspected viral meningitis in otherwise healthy children, 1. Consider using a meningitis scoring system, example the bacterial meningitis score. 918L4LLS7. Avoid ceftriaxone in neonates because of the risk of kernicterus, use cefotaxime or ceftazidime when possible. 9. V. Back collapse. AO. Find text outline. Uromeningitis, 1/2. Kernig sign VV. The Kernig sign can be assessed using 2 methods. In the first method, A, the extended leg is passively elevated at the hip joint. If there is pain, there is reflex flexion of the knee. Alternatively, B, the Kernig sign can be assessed by flexing the hip and knee at a 90 degrees angle. Subsequent extension of the leg causes stretching of the nerve roots or meninges, which can result in pain and muscle guarding against extension. Copyright Embellished. Brudzinski sign. Passive flexion of the neck, A, leads to spontaneous flexion of the hips, B, as a reflex, which provides relief of painful strain on the meninges. Copyright Embellished. Stabilize, if needed, scent shock/hypotension, 4 crystalloid scent airway management scent treat seizure if present * dick signs, coagulopathy treatment. Suspected meningitis goal, start empiric therapy, fever, headache, nuchal rigidity, as quickly as possible. Presence of a non-blanching rash should raise suspicion for meningococcal meningitis or Rocky Mountain spotted fever, RMSF. Scent establish 4-axis scent administer Oz, if respiratory distress. Obtain blood for culture, glucose, WBC, and coagulation studies. Lumbar puncture safe. Perform lumbar puncture. Why? Alarm symptoms, fails, scent focal neurological deficit * altered mental status scent immunocompromised, ICP elevated scent lesions in brain or skin near LP site scent seizures. Lumbar puncture unsafe. Yes. VV do not delay empiric treatment while waiting for head CT. Empiric therapy, ceftriaxone plus vancomycin plus dexamethasone if pneumococcal, adults, or _hemophilus, children, meningitis suspected plus ampicillin if high risk for listeria meningitis, immunocompromised or age 50. Empiric therapy until CSF cultures. No signs of raised ICP obtain head CT, LP not contraindicated. Signs of raised ICP ring enhancing 250, continue empiric therapy consider other diagnoses fungal TB until pathogen detected and, example toxoplasmosis, abscess, adjust accordingly CNS lymphoma, +/biopsy. WBC, 100-1000 greater than 1000 predominant, lymphocytes PMNs glucose, 40-70. Viral bacterial. JLL. Supportive plus stop empiric therapy. V. Consider HSV encephalitis if * altered mental status anosmia * bloody tap * temporal lobe involvement. Management of meningitis. Copyright Embellished. Further workup, gram stain, acid fast stain, India ink stain, fungal antigen, PCR, culture-rash but CSE findings not classic. V. Inda sent ad doxycycline empirically sent further workup, serology, for meningococcal meningitis PCR, skin biopsy, and sensitivity * history of tick exposure. Post-exposure prophylaxis for close contacts sent adults, rifampin, ceftriaxone, or ciprofloxacin sent pregnant, ceftriaxone sent minors, rifampin, ceftriaxone. Adjust therapy _ meningococcal accordingly or HIB meningitis. / Lidocaine. Lumbar puncture, 1/2 materials, patient positioning, and puncture site. Sterile materials, upper left, A. Local anesthetic, B. Syringe for application of local anesthetic, C. And D. Syringe and needles for superficial and deep application of local anesthetic, E. Gauze, F. CSF collection tubes, 4. G. Forceps, H. Sterile gloves, I. Antiseptic, J. Spinal needle. Non-sterile materials, lower left, K. Surgical mask. Meningitis, 2/4. Lidocaine. / antiseptic. Lumbar puncture, 1/2 materials, patient positioning, and puncture site. J. Spinal needle non-sterile materials, lower left, K. Surgical mask patient positioning, the patient is typically seated and flexed forward, upper right, or placed in a flexed lateral recumbent position with the head supported, lower right. Flexion increases the interspinous space and facilitates access to the subarachnoid space. Puncture site, far right for lumbar puncture, including spinal anesthesia, the spinal needle is typically inserted in the L3-4 or L4-5 interspace and directed toward the umbilicus. Copyright Emboss. Meningitis, 3/4. NL4L4ILDW, IEHOG LSU5XINE2 A3AES /FAHI2 /Y TLE AYEGA /A FAT D ILG equals A BSY7 Y /1 I2 GI I A 401 Euro YGAA7 EGY IIDS equals _A. Lumbar puncture, 2/2 procedure. 1. The skin is prepped widely with antiseptic in a spiral motion outwards from the intended needle insertion site. A sterile fenestrated drape is typically applied over the antiseptic prep, not shown. 2. Local anesthesia is injected subcutaneously with a small gauge needle, creating a skin wheel over the intended needle insertion site. Local anesthesia is then infiltrated into the deeper tissue through the skin wheel, anesthetizing the entire intended needle tract. 2a. 3. The spinal needle is inserted with the tip directed towards the umbilicus and advanced until a loss of resistance is felt. Failure to direct the needle toward the umbilicus may result in the needle encountering bone before reaching the subarachnoid space. 3a. 4. The stylet is withdrawn and the needle hub is observed for CSF flow. If flow is present, CSF is collected in 4 collection vials. 5. The stylet is replaced after the collection of CSF is complete. 6. The spinal needle and stylet are removed and a dressing is applied to the puncture site, not shown. MARANAC. Overlay. Neisseria meningitidis photomicrograph of a cerebrospinal fluid, CSF, sample, gram stain, 1000x magnification, gram-negative diplococci, examples indicated by arrowheads, the classic morphology of Neisseria meningitidis, are visible. Source, Neisseria meningitidis CSF gram 1000 by MICR Oman 12345, Wikimedia Commons, licensed under CC by SA 4.0. Tuberculous meningitis VV. Anatomical specimen of a brain, caudal view, with dura mater removed. The arachnoid and pia mater are thickened and discolored, white-grayish, in the area of the brain stem and the cerebellum. These changes, particularly if they occur in the basal arachnoid and pia mater, are characteristic of tuberculous meningitis. Hence also the term basal meningitis. Source, Tuberculous leptomeningitis by Yale Rosen, Flicker, licensed under CC by SA 2.0. Meningitis, 2/10. Tuberculous meningitis VV. 12-month-old infant with HIV and Mycobacterium tuberculosis. The child's body presents a position typical for a seizure. The head is overextended and the feet reach out for the head. Neck stiffness and general tension in hands and feet are also present. These findings are suggestive of meningoencephalitis. Source, Figure 132, 12-month-old child with late diagnosis of HIV infection, presented with TB meningitis, in Atlas of Pediatric HIV Infection by Regina E. Oladikan, Raniko J. Leloania, Carol Hlila, Agaja C. Ubisi, Sharafat O. Khatibi, Ambeva O. Malanda, Brian S. Ely, Kpan Books, licensed under CC by ND 4.0. Meningitis, 3/10. Cryptococcus neoformans A. Photomicrograph of a fungal culture, India ink stain, numerous spherical yeast cells of different sizes can be seen. The polysaccharide capsules appear as yellowish halos around the cell walls, dark circles. These features are characteristic of Cryptococcus neoformans under light microscopy. Source, ID #3771, CDC/Dr. Leaner Haley, Centers for Disease Control and Prevention, licensed under public domain. Further notes, Public Health Image Library, Phil, ID 3771. Cryptococcal meningitis. MRI head, with contrast, T1 weighted, axial plane, of a 58-year-old patient with monoclonal gammopathy and polycythemia vera who presented with confusion, fatigue, and auditory hallucinations for 1 week. Mild meningeal enhancement is seen, see arrows, which is suspicious for an infectious event and caused by cryptococcosis in this case. Source: Figure 1, in disseminated cryptococcal disease in a patient with monoclonal gammopathy of undetermined significance and polycythemia vera, a case report and review of the literature by Guoyar M., Ghazenfar H., Ashraf S., Gadam S., Medela A., Curious, licensed under CC by 4.0. Cryptococcosis. MRI head, with contrast, axial plane, a small contrast-enhancing lesion, indicated by arrow, resulting from cryptococcosis is visible in the right basal ganglia. In unspecific findings like this one, an inflammatory etiology should be considered as a differential on the basis of contrast enhancement and localization. Source: Figure 3, in disseminated cryptococcal disease in a patient with monoclonal gammopathy of undetermined significance and polycythemia vera, a case report and review of the literature by Guoyar M., Ghazenfar H., Ashraf S., Gadam S., Medela A., Curious, licensed under CC by 4.0. Meningitis, 6/10. Overlay. Cryptococcal meningoencephalitis VV. Photomicrograph of a murine brain autopsy specimen, H&E stain, high magnification, Cryptococcus neoformans, green overlay, can be seen invading the meninges, blue overlay, and the brain parenchyma, light pink tissue. Numerous neutrophils can be seen in the meninges, indicating inflammation. These findings are characteristic of cryptococcal meningoencephalitis. Created by Drmed Michael Misen. Euromeningitis, 7/10. Tick bite trademark. The body of a partially burrowed tick is visible. Copyright Embellished. Meningitis, 8/10. Tick VV. Copyright Embellished. Meningitis, 9/10. Tick after a blood meal VV. This image shows a female deer or black-legged tick, Ixodes scapularis, with an enlarged body following a blood meal. The tick's mouth parts, which it uses to suck blood, are clearly visible. The tick cuts the skin using its 2 chelicerae and inserts its hypostome into the wound. The deer tick is mainly found in the northeastern and upper Midwestern U.S. It is one of the various tick species that transmit Lyme disease and tick-borne meningoencephalitis. Source: ID # 15993, CDC/Dr. Gary Alpert, Urban Pests, Integrated Pest Management, IPM, Centers for Disease Control and Prevention CDC, licensed under public domain. Euromeningitis, 10/10. Naegleria fowleri VV. Photomicrographs of Naegleria fowleri specimens obtained from cerebrospinal fluid, CSF, samples A, multiple trophozoites in azenic, pure, culture B, trophozoite stage, Guiamsa stain, C, flagellate stage, Guiamsa stain, copyright Embellished. This image was adapted from the image figure 2 in primary amoebic meningoencephalitis related to groundwater in Costa Rica, diagnostic confirmation of 3 cases and environmental investigation by Lisette Rotana Morera, Lydia Zamora Rojas, Muriel Grijalba Murillo, Silvia Elena Molina Castro. Elizabeth Abraham Sandy, MDPI Open Access Journals, Pathogens, licensed under CC by 4.0. Meningitis, 1/3. Purpura VV. Bluish-red, round, or oval maculae, approximate 0.2 mm 1 cm in diameter, are distributed over the right lower leg. There is also an irregularly shaped macula of the same color lateral to the patella, approximate 4x 2 cm in diameter. This appearance is characteristic of purpura. Source: Copyright IMPP. Purpura in Waterhouse-Friderichsen syndrome. Purple non-blanching macules of various sizes, consistent with purpura, larger macules, and petechiae, smaller macules, is visible. These findings are consistent with purpura in Waterhouse-Friderichsen syndrome. Source: Copyright IMPP. Skin hemorrhages in Waterhouse-Friderichsen syndrome VV. There are multiple small, non-blinking purple macules on the upper thigh, medial aspect of the knee, and anterior lower leg. This appearance is consistent with purpura due to Waterhouse-Friderichsen syndrome. Source: Copyright IMPP. 4. Botulism. Botulism is a life-threatening condition of neuroparalysis that is caused by a potent neurotoxin produced by the spore-forming bacteria Clostridium botulinum. Botulinum toxin blocks the release of acetylcholine from presynaptic axon terminals into the synaptic cleft, irreversibly inhibiting neurotransmission. There are 3 main types of botulism: foodborne botulism, infant botulism, and wound botulism. Foodborne botulism results from the ingestion of a food product already contaminated with botulinum toxin, typically home-canned foods. Infant botulism represents the majority of cases and is caused by the ingestion of spores, commonly from honey or soil, which then germinate and produce neurotoxins within the intestinal tract. In wound botulism, which typically occurs in 4 drug users, see botulinum spores germinate in contaminated wounds. All 3 types present with neuroparalysis, while foodborne and infant botulism are sometimes also associated with gastrointestinal symptoms. Example: discomfort, nausea, constipation. Clinical suspicion of botulism may be confirmed by quickly identifying the toxin in bodily fluids, example serum, vomit, gastric acid, stool, and/or food. Foodborne botulism is best treated with an antitoxin and medically induced bowel emptying. Treatment of infant botulism consists of the administration of botulism immune globulin. Wound botulism requires surgical debridement in addition to antitoxin administration. ZO. FO, QO. Overview. Pathogen. Scent: Clostridium botulinum. Copyright gram-positive rod. Copyright spore-forming. Copyright obligate anaerobe. Copyright produces heat. Label: neurotoxin. Pathophysiology. Scent: botulinum toxin, protease that cleaves snare proteins and prevents fusion of transmitter-containing vesicles with the presynaptic membrane. Inhibition of Phi, acetylcholine release from the presynaptic axon terminals. Clinical features. Scent: neurological symptoms. O. Descending paralysis equals peripheral flaccid muscle paralysis that descends caudally, typically begins in frequently used muscles, equals pupils, accommodation paralysis, mydriasis, diplopia equals pharynx, dysarthria, dysphagia. Copyright autonomic nervous system, xerostomia. O. Infantile hypotonia, see infant botulism below. Scent: gastrointestinal symptoms. Copyright gastrointestinal discomfort, nausea, and vomiting, later followed by constipation. Copyright only present in 30% of cases of foodborne botulism, absent in wound botulism. Copyright constipation is often the first symptom of infant botulism. And 4 Ds of botulism: dysarthria, diplopia, dysphagia, and dyspnea. Diagnostics. Scent: rapidly identify botulinum toxin in samples from serum, vomit, gastric acid, stool, or suspicious foods. Scent: pathological EMG findings in affected muscles support the diagnosis. 2. Treatment. Scent: secure airways. See the corresponding sections for specific treatment measures. Therapeutic/cosmetic botulinum toxin use. Local injection of botulinum toxin A, Botox, can be used to treat various conditions, including EO muscle spasms, E focal dystonia, E hyperhidrosis, V back collapse. Fine text outline. Also used to reduce facial wrinkles. References IL4. OS. OX. Foodborne botulism. Etiology O. Ingestion of preformed botulinum toxin via contaminated foods. The anaerobic spores survive in poorly pasteurized canned foods, example vegetables with soil contact, meat, home fermented tofu. 5. Germination of the spores produces dangerous toxins, botulinum toxins equals enterotoxins AF, and gas bulging cans. Scent incubation period, 12 to 36 hours. Scent specific treatment. O. Horse-derived heptavalent botulism antitoxin. Copyright eradication of toxin through bowel emptying, induced by medication. Scent prevention. Copyright sterilize food through autoclaving. Copyright food should be boiled twice before being canned to kill spores that may have germinated after the first round of boiling. E.t. References 4. Gvio. At shared. Infant botulism. Etiology, ingestion of spores. O. Spores may be present in honey, juice, and contaminated soil. O. Germination of the spores in intestinal tract. Synthesis of botulinum toxin. Scent incubation period, days to 4 weeks. Clinical features, infants may present with infantile hypotonia. Copyright ptosis. O. Floppy movements. O. General weakness. Copyright poor feeding, weak sucking. Scent differential diagnosis. Differential diagnosis of infantile hypotonia. 1. Condition etiology. Clinical features. Management. Constipation, can be a presenting sign. Descending palsy, usually starts with ptosis. Spores of Clostridium botulinum, found in soil or contaminated. Palsy, YP, hone, poor feeding, weak sucking. Respiratory compromise. Supportive care for human botulism. Immune globulin. Infant botulism. Monitoring in neonatal ICU. Respiratory support. Acetylcholinesterase inhibitors in severe cases, plasmapheresis, 4-IgG. Hypotonia. Poor sucking. Respiratory distress. Neonatal transfer of acetylcholine receptor antibodies from a mother with myasthenia gravis. Myasthenia gravis. Symmetrical LMN palsy, more prominent in lower extremities. Supportive care. Spinal muscular asterisk defect in the SMN1 gene on chromosome 5q causing abnormal SMN_atrophy and fasciculations throughout the body. Nusinersen atrophy type 1 complex formation with subsequent death of anterior motor neurons, typically prominent in the tongue. Scent risdiplam. Scent weak cry and cough asterisk onasemnogena biparvivec. Respiratory failure. AZNOL 8 degrees 2. POOE88 Ceresis asterisk supportive care. ILN, intellectual disability. B. Scent for adult presentation, C. myotonic dystrophy. Asterisk characteristic facies, hypertelorism, epicanthal __ folds, broad and flat nasal bridge, small mouth, scent meiotic non-disjunction resulting in trisomy 21 hyoetonla asterisk supportive care. Trisomy 21 asterisk translocation. Trisomy 21 EAP asterisk management of gastrointestinal and Z equals a congenital heart defects. Asterisk mitotic non-disjunction resulting in trisomy 21, cardiovascular anomalies. Duodenal atresia. Delayed intellectual and motor development. Asterisk specific treatment. For human botulism. Immune globulin, Big 4, scent prevention, avoid exposure of V. Back collapse. Fine text outline. X. Botulism. Monitoring in neonatal ICU. Respiratory support. Acetylcholinesterase inhibitors. Hypotonia. Poor sucking. Respiratory distress. Neonatal transfer of acetylcholine receptor antibodies from a mother with myasthenia gravis. Myasthenia gravis in severe cases, plasmapheresis, 4-IgG. Symmetrical LMN palsy, more prominent in lower extremities. Supportive care. Spinal muscular asterisk defect in the SMN1 gene on chromosome 5q causing abnormal SMN__ atrophy and fasciculations throughout the body. Nusinersen atrophy type 1 complex formation with subsequent death of anterior motor neurons, typically prominent in the tongue. Sent risdiplom weak cry and cough asterisk onasemnogena biparvivec respiratory failure. Hypotonia, especially affecting the face CTG trinucleotide repeat expansion in the DMPK gene associated with cataracts, arrhythmias, and myotonic dystrophy equals, autosomal dominant, almost exclusively maternal inheritance, U sent supportive care type 1 intellectual disability B sent for adult presentation, C myotonic dystrophy. Sent characteristic facies, hypertelorism, epicanthal underscore equals. Folds, broad and flat nasal bridge, small mouth, asterisk meiotic non-disjunction resulting in trisomy 21 FWBGT on IS sent supportive care translocation trisomy 21 asterisk management of gastrointestinal and isomies. M asterisk congenital heart defects 99 mitotic non-disjunction resulting in trisomy 21 degree cardiovascular anomalies duodenal atresia delayed intellectual and motor development. Plus specific treatment, for human botulism immune globulin, Big 4, prevention, avoid exposure of. Add, a stool sample should be obtained for culture and toxin testing, because serum studies in infants often yield false negative results. 7. 6. Treatment should not be delayed if there is a high clinical suspicion of infant botulism. 8. References for L. Fay, IEEE. Wound botulism. Scent etiology, germinating spores in contaminated wounds, most common among 4 drug users, incubation period, 10 days, ranges from 4 to 14 days, scent specific treatment. Copyright administration of horse-derived botulism antitoxin. Copyright surgical debridement. Copyright antibiotics are only used to treat secondary bacterial infections. Scent prevention. EO government-sponsored sterile needle and syringe programs. Copyright avoidance of for drug use. OE seek medical attention for infected wounds. OAO. Differential diagnoses. Scent Guillain-Barré syndrome, myasthenia gravis, Scent Lambert-Eaton syndrome, Scent tick paralysis. References to. The differential diagnoses listed here are not exhaustive. NV. Back collapse. Find text outline. Botulism, 1/2. Clostridium botulinum VV. Photomicrograph of Clostridium botulinum, crystal violet stain, high magnification. Clostridium botulinum bacteria, rod-shaped, and endospores, smaller oval shapes, are visible. Source, #2107, Centers for Disease Control and Prevention, CDC, licensed under public domain. Urobotulism, 2/2. Action %EE potential WA1, vesicle containing, //AP /APWSY/ACHOOUYV. VA4J /YYY4, equals E, $FI SAM, Y synap V snare %7, FA /O and VA at E, I totag mind a /4 equals /I /we I /FF /light /degree, endo and cent BD // at E, chair KJ, chain DX face cytosis exocytosis recycling and in 5 OI or, J no fusion JVCA. A.YY /24YW6 IIJ /AG, degree X Q JWYWF equals E, YAYJW of asterisk co VFUILF /X, 1A/IA, OD 29% /WY, GT FA WW cent SS, smiley face, /3AAZEE. Degree snare complex way I. Nat degree E copyright equals Fay Air. NA asterisk E, AC degree F equals I, NEYP 4 cents 4G copyright 9 degrees 9 cent 920. EPSP 1 RP2. Mechanism of action, Botulinum toxin. Left image, physiological neuromuscular transmission at the motor end plate. Action potential reaches the motor end plate. SNARE protein complex facilitates the fusion of vesicles containing acetylcholine, ACH, with the prejunctional membrane. Release of ACH into the synaptic cleft. Reversible binding of ACH with ACH receptors on the postjunctional membrane. Opening of the ion channels of ACH receptors. Depolarization of the muscle. Acetylcholinesterase present on the postjunctional membrane breaks down ACH and releases it into the neuromuscular junction cleft. Choline is taken up by the choline transporter on the prejunctional membrane and recycled in ACH synthesis. Right image, cleavage of SNARE proteins by botulinum toxin. Botulinum toxin is endocytosed by cholinergic axon terminals, depicted in the left image. The light chain of botulinum toxin released into the prejunctional neuron cleaves the SNARE protein complex. Failure of fusion of vesicles containing ACH with the presynaptic membrane. ACH is not released into the neuromuscular junction. Neural impulse is not transmitted to the muscle. Flaccid paralysis of the muscle. Urobotulism, 1/1. Infant botulism VV. This child's ptosis and flaccid facial muscles are characteristic of infant botulism. Source, ID #16681, Dr. V.R. Dowell, Jr., Centers for Disease Control and Prevention, CDC, licensed under public domain. X. Poliomyelitis. Poliomyelitis, or polio, is a disease caused by poliovirus, a type of human enterovirus. Poliovirus spreads via fecal-oral transmission. Although the majority of poliovirus infections are asymptomatic, some may invade the central nervous system, leading to motor neuron death and irreversible paralysis that can cause respiratory insufficiency and death. Symptomatic poliomyelitis most commonly manifests as a flu-like illness. In rare cases, patients develop paralytic poliomyelitis, which manifests with weakness, decreased muscle tone, and hyporeflexia. The diagnosis is established based on polymerase chain reaction, PCR, findings of poliovirus RNA in body fluid samples, example stool, oropharyngeal swab, cerebrospinal fluid. Poliomyelitis has been eradicated in most parts of the world as a result of global vaccination. Initiatives. The treatment of poliomyelitis is mainly supportive. Patients with brainstem or respiratory muscle involvement may require intubation and mechanical ventilation. The majority of patients with paralytic poliomyelitis do not regain their full strength after recovery. Some patients go on to develop post-polio syndrome, which is characterized by progressive disability and muscle weakness decades after the initial infection. OOOE. Epidemiology. As a result of widespread vaccination measures, poliomyelitis has largely been eradicated in most countries worldwide. Poliovirus is still endemic in Afghanistan and Pakistan. 2. Epidemiological data refers to the U.S., unless otherwise specified. WA and etiology. Causative agent. Scent poliovirus is an RNA virus in the family Picornaviridae, genus Enterovirus. Scent wild poliovirus type 1 causes most paralytic manifestations of poliomyelitis. 2. Vaccine-derived poliovirus type 2, VDPV2 oral polio vaccine, OPV, replicates in a recently vaccinated person. Viral reversion to neurovirulence. Poliomyelitis in unvaccinated or immunocompromised individuals exposed to the recently vaccinated person. 1E humans are the only hosts. Route of transmission. 21. Scent fecal-oral, absorption of poliovirus in the intestinal tract. Scent droplet, rare, incubation time *7 to 14 days. 5. Risk factors for poliovirus infection. 4E traveling to endemic regions. Scent working with polioviruses specimens, example laboratory workers, researchers. Scent caring for individuals likely to be infected with poliovirus, example healthcare personnel, refugee camp workers, Underimmunized and/or immunosuppressed individuals. 5. Copyright working or living in endemic regions. Copyright in close contact with international children receiving the oral poliovirus vaccine, example international adoptees, refugees. Dash. Ooko, Seuss. Pathophysiology. Scent. The virus replicates in the gastrointestinal tract, oropharynx and small intestine. Following oral ingestion enters the bloodstream. Potential invasion of the gray matter of the spinal cord, particularly the lower motor neurons of the anterior horn, myelitis. DS. V. Back collapse. Fine text outline. Clinical features. Over 72% of infections with poliovirus are asymptomatic. Clinical infection, mostly flu-like symptoms, is observed in less than 24% of cases, and less than 1% of infected individuals develop paralysis. The clinical forms of poliomyelitis are SI6L. Poliomyelitis without CNS involvement, abortive poliomyelitis. Nonspecific symptoms: gastroenteritis, fever, nausea, sore throat, myalgia, and headaches for 1 to 3 days. Scent. Complete recovery without complications or transition to poliomyelitis with CNS involvement. Poliomyelitis with CNS involvement. Non-paralytic poliomyelitis, aseptic meningitic form. Begins several days following abortive poliomyelitis, often temporary, symptom-free interval, fever, neck stiffness, headache, vomiting, muscle pain, neck muscle weakness, head drop sign, head falls back when placed in a supine position, no paresis. Paralytic poliomyelitis occurs 2 to 3 days following the meningitic form after a brief symptom-free interval. Fever, malaise, headache, nausea, severe back, neck, and muscle pain. Asymmetric acute flaccid paralysis worsens over hours to days. EO most commonly affects the leg muscles, although the arms, abdomen, trunk, thorax, and eyes may be affected. Copyright paralysis is usually more severe in proximal muscles than in distal muscles. Ascending paralysis with diaphragmatic involvement. Respiratory failure. Bulbar form with brainstem involvement, rare damage to the cerebral or autonomic nerve centers, cranial nerves and respiratory center. Central respiratory paralysis. Diminished deep tendon reflexes, muscle atrophy, hypotonia, fasciculations. OOE. Subtypes and variants. Post-polio syndrome, PPS, 71. Copyright most frequent complication observed following poliovirus infection, up to 40% of survivors. Copyright occurs decades after infection. Copyright manifests with progressive muscle weakness and pain, even in areas that were not affected by the initial infection. OOFO, CO. Diagnostics. The initial test, PCR of stool or oropharyngeal samples to test for enterovirus. 9. Sent confirmatory test, PCR of CSF, stool or oropharyngeal samples to test for poliovirus or NA8. Sent CSF will show copyright by protein levels, nucleocytosis with either neutrophils, early infection, or lymphocytes, late infection, or normal glucose levels. W1 and differential diagnoses. Sent other viral infections. Other enteroviruses may also cause flaccid paralysis. Sent Guillain-Barré syndrome. Paralysis is typically symmetrical in Guillain-Barré syndrome. In addition, it would not manifest in CSF pleocytosis. Acute intermittent porphyria may also present with muscle weakness and bulbar paralysis. Sent spinal muscular atrophy. Paralysis is typically symmetrical. The differential diagnoses listed here are not exhaustive. B. Back collapse. Fine text outline. The differential diagnoses listed here are not exhaustive. Low your notes at shared notes. Treatment. Scent pain relief, scent airway management and mechanical ventilation if needed. Example signs of airway compromise, respiratory failure, * close monitoring of blood pressure and respiratory function. Function. WA your notes. 4 shared notes. Prognosis. The prognosis is dependent on the form of poliomyelitis. In the abortive and non-paralytic forms, complete recovery without complications occurs within 2 weeks. Sent in the paralytic form, the most serious short-term risk is death due to diaphragmatic involvement. After recovery, most patients have residual deficits, including muscle weakness or contractures and muscle pain. Sent post-polio syndrome may lead to muscle weakness and pain decades after polio infection. So shared notes. Prevention. Vaccination 0111112. Vaccine, 13. Asterisk the inactivated poliovirus vaccine, IPV, is used in the United States and is administered subcutaneously or intramuscularly. The IPV may be administered alone or in combination with other vaccines, such as OTTAP, OTDAP, OTDDTAP, IPV/HIV, copyright DTAP, IPV HEP. 1 ODTAP IPVJ copyright DTAP IPV HIV have sent the live attenuated oral polio vaccine. OPVO has not been used in the US since 2000 because of the slightly increased risk of vaccine-associated paralytic polio is still used in resource-limited countries' immunization schedule. The inactivated vaccine is recommended for all individuals. See the ACIP immunization schedule for details. Sent individuals with risk factors for poliovirus infection may require additional doses of vaccination. For more details, see 12.4I5-degree immunization schedule by medical indication copyright vaccines before travel. Tips and links. Sources. Last updated June 29, 2023 7. Back collapse fine text outline. Poliomyelitis 1/1. Diseases of the fore, anterior horn, posterior spinal arteries / surprised face /E/D, spinal muscular atrophy, polio / A, central cord syndrome, example due to syringomyelia. E. Amyotrophic lateral sclerosis. B. Anterior cord syndrome, example due to anterior spinal artery occlusion, anterior spinal artery. At dorsal column / F, tabs dorsalis at, anterior horn of the spinal cord / due to syphilis, at, lateral horn of the spinal cord. Copyright, posterior horn of the spinal cord, dorsal root copyright anterior white comies shore at, pyramidal tract spinocerebellar tract. C. Posterior cord syndrome, example due to posterior, spinal artery occlusion, A. Registered /G, vitamin bis deficiency, example due to atrophic gastritis. Spinal cord lesions BD. Cross-sectional representation of spinal cord neuroanatomy and different regional lesions, purple. A. Central cord syndrome, bilateral paresis B, anterior cord syndrome, bilateral motor paralysis, loss of pain and temperature sensation, and autonomic dysfunction C, posterior cord syndrome, ipsilateral loss of proprioception, vibration, and touch sensation D, spinal muscular atrophy, polio, progressive bilateral paresis E, amyotrophic lateral sclerosis, progressive bilateral paresis F, tabs dorsalis, progressive bilateral loss of proprioception, vibration, and touch sensation G. Vitamin B deficiency, loss of proprioception, vibration, and touch sensation, ataxia, and persistent paresthesia. Copyright Embellished. Legend. Recommended range of recommended vaccination recommended no recommended vaccination based on ages for recommendations / ages for all 00 can begin in shared clinical, for catch up certain high, not applicable children this age group decision vaccination risk groups group making. Birth to 15 months. These recommendations must be read with the notes that follow. For those who fall behind or start late, Provide catch-up vaccination at the earliest opportunity as indicated by the green bars. To determine minimum intervals between doses, see the catch-up schedule, Table 2. Vaccine and other 1912 immunizing agents for MO2 MOS 4 MOS 6 MOS 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 15 MOS. Respiratory syncytial virus at 1 dose depending on maternal RSV 1 dose, 8 through 19, RSV MAB vaccination status, see notes months, see notes near Sevimab. Hepatitis B at IE HER, Hep B, dose. Rotavirus Rotav, RV, G at AST on GRV1, 2 dose series, dose RV5, 3 dose series, _. Diphtheria, tetanus, and acellular pertussis 1 2nd 3rd, DTaP. Haemophilus pu 4 st 2nd C plus 3 or 4 dose, influenza type B at, dose notes see notes, HIB, _. Pneumococcal 4 st 2nd 3rd conjugate at dose sedone. PCV 15, PCV 20. Inactivated poliovirus equals at 0 dose. COVID-19 at 1 or more doses of updated, 2023, 1 VCOV mRNA, 2024 formula, vaccine. COVID-19 at 1 or more doses of updated, 2023, 1 VCOV mRNA, 2024 formula, vaccine 1 VCOV APS, see notes. Influenza, IIV4, at annual vaccination 1 or 2 doses at Influenza, LAIV4, at measles, mumps, rubella at see notes, MMR. Varicella at, VAR. Hepatitis A at tetanus, diphtheria, and acellular pertussis rayi, Tdap, 27 YRS. Human papillomavirus at, HPV. Meningococcal at, Menacwi CRM 22 MOS, Menacwi TT 22 years. See notes. Meningococcal B at, Men B4C, Men B FHBP. Virus vaccine at, RSV Abrysvo. Dengue at, Denacid, 9 to 16 YRS. Mpox at 18 months to 18 years. 18 months to 18 years. Respiratory syncytial virus at, RSV MAB near Sevimab. Hepatitis B at, Hep B. Rotavirus at, RV1, 2 dose series, RV5, 3 dose series. Diphtheria, tetanus, and acellular pertussis at, DTaP. Haemophilus influenza type Hep at, HIB. Pneumococcal conjugate at, PCV 15, PCV 20. Inactivated poliovirus at, IPV. COVID-12 1 or more doses of updated, 2023 to 2024 formula, vaccine, 1 VCOV mRNA, 1 VCOV L, see notes, APS. Influenza, IIV4, at annual vaccination 1 or 2 doses annual vaccination 1 dose only. Influenza, LAIV4, at measles, mumps, rubella at, MMR. Varicella at, VAR. Hepatitis A at, HEPA. Copyright 00000000000000008 Copyright 00 Copyright 0000000 Orf EC Re Tetanus, diphtheria, and acellular pertussis at, Tdap, 27 YRS. X25CDE.gov. CDE.gov. Vaccine and other immunizing agents. Human papillomavirus 0, HPV. Meningococcal at, Menacwi CRM22 MOS, Menacwi TT 22 years. Meningococcal B at, Men B4C, Men FHBP. Respiratory syncytial virus vaccine at, RSV Abrisvo. Dengue at seropositive in endemic, Den 4 SID, 9 to 16 YRS, dengue areas, see notes, Mpox at. To make vaccination recommendations, healthcare providers should. X26CDE.gov. Birth 18 years immunization schedule, by medical condition CDC. Recommendations for ages 18 years or younger, United States, 2024. Print. Euro Back to Child and Adolescent Immunization Schedule homepage. Vaccines and other immunizing agents in the Child VA Get Email Updates Immunization Schedule. Download the How to Use the Schedule. To make vaccination recommendations, healthcare providers should print the schedule, color. 1. Determine recommended vaccine by age, Table 1, by age, print the schedule, black and white. 2. Determine recommended interval for catch-up vaccination, Table 2, catch-up. 3. Assess need for additional recommended vaccines by medical condition or other indication, Table 3, by medical indication. Download the mobile app. 4. Review vaccine types, frequencies, intervals, and compliant version of the schedule. Considerations for special situations, notes. 5. Review contraindications and precautions for vaccine types, Appendix. 6. Review new or updated ACIP guidance, Addendum. Legend. Not recommended. Recommended J for all age. Precaution, recommended for all children, eligible children. Might be A for all age but is and additional indicated if contraindicated. Eligible children. Recommended doses may be benefit of or not an benefit who lack for some necessary. Recommended protection. Guidance / not documentation. Children based 9 based on * vaccinate after outweighs applicable of a complete on increased medical risk of pregnancy, if vaccination risk for or condition or indicated. Adverse series severe other RR reaction outcomes from indications. See disease notes. Always use this table in conjunction with Table 1 and the notes that follow. Medical conditions are often not TE-IC in all RAL CAE. Not recommended for all. Precaution, recommended for all children, but is age-eligible children, and might be contraindicated or age-eligible children. _= recommended for some FJ. Additional doses may be indicated if not recommended. No who lack, children based on necessary based on benefit of * vaccinate after guidance / not documentation of a increased risk for or medical condition or protection. Pregnancy, if applicable. Complete vaccination AE, severe outcomes from other indications. See outweighs risk of indicated series. Disease notes. Adverse reaction. Always use this table in conjunction with Table 1 and the notes that follow. Medical conditions are often not mutually exclusive. If multiple conditions are present, refer to guidance in all relevant columns. See notes for medical conditions not listed. Kidney HIV infection CD4 failure. Percentage and count. Endosplenia or stage CSF leak. Persistent renal immunocompromised or complement heart disease chronic vaccine and other status, excluding HIV. RSV mAb at second RSV. Nirsevimab, season for one dose depending on maternal chronic maternal RSV vaccination status, see notes status, see notes lung Disease. See notes. Hepatitis B at rotavirus at A. Percentage and count registered asplenia or stage CSF leak persistent renal immunocompromised or complement heart disease chronic vaccine and other status, excluding HIV. DTAP/TDAP at DTAP. DAP QOSE Euro D pregnant. HIV Euro a C notes pneumococcal at ITV. COVID-19 at C notes. Asthma, LAIV4 at wheezing, 2 to 4 years. Measles, mumps, rubella, RF, vaccine and other immunizing agents pregnancy. Immunocompromised status, excluding HIV infection. Percentage and count, equals 15% and 200/ml. CSF leak or cochlear implant. Implant. Asplenia or persistent complement component deficiencies. End-stage renal heart disease chronic or on liver lung disease dialysis disease diabetes. Hepatitis A at human papillomavirus at meningococcal. ACWY at previous vaccines, see the General Best Practice Guidelines for Immunization, Altered Immunocompetence, and Table 4:1, footnote J. B. Severe combined immunodeficiency. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age, Table 1, by age, 4. Review vaccine types, frequencies, intervals, and considerations 2. Determine recommended interval for catch-up vaccination for special situations, notes, Table 2, catch-up, 5. Review contraindications and precautions for vaccine types 3. Assess need for additional recommended vaccines by medical, appendix, condition or other indication, Table 3, by medical indication, 6. Review new or updated ACIP guidance, addendum. Recommended by the Advisory Committee on Immunization Practices, ACIP, and approved by the Centers for Disease Control and Prevention, CDC, American Academy of Pediatrics, AAP4, American Academy of Family Physicians, AAFP4, American College of Obstetricians and Gynecologists, ACOG4, American College of Nurse Midwives, ACNM4, American Academy of Physician Associates, AAPA%, and National Association of Pediatric Nurse Practitioners, NAPNAP 4%. The comprehensive summary of the ACIP recommended changes made to the child and adolescent immunization schedule can be found in the January 11, 2024 MMWR report. Suspected cases of reportable vaccine-preventable diseases or outbreaks to your state or local health department ** clinically significant adverse events to the Vaccine Adverse Event Reporting System, VAERS, at www.vaers.hhs.gov or 800-822-7967. Questions or comments, contact www.cdc.gov/cdc-info or 800-CDC-INFO, 800-232-4636, in English or Spanish, 8 a.m. to 8 p.m. Eastern Time, Monday through Friday, excluding holidays. Helpful information. Complete Advisory Committee on Immunization Practices, ACIP, Recommendations. ACIP shared clinical decision-making recommendations sent general best practice guidelines for immunization, including contraindications and precautions, vaccine information statements =VE C. Ars Pari \VA. Phi 1. Recommended catch-up immunization schedule for children and adolescents who start late or who are more than 1 month behind. United States, 2024. Print Euro back to child and adolescent immunization schedule homepage. Vaccines and other immunizing agents in the child immunization schedule IZA get email updates. How to use the schedule. Download the schedule to make vaccination recommendations. Healthcare providers should see and I bets IEEE 1. Determine recommended vaccine by age, Table 1, by age, print the schedule, black and white 2. Determine recommended interval for catch-up vaccination, Table 2, catch-up, 3. Assess need for additional recommended vaccines by medical condition or other. Download the mobile app. Indication, Table 3, by medical indication, 4. Review vaccine types, frequencies, intervals, and considerations for special situations, Notes, 5. Review contraindications and precautions for vaccine types, Appendix, 6. Review new or updated ACIP guidance, Addendum. Vaccine Catch-up Guidance S. CDC has developed catch-up guidance job aids to assist healthcare providers in interpreting Table 2 in the child and adolescent immunization schedule. Children age 4 months through 6 years. The table below provides catch-up schedules and minimum intervals between doses for children whose vaccinations have been delayed. A vaccine series does not need to be restarted, regardless of the time that has elapsed between doses. Use the section appropriate for the child's age. Always use this table in conjunction with Table 1 and the notes that follow. Hepatitis B at birth 4 weeks, 8 weeks and at least 16 weeks after first dose. Minimum age for the final dose is 24 weeks. Rotavirus at 6 weeks, maximum 4 weeks. 4 weeks age for first dose is maximum age for 14 weeks, 6 days. Final dose is 8 months, 0 days. Diphtheria, 6 weeks, 4 weeks, 4 weeks, 6 months, 6 months. Tetanus, and a 5th dose is not. Diphtheria, 6 weeks, 4 weeks, 4 weeks, 6 months, 6 months. Tetanus, and a 5th dose is not acellular necessary if the pertussis at 4th dose was administered at age 4 years or older and at least 6 months after dose 3. Haemophilus 6 weeks, no further doses, no further doses 8 weeks, as final influenza needed dose, type Hep at if first dose was if previous dose was _ this dose only administered at age necessary for 15 months or older. 4 weeks if first dose was administered before the 1-degree birthday. 8 weeks, as final dose, if first dose was administered at age 12 through 14 months. 15 months or older. 4 weeks if current age is younger than 12 months and first dose was administered at younger than age 7 months and at least one previous dose was PRPT, ACT HIV registered, Pentacel registered, Hybrix registered, Vaxillus registered, or unknown. Children age 12 through 59 months who received 3 doses before the 1-degree birthday. 8 weeks and age 12 through 59 months, as final dose, if current age is younger than 12 months and first dose was administered at age 7 through 11 months, or if current age is 12 through 59 months and first dose was administered before the 1% birthday, and second dose was administered at younger than 15 months, or if both doses were PEDVAX HIV registered and were administered before the 1* birthday. Pneumococcal conjugate at 6 weeks, no further doses needed for healthy children if first dose was administered at age 24 months or older. 4 weeks if first dose administered before the 15th birthday. 8 weeks, as final dose for healthy children, if first dose was administered at the 15th birthday or after. No further doses needed for healthy children if previous dose was administered at age 24 months or older. 4 weeks if current age is younger than 12 months and previous dose given at 8 weeks, as final dose. This dose is only necessary for children age 12 through 59 months regardless of risk, or age 60 through 71 months with any risk, who received 3 doses before age 12 months. Inactivated 6 weeks 4 weeks 4 weeks 6 months poliovirus at if current age is measles, 12 months 4 weeks mumps, rubella at varicella at 12 months 3 months, hepatitis A at 12 months 6 months, meningococcal 2 months 8 weeks. See notes ACWY at menacYCRM 2 years men ACWYTT. Children and adolescents age 7 through 18 years. Tetanus, 7 years 4 weeks 6 months. Diphtheria, if first dose of DTaP/DT if first dose of DTaP/DT. Tetanus, was administered before diphtheria, and the 1 degree birthday acellular 6 months, as final dose. Pertussis at if first dose of DTaP/DT or Tdap/TD was administered at or after the 1 degree birthday. Human 9 years routine dosing intervals are recommended. Papillomavirus at hepatitis A at N/A 6 months. Hepatitis B at N/A 4 weeks 8 weeks and at least 16 weeks after first dose. Inactivated N/A 4 weeks 6 months. A fourth dose of IPV is poliovirus at a fourth dose is not indicated if all previous necessary if the third dose was administered at age 4 years or older and at least 6 months after the doses were administered at inactivated N/A 4 weeks 6 months. A fourth dose of IPV is poliovirus at a fourth dose is not indicated if all previous necessary if the third doses were administered was administered at age 4 at measles, N/A 4 weeks mumps, rubella SI. Varicella at N/A 3 months if younger than age 13 years. 4 weeks if age 13 years or older. Dengue at 9 years 6 months. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age, Table 1, by age. 2. Determine recommended interval for catch-up vaccination, Table 2, catch-up. 3. Assess need for additional recommended vaccines by medical. 4. Review vaccine types, frequencies, intervals, and considerations for special situations, notes. 5. Review contraindications and precautions for vaccine types, appendix. Adult immunization schedule by age, addendum updated February 29, 2024. Recommendations for ages 19 years or older, United States, 2024 print Euro back to adult immunization schedule homepage. Vaccines in the adult immunization schedule. How to use the schedule to make vaccination recommendations. Healthcare providers should 1. Determine recommended vaccine by age, Table 1, by age. 2. Assess need for additional recommended vaccinations by medical condition or other indication, Table 2, by medical condition. 3. Review vaccine types, dosing frequencies and intervals, and considerations for special situations, notes. 4. Review contraindications and precautions for vaccine types, appendix. 5. Review new or updated ACIP guidance, addendum. XA get email updates. Download the schedule, print the schedule, color BB print the schedule, black and white download the mobile app. Compliant version of the schedule. Legend. Recommended vaccination for recommended vaccination for recommended vaccination no recommendation / not adults who meet age adults with an additional risk based on shared clinical applicable requirement, lack factor or another indication decision-making documentation of vaccination, or lack evidence of immunity. COVID-19 at influenza inactivated, IIV4, or influenza recombinant, RIV4, at influenza live attenuated, LAIV4, at respiratory syncytial virus, RSV, at tetanus, diphtheria, pertussis. Tetanus, diphtheria, pertussis, Tdap or TD, At 1 dose Tdap, then Td or Tdap booster every 10 years. Measles, mumps, rubella, MMR, at. For healthcare personnel, see notes. 1 or 2 doses depending on indication, if born in 1957 or later. Varicella, VAR, at 2 doses, if born in 1980 or later. Zoster recombinant, RZV, at. Human papillomavirus, HPV, at 2 or 3 doses depending on age at initial vaccination or condition 27 through 45 years. Pneumococcal, PCV15, PCV20, PPSV23, SI. See notes. See notes. Hepatitis A, HEPA, at. Hepatitis B, Hep B, at 2, 3, or 4 doses depending on vaccine or. Meningococcal A, C, W, Y, MEN-ACWY, at. Meningococcal B, MEN-B, at. Haemophilus influenza type B, HIB, at. Mpox at. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age, Table 1, by age, 3. Review vaccine types, frequencies, intervals, and considerations 2. Assess need for additional recommended vaccinations by for special situations, notes, medical condition or other indication, Table 2, by medical 4. Review contraindications and precautions for vaccine types condition, Appendix 5. Review new or updated ACIP guidance, Addendum. This schedule is recommended by the Advisory Committee on Immunization Practices, ACIP, and approved by the Centers for Disease Control and Prevention, CDC, American College of Physicians, ACP, 4, American Academy of Family Physicians, AAFP 4, American College of Obstetricians and Gynecologists, ACOG 4, American College of Nurse Midwives, ACNM 4, American Academy of Physician Associates, AAPA 4, American Pharmacists Association, APHA 4, and Society for Healthcare. Epidemiology of America, Shea%. The comprehensive summary of the ACIP recommended changes made to the adult immunization schedule can be found in the January 11, 2024 MMWR. Adult Immunization Schedule by Medical Conditio. Indication. Recommendations for ages 19 years or older, United States, 2024. Print. Euro back to Adult Immunization Schedule homepage. Vaccines in the Adult Immunization Schedule. How to use the schedule download to make vaccination recommendations. Healthcare providers should print the SCHE1. Determine recommended vaccine by age, Table 1, by age, print the SCHE2. Assess need for additional recommended vaccinations by medical condition or other indication, Table 2, by medical condition, download the 3. Review vaccine types, dosing frequencies and intervals, and considerations for special situations, notes, 4. Review contraindications and precautions for vaccine types, Appendix, compliant versi. Recommended for all adults who lack documentation of vaccination, or lack evidence of immunity. Not recommended for all adults, but recommended for some adults based on either age or increased risk for or severe outcomes from disease. Recommended based on shared clinical decision-making. Recommended for all adults, and additional doses may be necessary based on medical condition or other indications. See notes. Precaution might be indicated if benefit of protection outweighs risk of adverse reaction. A 55, 9. Contraindicated or not recommended. No * vaccinate after pregnancy, if indicated. Guidance / not applicable. Always use this table in conjunction with Table 1 and the notes that follow. Medical conditions or indications are often not mutually exclusive. If multiple medical conditions or indications are present, refer to guidance in all relevant columns. See notes for medical conditions or indications not listed. Kidney HIV infection CD4WS percentage and count end-stage immunorenal chronic compromised men who asplenia, heart disease liver, excluding. COVID-19 at see notes. 144 at or RIV for 1 dose annually. 1 dose LAIV4 at annually if age 1 dose annually if age 19-49 years 19 to 49 years. Kidney HIV infection CD4 His percentage and count end-stage renal chronic compromised men who asplenia, heart disease liver, excluding. RSV at seasonal administration. See notes see notes see notes. Tdap or TD at Tdap, 1 dose each 1 dose Tdap, then TD or Tdap booster every 10 YRS pregnancy. MMR at 1 or 2 doses depending on indication. VAR at see notes. RZV at see notes. HPV at 3 dose series if indicated. Pneumococcal at. HEPA at. Hep B at age equals see notes. A precaution for LAIV4 does not apply to alcoholism. B see notes for influenza, hepatitis B, measles, mumps, and rubella, and varicella vaccinations. See hematopoietic stem cell transplant. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age, Table 1, by age, 4. Review contraindications and precautions for vaccine types 2. Assess need for additional recommended vaccinations by medical, appendix, condition or other indication, Table 2, by medical condition, 5. Review new or updated ACIP guidance, Addendum. X. Tetanus. Tetanus, lockjaw, is an acute disease caused by neurotoxins from the bacterium Clostridium tetani. C. tetany is ubiquitous in spore form and enters the body through broken skin, example deep puncture wounds. Its toxins then cause uncontrolled activation of alpha motor neurons, leading to muscular rigidity and spasms. Patients classically present with a triad of trismus, rhesus sardonicus, and episthetanus. Tetanus is a clinical diagnosis, but diagnostic testing may help confirm the diagnosis. Treatment includes airway management, wound debridement, immunoglobulin therapy, example human tetanus immune globulin, antibiotics, example metronidazole, and pharmacological management of severe muscle spasms. Prevention of tetanus involves routine immunization with tetanus vaccines and administering post-exposure prophylaxis for wounds. YA. Etiology. Pathogen copyright Clostridium tetani, a gram-positive, obligate anaerobic, spore-forming rod O produces neurotoxins tetanospasmin and tetanolizin O ubiquitous, especially animal feces and soil, scent route of infection copyright Clostridial spores contaminate a wound, example through dirt, saliva, feces. Copyright localized ischemia, necrosis, foreign bodies, and / or co-infection with other bacteria predisposed to infection. EO wounds with compromised blood supply create anaerobic conditions that are required for the germination and multiplication of C. tetani. Equals deep, penetrating wounds, example knife, gunshot, animal bites, equals open fractures equals surgical procedures, example bowel, biliary tract, or dental surgery, equals burns umbilical stump infections equals septic abortion scent groups with a higher risk, non-immunized individuals, those with diabetes, neonates, people who inject drugs, PWID, certain patient groups, i.e., post-surgical, obstetric, dental. OS2. Pathophysiology. Ubiquitous C. tetani spores contaminate a wound. Bacterial reproduction under anaerobic conditions. Production of the neurotoxins tetanospasmin and tetanolizin. Scent tetanospasmin reaches the CNS through retrograde axonal transport. Copyright toxin binds to receptors of peripheral nerves and is then transported to interneurons, Renshaw cells, in the CNS via vesicles. 1. 2. O acts as protease that cleave synaptobrevin, a snare protein. Prevention of inhibitory neurotransmitters, i.e., GABA and glycin, release from Renshaw cells in the spinal cord. Uninhibited activation of alpha motor neurons. Muscle spasms, rigidity, and autonomic instability. Scent tetanolizin causes hemolysis and has cardiotoxic effects. QB neurotoxins, not the pathogen itself, cause tetanic contractions. And tetanospasmin causes tetanic spasms. OES. Clinical features. Scent incubation period, 3 to 21 days, average, 10 days, scent generalized tetanus, painful muscle spasms and rigidity, copyright trismus, lockjaw due to spasms of jaw musculature, commonly the first tetanus-specific symptom, orissus sardonicus, sustained facial muscle spasm that causes a characteristic, apparently sardonic grin and raised eyebrows. Copyright episthetanus, backward arching of spine, neck, and head caused by spasms of the back muscles, copyright neck stiffness. Abdominal rigidity. 1. Scent life threatening complications. Laryngospasm and or respiratory muscle spasms. Respiratory failure. 3. Copyright autonomic dysfunction, circulatory arrest and shock. 3. 1. Back collapse. Fine text outline. Subtypes and variants. Neonatal tetanus. Scent occurs in infants of inadequately immunized mothers after unsterile management of the umbilical stump. Scent typically occurs 5 to 8 days after birth, but the incubation period can take up to several weeks. Scent typically a rapid onset of symptoms as axonal length in infants is shorter than in adults. 4. Symptoms. Copyright difficulty opening the mouth and feeding due to trismus and rhesus sardonicus. Muscle stiffness and episthetanus. Copyright clenched hands. Other types. 5. Plus localized tetanus, patients present with painful muscle contractions in areas surrounding the injury site only. Scent cephalic tetanus. Copyright in patients with open head or neck injuries. Copyright initially only affects cranial nerves, especially flaccid paralysis of CN7, which can be mistaken for stroke. OOE. Diagnostics. Scent tetanus is a clinical diagnosis based on muscle spasms and rigidity associated with an entry point for bacteria and inadequate immunization. Scent wound culture and serology may confirm the diagnosis but have low sensitivity and specificity. Z*OES. Treatment/ILS-IL-21L10. The following relates to the treatment of clinically apparent tetanus. C. Tetanus prophylaxis after injury for preventing tetanus in individuals with acute wounds. Approach 7 IS 910. Immediately manage life-threatening and severe symptoms, see acute stabilization. Administer passive immunization, example human tetanus immunoglobulin, as soon as possible. Manage acute wounds, example wound irrigation and debridement. Initiate antibiotics, preferably metronidazole. Scent begin active immunization with the tetanus vaccine once the patient is improving. At wound care and antibiotics decrease bacterial load and toxin production. Immunoglobulin therapy neutralizes free toxins. 3-9. Acute stabilization /7 ISII 9110. Scent laryngospasm or respiratory muscle spasms, airway management. 13 severe muscle spasms, benzodiazepines and or paralytics, potentially in combination with mechanical ventilation, S13 antibiotics, 7 IL8 I9 Li10. Scent preferred, metronidazole. Scent alternative, penicillin G immunization, 7 I8 I91 L10. Plus passive immunization, immunoglobulin therapy. Copyright 17 First line, I am human tetanus immunoglobulin, HTIG, OHTIG unavailable, consider intravenous immunoglobulin. Sent active immunization, tetanus vaccine. OGOS. Prevention. Tetanus vaccine, 171I18. Routine immunization is recommended for all individuals. Tetanus. Acute stabilization 7IL8I91I10. Plus laryngospasm or respiratory muscle spasms, airway management, 5 severe muscle spasms, benzodiazepines and or paralytics, potentially in combination with mechanical ventilation, A13 antibiotics, 7I8291I101. Scent preferred, metronidazole scent alternative, penicillin G immunization, 7I is I91L10. Plus passive immunization, immunoglobulin therapy, 1L70 first line, I am human tetanus immunoglobulin, HTIG, EHTIG unavailable, consider intravenous immunoglobulin. Sent active immunization, tetanus vaccine. WA. OE. Prevention. Tetanus vaccine, 171I18. Routine immunization is recommended for all individuals. Active component, denatured tetanus toxin plus available vaccines. Copyright children. Copyright boosters with TD or Tdap are recommended every 10 years for all adolescents and adults who have completed the primary Tdap and DTAP series. See ACIP immunization schedule for details, 180-120L21. Copyright acellular pertussis containing vaccines are contraindicated in patients who previously developed unexplained encephalopathy within a week after receiving a 19 acellular pertussis vaccine, i.e., DTAP or Tdap. Tetanus prophylaxis after injury, degree LLA 27122. Management is based on copyright tetanus vaccine history o wound assessment copyright immune status, example immunocompromised state, HIV infection, 9 cent tetanus prone wounds include, copyright dirty wounds copyright deep injuries 1 copyright thermal injuries. PBP 9LF822 tetanus vaccine history clean and minor wounds tetanus prone wounds sent in separate sites, administer both, unknown or sent last tetanus vaccine. Administer HTIG to patients with severe immunodeficiency or HIV infection and a tetanus-prone wound regardless of tetanus vaccine history. 9. Back collapse fine text outline. Tetanus, 1/3. 7. Rhesus sardonicus in tetanus. Sustained spasm of the facial muscles has resulted in trismus and the characteristic grinning appearance. Source, ID, 2857, CDC/Dr. Thomas F. Sellers, Centers for Disease Control and Prevention licensed under public domain. Tetanus, 2/3. Rhesus sardonicus, sardonic laughter, in tetanus VV. Photograph showing the characteristic facial muscle spasm of tetanus, with the appearance of a distorted grin and raised eyebrows. Source, ID #, 1657, CDC/Armed Forces Institute of Pathology, AFIP/C Farmer, Centers for Disease Control and Prevention, Atlanta, USA licensed under public domain. Opisthotonus VV. This young patient shows hyperextension of his head, neck, and back, hyperlordosis, a position which is referred to as opisthotonus. Opisthotonus is characteristic of lockjaw, tetanus. Source, ID #, 6373, CDC, Centers for Disease Control and Prevention, CDC, licensed under public domain. Rabies. Rabies is a neurotropic virus contracted from the bite of an infected animal. The virus enters the patient's skin from the saliva of the animal and migrates along the peripheral nerves to the central nervous system, CNS. An incubation period of 4 to 12 weeks typically precedes the clinical appearance of the disease, which manifests with a prodrome of nonspecific flu-like symptoms, followed by acute rabies encephalitis. Clinical findings include fever, hydrophobia, hypersalivation, and stupor alternating with mania. Coma and eventually death due to respiratory and circulatory collapse ensue. A minority of rabies cases are paralytic rather than encephalitic, presenting with ascending paralysis similar to that of Guillain-Barré syndrome and culminating in cardiac and respiratory arrest. With adequate post-exposure prophylaxis, PEP, i.e., with rabies immunoglobulin plus rabies vaccine, and wound care following a rabid animal bite, rabies infection is preventable. No curative treatment is available once the signs and symptoms of rabies have appeared, and the disease is almost always fatal. Pre-exposure prophylaxis with the rabies vaccine is recommended for individuals traveling to areas where the virus is widespread, as well as for those with jobs that predispose them to infection, example veterinarians. OS. FE, CES. Epidemiology. Scent found in animal reservoirs in most countries throughout the world. Scent considerable divide between developed and developing countries in terms of human death due to rabies. Copyright incidence worldwide, up to 70,000 people die of rabies each year. One copyright incidence in the US, 3 people on average die of rabies each year. Epidemiological data refers to the US, unless otherwise specified. OSYOE. Etiology. Pathogen. Copyright rabies is caused by several different members of the Rhabdoviridae family. O. Rhabdoviruses are rod or bullet-shaped. O. genus, Lyssavirus. OSS. RNA scent transmission. O. most common animal reservoir worldwide, dogs. EO. most common animal reservoirs in the US, bats, raccoons, skunks, and foxes. O. spread through saliva of rabid animal after bite injury. O. via aerosols, example bat caves, rare. References to Y. Pathophysiology. Rabies virus binds the ACH receptor of peripheral nerves in the bite wound, migrates retrogradely along the axonal microtubules, using motor protein dynein, enters the CNS equals infects the brain. Copyright diencephalon, hippocampus, and brainstem are involved. First copyright causes acute, progressive, and fatal encephalitis. Encephalitic rabies. Copyright in References 3. Back collapse. Find text outline. Clinical years. General. Scent incubation period, 4 to 12 weeks. Average scent prodromal symptoms. Copyright flu-like symptoms, example fever, malaise. Copyright locally, pain, paresthesia, and pruritus near the bite site. Encephalitic rabies, most common type. Scent hydrophobia. Rabies patients experience involuntary, painful pharyngeal muscle spasms when trying to drink. Later on in the disease, the sight of water alone may provoke nausea or vomiting. 1. CNS symptoms. O. anxiety, agitation, and combativeness alternating with calm periods. Copyright confusion and hallucinations. O. photophobia. Copyright fasciculations. Degree seizures. OT muscle tone and reflexes with nuchal rigidity. Autonomic symptoms, example hypersalivation, hyperhidrosis, coma and death within days to weeks of the development of neurological symptoms, paralytic rabies. Flaccid paralysis, gradually ascending and spreading from bite wound. 4. Scent paraplegia and loss of sphincter tone, respiratory failure and death. And the pathognomonic feature of rabies is hydrophobia due to pharyngeal muscle spasm. This may present along with agitation, strange behavior, mental status changes, and possibly foaming at the mouth. References, SLL, 71I8. OO Cernoi. A2 shared no manage. Diagnostics. In the case of a bite injury from a suspicious animal, see PEP algorithm in treatment below. Ante-mortem diagnosis. Several tests using multiple specimens must be performed to diagnose rabies because individual tests have limited sensitivity. Evidence of the virus can only be obtained after disease onset. Plus 4 specimens are required for testing: serum, saliva, CSF, and skin. 9 laboratory tests ORT-PCR to detect rabies, RNA copyright cell culture to isolate the virus, copyright fluorescent antibody testing, FAD, to detect viral antigen in a smear or frozen section of a biopsy. Antibody testing, indirect fluorescent antibody test, equals serum antibodies detected in individuals who are not immunized and did not receive post-exposure prophylactic immunoglobulins indicate the diagnosis equals rising serum. Antibody levels over several days in immunized patients are suggestive of rabies infection equals antibodies in the CSF regardless of the immunization history are indicative of rabies infection. Additional tests OCSF testing, findings characteristic of encephalitis. 1 postmortem diagnosis. Scent postmortem brain tissue autopsy, copyright immunofluorescent staining of viral antigen in infected CNS tissue. Degree histopathological findings, Negri bodies, eosinophilic cytoplasmic inclusion bodies typically found in the cerebellum and hippocampus. Back collapse, fine text outline. Rabies risk assessment. See also animal bites. Administer PEP bite by a known wild reservoir for rabies, example bats, raccoons, skunks, foxes, if the animal is not available for testing or if the test comes back positive, see bat bites. 4 bite by a domestic carnivore, example dog, not available for observation or displaying symptoms of rabies, see dog bites and cat bites. Scent observe/test animal and possibly administer PEP. Copyright attack by an unvaccinated domestic carnivore without symptoms of rabies, example dog, observe animal for a 10-day period, equals animal remains normal, PEP is not necessary equals animal starts to display symptoms of rabies equals euthanize and study brain samples of the animal equals administer PEP to patient equals PEP is stopped if test results of the animal are negative. Scent PEP is not required. Copyright bite by a vaccinated domestic carnivore. Copyright bite by an indoor domestic herbivore. Ed. =_ Rabies post-exposure prophylaxis, 1 degree LL11. Scent cleaning and debridement, as with all bite wounds. Tetanus shot and antibiotic prophylaxis may be indicated. Non-immunized patient, post-exposure prophylaxis, passive-active immunization, a rabies immunoglobulin is given into the site of the wound by injection, passive immunization, CC. Copyright plus inactivated rabies vaccine is given IM on days 0, 3, 7, and 14, active immunization, plus prior immunization, 12. Even patients who have been vaccinated against rabies should be treated after exposure. A rabies vaccine IM on days 0 and 3. Copyright no immunoglobulin. Copyright check antibody titers on day 14. Copyright treatment with PEP in suspected cases of a bite by a rabid animal should take place urgently, as the disease is fatal once it becomes symptomatic. Suspicion of rabies is sufficient indication for PEP. Symptomatic encephalitic or paralytic rabies. Plus palliative treatment, pain management and sedation. 7 and prognosis. Scent mortality, symptomatic rabies is almost always fatal. Rabies is preventable following exposure to a rabid animal with adequate PEP, see treatment section above. Rabies is almost always fatal once the symptoms have appeared. References 3. OOOE. Prevention. Vaccination, pre-exposure prophylaxis. Rabies vaccine, inactivated, killed, vaccine scent indications. Copyright people with frequent occupational contact with potentially rabid animals. Copyright travelers to regions in which rabies is widespread, especially if PEP may not be readily available. See vaccines before travel for immunization schedule. Obligation to report. Rabies is a nationally notifiable disease according to the CDC. Back collapse, find text outline. J. Rabies, 1/1. Rabies virus. AE. Incubation per lot. Transmission, bites from infected animals, mostly dogs. Typically 3 to 8 weeks, occasionally years. Clinical features. 1. Unspecific prodromal period agitation, hydrophobia, muscle cramps, autonomic instability. 2b. Paralytic rabies, flaccid paralysis. Annual incidence 59,000 cases worldwide. Annual mortality rate 59,000 cases worldwide. Immunization of wild and domestic animals, pre-exposure immunization prevention, post-exposure prophylaxis. No treatment available. Nets, virtually always fatal cases of rabies per 100,000 population. IBNE. Rabies fact sheet and mortality map. HBS 090038-0.19a, BB 15 to 30 _0.0024-0.038 FH 06-15. The high mortality rate of rabies in developing countries is attributed to a lack of vaccination programs for animals and post-exposure prophylaxis being unaffordable or unavailable. Copyright Emboss. Map based on Hampson et al., estimating the global burden of endemic canine rabies. In PLOS Neglected Tropical Diseases. 9, 2015, doi 10.1371/journal.pntd.00037009. Rabid dog. This dog is salivating and there is froth at its mouth because infection with the rabies virus causes difficulty swallowing. Other symptoms in animals include abnormal behavior, nervousness, weight loss, paralysis, and epileptic seizures. Source: ID #2626, CDC, Centers for Disease Control and Prevention, licensed under public domain. Overlay. Ganglion cell with Negri bodies VV. Photomicrograph of autopsy specimen of brain tissue, H&E stain, Negri bodies, examples indicated by green arrows, are eosinophilic intracytoplasmic inclusion bodies present within the cell bodies and axons of neurons infected by the rabies virus. Although the presence of Negri bodies is pathognomonic of rabies, their absence does not rule out infection. Source: Copyright IMPP. Rabies, 2/3. G. Overlay. Negri bodies in a neuron VV. Photomicrograph of brain tissue, H&E stain, high magnification, a pyramidal cell, green overlay, is visible in the center of the image. The distinct eosinophilic intracytoplasmic inclusions within the pyramidal cells are Negri bodies, examples indicated by black arrowheads and white dashed outlines. Negri bodies are most commonly found within the pyramidal cells of hippocampus and the Purkinje cells of patients infected by the rabies virus. Although the presence of Negri bodies is pathognomonic of rabies, their absence does not rule out infection. Source: ID #3377, CDC/Dr. Daniel P. Pearl, Centers for Disease Control and Prevention, licensed under public domain. Further notes: Public Health Image Library, Phil, ID 3377. Rabies, 2/3. Overlay. Negri bodies in a neuron VV. Photomicrograph of brain tissue, H&E stain, high magnification, a pyramidal cell, green overlay, is visible in the center of the image. The distinct eosinophilic intracytoplasmic inclusions within the pyramidal cells are Negri bodies, examples indicated by black arrowheads and white dashed outlines. Negri bodies are most commonly found within the pyramidal cells of hippocampus and the Purkinje cells of patients infected by the rabies virus. Although the presence of Negri bodies is pathognomonic of rabies, Their absence does not rule out infection. Source, ID hashtag 3377, CDC/Dr. Daniel P. Pearl, Centers for Disease Control and Prevention licensed under public domain. Further notes, Public Health Image Library, Phil, ID, 3377. Overlay. Rabies virus. Electron micrograph of cell with rabies virions. The rabies virions can be identified by their bullet-shaped appearance, examples indicated by green overlay. They can bud from negri bodies, which are pathognomonic inclusions within the cell, example indicated by red hatched overlay. This image is an adaptation. Source of original image, Centers for Disease Control and Prevention. Original title, ID hashtag 1876. Created by, CDC/Dr. Fred Murphy. Licensed under public domain. Modifications to original image, overlays added. Overlay. Rabies virus. Electron micrograph of cell with rabies virions. The rabies virions can be identified by their bullet-shaped appearance, examples indicated by green overlay. They can bud from negri bodies, which are pathognomonic inclusions within the cell, example indicated by red hatched overlay. This image is an adaptation. Source of original image, Centers for Disease Control and Prevention. Original title, ID hashtag 1876. Created by, CDC/Dr. Fred Murphy. Licensed under public domain. Modifications to original image, overlays added. Eurorabies, 1/1. Potential rabies exposure. Why? Wild, high-risk animal. Test available to test? Animal yes. Animal positive no. PEP. Rabies post-exposure prophylaxis. Copyright Emboss. Why? Domestic carnivore. V. Unavailable for observation. V. Symptoms of rabies within the next 10 days? Yes. Start PEP plus test. Animal stop PEP if test is negative. Why indoor domestic herbivore? U. Livestock, outdoor, domestic herbivore, other wild animal. V. Contact local health department. X. Infectious rashes in childhood. This article covers various infectious exanthems, rashes, in childhood, including measles, scarlet fever, rubella, fifth disease, roseola infantum, chickenpox, and hand, foot, and mouth DID. For more information on each specific condition, see the respective articles. Overview of infectious rashes in childhood. Overview of infectious rashes in childhood. Pathogen appearance of exanthem. Course of exanthem. Other clinical features. Asterisk prodromal stage. Scent begins on the face, frequently behind the ears. Asterisk disseminates to the rest of the. Copyright coryza, cough, and plus erythematous, maculopapular conjunctivitis. Spots are 1 to 10 mm in size, degree colic spots. Measles asterisk measles virus BRRAIAE body. SAE pent-ali confluent asterisk fades after 5 days with brown equals M stage discoloration and desquamation. Copyright high fever, malaise. A copyright generalized lymphadenopathy. Asterisk begins in the neck region. Asterisk disseminates to the head, trunk, fine, erythematous, maculopapular, sandpaper-like. Asterisk high fever with sudden C texture, and extremities. Acuum rire Rs degree onset. Asterisk blanching scent brown discoloration and G equals M, pi penis. Asterisk pastia lines, linear petechiae in desquamation of the skin during, NNY tongue of the groin, armpit, and elbow. The 2nd to 4th week of degree ancylopharyngeates creases, infection I. Scent fine, erythematous. Cis asterisk begins behind the ears. Asterisk good general condition, mild maculopapular rash, spots 2b beyond. Asterisk extends to the trunk and fever, 3 mm in size. Rubella, rubella virus blani in extremities *suboccipital and post 2 == symptoms usually disappear auricular lymphadenopathy *non-confluent medium-sized Dinesafant within 3 days *Forchheimer sign. Back collapse fine text outline. Rubella plus rubella virus. Fifth disease, erythema *parvovirus B19 infectiosum. Roseola infantum human, exanthum K subidum, LE herpes virus. Chickenpox varicella zoster, varicella, virus. Hand, foot, and Coxsackie mouth disease virus. Fine, erythematous maculopapular rash, spots 2-3 mm in size, blanching non-confluent medium-sized spots. Maculopapular initially confluent lace-like and reticular appearance over time becomes more pronounced after exposure to sunlight or heat. Erythematous, maculopapular, spots 2 to 5 mm in size, scent patchy, blanching. Vesicular rash on erythematous background starry sky, simultaneous occurrence of various stages of rash, example vesicles, crusted papules. Tender macules vesicular rash. Begins behind the ears, extends to the trunk and extremities. Symptoms usually disappear within 3 days. Slapped cheek appearance, flushed cheeks with perioral pallor can spread to extremities and trunk. Fades after 5 to 8 days, may be recurrent for several months following the initial infection. Develops as the fever subsides, originates on the trunk and may spread to the face and extremities, frequently observed from only several hours to a maximum of 3 days. Begins on trunk, scalp, face, and proximal limbs, involves hands, feet, and mucous membrane. Severe pruritus fades after 1 week. Affects feet and hands. One rarely generalizes. Fades after 4 days. Good general condition, mild fever, suboccipital and post-auricular lymphadenopathy plus Forchheimer sign. Good general condition plus arthritis. Good general condition, initial sudden high fever for 3 to 5 days, 3-day fever, Nagayama spots. Prodrome possible, 1 to 2 days prior to exanthem onset, oropharyngeal and urogenital ulcers. Poor general condition, highly contagious stomatitis and enanthem I, fever. Copyright drug reactions should always be considered as a potential cause of a rash. WA. Back. At. Last updated September 19, 2022. A. Collapse fine text. A. Outline. Measles 7. First disease, morbilli, A=Y=, AE, WFI pathogen paramyxovirus ZZ in Bari. Course / red. Improvement of exanthem with fine if ES desquamation after 4 to 5 days ASF on. Complications AEY het lal 8 palate and subacute sclerosing panencephalitis 9. NPP, SSPE, tail eyes, measles encephalitis CIE tai. Treatment symptomatic generalized A, lymphadenopathy 4 degrees / 2% DS, vaccine TENC /BW exanthem yes AKT /OLTKN, erythematous, maculopapular, UES %, UI blanching, partially confluent, IOI. /is 0% SAE. Westfed at copyright, reduced general condition incubation period 14 days OL la time /AE and high fever, biphasic, contagious 5 days VA period as, EYC3. Barking cough. Exposure onset of exanthem. Measles fact sheet VV. Copyright Boss. Overlay. Colic spots VV colic spots, which are characteristic of measles infection, are visible on the buccal mucosa. These are white necrotic lesions, dashed line, on an erythematous base. This image is an adaptation. Source of original image, Centers for Disease Control and Prevention, CDC. Original title, ID #4500. Created by, CDC. Licensed under public domain. Modifications to original image, image turned. Overlay. Colic spots VV colic spots, which are characteristic of measles infection, are visible on the buccal mucosa. These are white necrotic lesions, dashed line, on an erythematous base. This image is an adaptation. Source of original image, Centers for Disease Control and Prevention, CDC. Original title, ID #4500. Created by, CDC. Licensed under public domain. Modifications to original image, image turned. Measles rash VV. Generalized maculopapular exanthem is visible on this toddler's body. Source, Measles rash Phil, Centers for Disease Control and Prevention, Atlanta, USA, Centers for Disease Control and Prevention licensed. Under public domain. Uroinfectious rashes in childhood, 4/25. Abdominal rash in measles VV. A widespread maculopapular rash is visible across the abdomen. Source, ID #3168, CDC/Heinz F. Eichenwald, MD, Centers for Disease Control and Prevention, CDC, licensed under public domain. Infectious rashes in childhood, 5/25. Measles. A maculopapular exanthema, which is partially confluent, is visible on the trunk. In combination with the corresponding characteristic clinical features, these skin findings are suggestive of measles. Source, Measles in African Child 3, Mike Blythe, Wikimedia Commons licensed under public domain. Measles. Multiple maculopapular blanching and partially confluent patches are disseminated over the head, neck, and back of this young patient. These findings are consistent with a desquamating rash, which can occur after fading of the first erythematous exanthema, caused by an infection with the measles virus. Source, Figure 34, in Atlas of Pediatric HIV Infection by Regina E. Oladican, Raniko J. Leloania, Carol Hlila et.al., Open Books, licensed under CC by ND 4.0. Infectious rashes in childhood, 7/25. Scarlet fever second disease, scarlatina. Pathogen group A, beta hemolytic, streptococcus, exotoxins. Course after 1 to 2 days, confluence and scarlet red discoloration of exanthem after 1 to 3 weeks, fine desquamation of the trunk, peeling of the hands and feet. Complications: acute rheumatic fever post-streptococcal glomerulonephritis. Treatment: antibiotics, example penicillin. Vaccine: none. Incubation period: PMENS. Contagious period with antibiotics, without antibiotics exposure, onset of exanthem. Scarlet fever fact sheet. Copyright Emboss. Flushed face with perioral pallor. Exanthem, initially pale red, maculopapular, small spots, A/cervical i.e. lymphadenopathy RZI. Pastia lines. Enanthem of soft palate, initially white coating on tongue, strawberry tongue in further course. G. Reduced general condition. 4. High fever. Y. Abdominal pain. I. Nausea. Time. Skin manifestations in scarlet fever VV. The typical scarlet-colored, fine, maculopapular exanthem of scarlet fever is seen on the right arm. Flushed cheeks and perioral pallor are also evident. Source: Scarlet Fever by Beto Badop, Wikimedia Commons, licensed under CC by SA 3.0. Modifications: pixelated eyes. Desquamation in scarlet fever VV. Palms showing lamellar desquamation of the skin, skin glove. Desquamation typically occurs in the 2 and D4th week of the disease. The face and trunk typically show pityriaciform scales. Source: Charlach, Yasmin Feth, Wikimedia Commons licensed under public domain. Strawberry tongue. The tongue is bright red with prominent edematous papillae and a white coating. This finding is typically seen during the exanthematous phase of scarlet fever, but may also be seen in other conditions such as toxic shock syndrome or Kawasaki disease. Source: Charlach by Martin Kronewitter, Wikimedia Commons, licensed under CC by SA 2.5. Rubella third disease, German measles. Pathogen rubella virus. Coarse exanthem that resolves within 3 days. Suboccipital and postauricular lymphadenopathy. WY. Forchheimer spots complications: arthritis, encephalitis, thrombocytopenic purpura, congenital rubella syndrome. Treatment: symptomaticon, exanthem re-efe, erythematous, maculopapular, vaccine / blanching, non-confluent, yes medium-sized spots. Incubation period 14-21 days. Time copyright, good general condition, contagious Q mild F mild fever. Period exposure onset of exanthem we. Rubella fact sheet VV. Copyright Emboss. Rubella rash VV. A non-confluent, pink, maculopapular rash is visible across this infant's trunk and extremities. Source: ID #4513, CDC, Centers for Disease Control and Prevention, CDC, licensed under public domain. Rubella VV. Photograph of the abdominal wall of a child. It shows a maculopopulous medium-sized non-confluent erythematous rash in the truncal area caused by an infection with rubella. The rash usually fades after 3 days, hence it is often called 3-day measles. Source: ID #4514, CDC, Centers for Disease Control and Prevention, licensed under public domain. Pathogen YF parvovirus B19. Reddened cheeks SS coarse slap cheek rash / exanthem in only 15 to 20% of cases, infection often asymptomatic, alternating fading and recurrence possible for months. Complications: parvovirus B19 associated arthritis, exanthemoplastic crisis / initially maculopapular, confluent, hydrops fetalis S / lace-like in further course. Treatment: symptomatic. Vaccine U. None. Copyright, good general condition, incubation period 14 days / time EE mild fever, contagious period exposure onset of exanthem. Erythema infectiosum, 5th disease, fact sheet VV. Copyright Emboss. 5th disease, parvovirus B19. There are bright red cheeks, slap cheek appearance, and a diffuse, red, confluent maculopapular rash visible over the body of the 16-month-old infant. This is the characteristic cutaneous appearance of 5th disease, erythema infectiosum, caused by infection with parvovirus B19. This image is an adaptation. Source of original image, Wikimedia Commons. Original title, 5th disease. Created by Andrew Kerr. Licensed under public domain. Modifications to original image, pixelated eyes. Infectious rashes in childhood, 16/25. 5th disease. Multiple erythematous, partially confluent macules and papules extend over the upper arm in a reticular pattern. This is the typical appearance of the exanthem associated with fifth disease. Image source of original image, www.pediatry-in-builder-n.de. Created by Dr. Thomas Rotten-Strock. Infectious rashes in childhood, 1725. Roseola infantum sixth disease, exanthem subitum bulging fontanelle pathogen Y in infants. Human herpes virus 6 and 7 SSNS, HHV6, HHV7, Ziavira S, is AOUISE, edematous eyelids PNE cervical symptoms resolve within hours to maximum 3 days FOSSCCVI/. Lymphadenopathy complications, SS febrile seizures TI. Encephalitis. And treatment/symptomatic exanthem / pale red, blanching vaccine macular or maculopapular nun rash, especially on trunk. Incubation period, time contagious unknown period. Exposure onset of exanthem. Roseola infantum, sixth disease, fact sheet. Copyright Embellished. Copyright, good general condition and high fever for 3 days before onset of exanthem. 2 cough and rhinorrhea. EY abdominal pain. Infectious rashes in childhood, 1825. Exanthem subitum, Roseola infantum, VV. A 1-year-old child with a recent febrile illness who developed a non-pruritic, blanching, erythematous maculopapular rash beginning on the trunk and spreading peripherally 1 day after the fever subsided. The pictured rash and history are consistent with exanthem subitum, also known as Roseola infantum or sixth disease. This benign disease is usually caused by HHV6 and may also cause a cough, runny nose, and/or diarrhea. Source: Sestimalatia, Emiliano Berzagli, Wikimedia Commons licensed under public domain. Roseola infantum, 3-day fever, exanthem subitum, VV. This 9-month-old infant suffered from a high fever of up to 39.8 degrees Celsius 103.6 degrees Fahrenheit for 3 days. Following a sudden decrease in temperature, the infant developed a rapidly spreading, patchy, macular exanthem on the neck, behind the ears, and on the entire trunk. The rash lasted for 2 days. The names of the disease reflect its 2 phases, 3-day fever and exanthem subitum, i.e., sudden exanthem. Copyright Embellished. Chickenpox varicella is pathogen Y. Varicella zoster virus Afiana EE =OMOI =Onavio on scalp involvement course, CBEA. Widespread vesicular rash with lesions WE/T beginning as macules and rapidly becoming neuropapules. Simultaneous occurrence of various rash stages. Calvenink said, involvement remission of exanthem after 8 days. Complications SOX-AE bacterial superinfection/Lee SOX, 0009 meningitis, acute cerebellar ataxia, encephalitis/ith herpes zoster, shingles, from virus reactivation exanthem congenital varicella syndrome, vesicles, some filled with opaque fluid, and crusted lesions, treatment FHN /symptomatic. Vaccine yes. Slightly reduced general condition incubation period 10-21 days. TNE mild fever contagious, period severe pruritus. Exposure onset of exanthem by a headache, muscle, and joint pain. Chickenpox fact sheet VV. Copyright Embellished. Infectious rashes in childhood, 21/25, A. AES 4 Physite. AES. The chickenpox, varicella, upper body of a young boy with exanthem showing the simultaneous occurrence of various stages of rash, mainly vesicles and pustules, no crusted erosions. This clinical finding is also referred to as starry sky and is typical of chickenpox. Source: Varicella aranzales, Camilorenzales, Wikimedia Commons licensed under public domain. Infectious rashes in childhood, 22/25. Facial rash in chickenpox VV. The face of the girl shows macules, vesicles, and papules on an erythematous base, as well as erupted vesicles and crusted papules. The simultaneous occurrence of various stages of rash is sometimes described as starry sky and is typical of chickenpox. Source: ID #10486, CDC/Dr. John Noble, Jr., Centers for Disease Control and Prevention, CDC, licensed under public domain. Hand, foot, and mouth disease VV. Hands and feet of a 36-year-old male patient. Maculopapular lesions are visible on the inner surface of the hands and feet. The localization in conjunction with the enanthem of the mucous membranes is typical of hand, foot, and mouth disease. The characteristic vesicles are not frequently formed in adulthood. Source: Hand-foot-mouth disease adult 36 years by Klatchmanacker, Wikimedia Commons, licensed under CC by SA 3.0. Skin lesions in hand, foot, and mouth disease VV. 12-month-old infant. Typical white-gray blisters with a diameter of approximate 3 to 5 mm surrounded by an erythematous halo are seen on the fingers, top images. Another common finding, as seen here, is a disseminated maculopapular rash on the upper and lower legs, bottom left. In addition, there is a partially crusted papulovesicular rash in the perioral region, bottom right. However, the eponymous involvement of the mouth refers to the typically painful aphthous enanthem of the oral mucosa, which is not shown here. Copyright Embellished. Infectious rashes in childhood, 25/25. Measles, scarlet fever, rubella, erythema infectiosum, roseola, varicella, German measles, 5th disease, 6th disease, chicken pox. Classic pediatric exanthem diseases VV. Many infectious diseases in children present with a rash, exanthem. The distribution and morphological characteristics of the exanthem allow the diseases to be differentiated from one another. Measles, patients present with a dark red, erythematous, maculopapular, partially confluent exanthem, which spreads from behind the ears to the rest of the body. Scarlet fever, patients present with a fine, light red, maculopapular rash. The exanthem begins on the neck and disseminates to the whole body. The patient's face may be red with perioral sparring. After 1 to 2 days, the exanthem becomes scarlet-colored, and partially confluent. The rash is most pronounced in the axilla and groin. Non-blinking petechiae, pastia lines, may be present. Rubella, German measles, patients typically present with a non-confluent, pink, maculopapular exanthem, which, like measles, extends from behind the ears to the rest of the body. XP. Measles, scarlet fever, rubella, erythema infectiosum, roseola, varicella, German measles, 5th disease, 6th disease, chicken pox. Classic pediatric exanthem diseases VV. Erythema infectiosum, 5th disease, a confluent, maculopapular rash appears only in % of patients. It may take on a lace-like, reticular appearance over time. Additionally, patients present with diffuse redness of the face with perioral sparring, slapped cheek rash. Roseola infantum, 6th disease, 3 days of high fever are followed by a sudden decrease in temperature and development of a patchy, rose-pink, macular exanthem. The rash originates on the trunk and neck, and may spread to the face and extremities in some cases. Varicella, chickenpox. The exanthem affects the whole body, typically spreading to the scalp as well. Various stages of the rash occur simultaneously, which leads to the characteristic clinical finding known as starry sky. Copyright Embellished. X. Rubella. Rubella, or German measles, is an infectious disease that is caused by the rubella virus. Since the introduction of the measles, mumps, and rubella, MMR, vaccine, it is a relatively rare condition. Rubella is transmitted via airborne droplets and has a mild clinical course. The clinical presentation begins with nonspecific flu-like symptoms and postauricular and/or suboccipital lymphadenopathy. An exanthem phase may overlap or follow. This phase is characterized by a rash that typically starts behind the ears and progresses distally, developing into a generalized maculopapular rash. Rubella is usually self-limiting and involves symptomatic treatment. Complications of infection during pregnancy may cause congenital rubella syndrome with severe malformations, example hearing loss, cataracts, heart defects, intellectual disabilities. The rubella vaccine is a combination vaccine that protects against measles, mumps, and rubella. MMR vaccine. The MMRV vaccine also protects against varicella. Immunization is recommended for all children, in addition to adults without evidence of immunity to measles, mumps, and/or rubella. WA and epidemiology. Plus rare disease in the U.S. following the implementation of the MMR vaccine. Risk factors. See risk factors for measles, mumps, and/or rubella. Epidemiological data refers to the U.S., unless otherwise specified. WA CE Etiology. Pathogen O. rubella virus, an RNA virus of the family Matinaviridae. Copyright prior to 2019, the rubella virus was classified as the sole member of the rubivirus genus in the Togaviridae family. 1O humans are the only hosts. Scent route of transmission O. respiratory droplets or transplacental. Copyright infectivity, 7 days prior to and 7 days following the appearance of an exanthem. 1 Copyright low infectivity and virulence. OS OSOR. Clinical features. Patients with rubella infection are asymptomatic in 50% of cases. Young children have a far milder course than older children and adults. The latter group often presents with prodromal symptoms, other systemic complaints, example arthritis, and a longer duration of infection. Prodromal phase. Incubation period, 2 to 3 weeks after infection. Scent duration, 1 to 5 days. Findings O. postauricular and suboccipital lymphadenopathy and occasionally splenomegaly. Copyright mild and nonspecific symptoms such as low-grade fever, mild sore throat, cough, conjunctivitis, headache, and aching joints. O. Forchheimer sign, enanthem of the soft palate exanthem phase. Scent duration, lasts 2 to 3 days. Scent findings O. fine, non-confluent, pink maculopapular rash. Ha equals begins at the head, primarily behind the ears, extends to the trunk and extremities, sparing palms, and solace equals rash may be itchy in adults. Degree polyarthritis. I equals WA. Back collapse. Fine text outline. Diagnostics. Although rubella infection may be considered a clinical diagnosis, laboratory confirmation is necessary for certain patient groups to assess the risk of complications such as example congenital rubella in pregnant women or encephalitis. Plus laboratory tests 21.3 Copyright CBC, leukocytopenia with relative lymphocytosis and increased plasma cells. Copyright confirmatory test, serology equals detection of IgM antibodies, 4-fold increase in IgG titer for prenatal and congenital diagnosis. See congenital rubella syndrome. VAFO, QO. Differential diagnoses. Scent differential diagnoses of pediatric rashes. The differential diagnoses listed here are not exhaustive. WAU. AE shared I. Treatment. Symptomatic treatment. Copyright severe pruritus, antihistamines O. severe polyarthritis, rest and nonsteroidal anti-inflammatory drugs for treatment of congenital rubella syndrome and seronegative women following exposure to rubella virus, see congenital rubella syndrome. Isolate patients with confirmed infection. 4. All individuals, isolate for 7 days from the onset of rash. Copyright hospitalized patients, initiate droplet precautions. Rubella is a nationally notifiable disease, report all cases to the appropriate health departments. 5. Complications. Chronic arthritis, especially women, thrombocytopenic purpura rubella during pregnancy, torch infection congenital rubella syndrome rare, rubella encephalitis, bronchitis, otitis, myocarditis, pericarditis. We list the most important complications. The selection is not exhaustive. LDO SOR. Prognosis. The disease usually has a benign course and the exanthem disappears rapidly. Joint pain may persist for several weeks, arthralgia may persist up to a month in adults. Back collapse. Fine text outline. Complications. Chronic arthritis, especially women, thrombocytopenic purpura rubella during pregnancy, torch infection congenital rubella syndrome rare, rubella encephalitis, bronchitis, otitis, myocarditis, pericarditis. We list the most important complications. The selection is not exhaustive. CE. Prognosis. The disease usually has a benign course and the exanthem disappears rapidly. Joint pain may persist for several weeks, arthralgia may persist up to a month in adults. 21C, shared note, not. Prevention. Vaccination L728. Administer a live attenuated rubella vaccine, i.e., MMR vaccine, MMRV vaccine, according to the ACIP immunization schedule. See the following: immunizations for measles, mumps, and rubella. ACIP immunization schedule *, contraindications to live vaccines, example pregnancy, immunocompromise. Evidence of immunity to rubella, 91L101C. Indications to test for immunity to rubella and evidence of immunity to measles, mumps, and/or rubella. If laboratory evidence of immunity to rubella is required, perform serologic testing. OT, copyright IgG measurement by enzyme immunoassay is preferred. Copyright a rubella IgG titer 10 IU/ml indicates immunity to rubella. 91 exposure control /4LL11 for confirmed cases of rubella, patients, isolate for 7 days from the onset of rash to prevent further transmission. Exposed contacts without evidence of immunity to measles, mumps, and/or rubella, quarantine for 23 days from the onset of rash in the last known exposure. 11146, women of reproductive age without evidence of immunity to rubella should be vaccinated prior to pregnancy to prevent congenital rubella syndrome. 12. OOES. Tips and links. Sources last updated May 31, 2023. X26cdce.gov. Child and adolescent immunization schedule by age. Recommendations for ages 18 years or younger, United States, 2024. Print. Vaccines and other immunizing agents in the child immunization schedule. WA get email updates. How to use the schedule. Download the schedule to make vaccination recommendations. Healthcare providers should print the schedule. Color 1. Determine recommended vaccine by age, Table 1, by age, print the schedule, black and white. 2. Determine recommended interval for catch-up vaccination, Table 2, catch-up. 3. Assess need for additional recommended vaccines by medical condition or other. Download the mobile app. Indication, Table 3, by medical indication. 4. Review vaccine types, frequencies, intervals, and considerations for special situations, notes, compliant version of the Schedule 5. Review contraindications and precautions for vaccine types, Appendix 6. Review new or updated ACIP guidance, Addendum. Legend. Range of 5 recommended recommended OE no recommended ages copyright OE. Vaccination based on recommended ages for certain high risk vaccination can begin shared clinical decision recommendation / A for all children for catch up ropes G in this age group make in not applicable vaccination Bruic G. Birth to 15 months. These recommendations must be read with the notes that follow. For those who fall behind or start late, provide catch-up vaccination at the earliest opportunity as indicated by the green bars. To determine minimum intervals between doses, see the catch-up schedule, Table 2. Vaccine and other immunizing agents birth 1 MO 2 MOs 4 MOs 6 MOs 9 MOs. Respiratory syncytial virus at 1 dose depending on maternal RSV vaccination, RSV-MAB nirsevimab, status, see notes. Hepatitis B hepatitis 15T dose, Hep B. Rotavirus, RV, at ANSRV1, 2-dose series, RV5, 3-dose first dose 2-dose note series. Diphtheria, tetanus, and acellular pertussis at first dose 2 trademark 4-dose 3 cent dose, DTAP. IPV. Vaccine and other immunizing equals AAFH agents birth 1 MO 2 MOs 4 MOs 6 MOs 9 MOs 12 MOs 15 MOs. Haemophilus influenza type B at C. Pneumococcal conjugate at VOS 1% * dose 24 dose 3 dose, PCV 15, PCV 20. Inactivated poliovirus at P15 dose 2 trademark 4 dose. COVID-19 at 1 VCOV mRNA, 1 VCOV APS, 1 or more doses of updated, 2023 to 2024 formula, vaccine, see notes. Influenza, IIV4, at annual vaccination 1 or 2 doses. Influenza, LAIV4, at measles, mumps, rubella at B no or E ants, MMR, dash. Varicella at Pat Doi, VAR. Hepatitis A at. Vaccine and other immunizing agents birth 1 MO 2 MOs 4 MOs 6 MOs. 9 MOs 12 MOs 15 MOs tetanus, diphtheria, and acellular pertussis at, Tdap, equals 7 YRS, human papillomavirus at, HPV, meningococcal at, menacY-CRM 22 MOs, see notes menacY-TT 22 years, meningococcal B at, MEN-B4C, MEN-FHBP, respiratory syncytial virus vaccine, RSV Abrysvo, dengue at, Den4 SID, 9 to 16 YRS, Mpox at 18 months to 18 years rare. Respiratory syncytial virus at, RSV-MAB nirsevimab. Hepatitis B at, Hep B. Rotavirus at, RV, RV1, 2-dose series, RV5, 3-dose series. Diphtheria, tetanus, and acellular pertussis at, DTAP. Haemophilus influenza type B at, HIB. Pneumococcal conjugate at, PCV 15, PCV 20. Inactivated poliovirus at, IPV. Dose. COVID-19 at, 1 VCOV mRNA, 1 VCOV APS. 1 or more doses of updated, 2023 to 2024 formula, vaccine, see notes. Influenza, IIV4, at annual vaccination 1 or 2 doses annual vaccination 1 dose only. At 008 copyright 000000088808 copyright 08G at registered copyright MDOM or ES. Annual vaccination 1 or annual vaccination 1 dose only 2 doses influenza, LAIV4, at measles, mumps, rubella at MMR, varicella at VAR, hepatitis A at HEPA, tetanus, diphtheria, and acellular pertussis at Tdap equals 7 YRS. Human papillomavirus at HPV. Meningococcal at Menacwi CRM 22 MOS, Menacwi TT 22 years. Meningococcal B at MEN-B4C, MEN-FHBP. Respiratory syncytial virus vaccine at RSV Abrysvo. Dengue at Denacid, 9 to 16 YRS. Mpox at. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age, Table 1, by age, 2. Determine recommended interval for catch-up vaccination, Table 2, catch-up, 3. Assess need for additional recommended vaccines by medical condition or other indication, Table 3, by medical indication. 4. Review vaccine types, frequencies, intervals, and considerations for special situations, Notes, 5. Review contraindications and precautions for vaccine types, Appendix, 6. Review new or updated ACIP guidance, Addendum. X26cdce.gov recommended catch-up immunization schedule for children and adolescents who start late or who are more than 1 month behind. United States, 2024. Print Euro back to child and adolescent immunization schedule homepage. Vaccines and other immunizing agents in the child immunization schedule. We get email updates. How to use the schedule. Download the schedule to make vaccination recommendations. Healthcare providers should, Pint Phi Okatuli, Coker 1. Determine recommended vaccine by age, Table 1, by age, print the schedule, black and white 2. Determine recommended interval for catch-up vaccination, Table 2, catch-up, 3. Assess need for additional recommended vaccines by medical condition or other. Download the mobile app indication, Table 3, by medical indication, 4. Review vaccine types, frequencies, intervals, and considerations for special situations, Notes, 5. Review contraindications and precautions for vaccine types, Appendix, 6. Review new or updated ACIP guidance, Addendum. Children age 4 months through 6 years. The table below provides catch-up schedules and minimum intervals between doses for children whose vaccinations have been delayed. A vaccine series does not need to be restarted, regardless of the time that has elapsed between doses. Use the section appropriate for the child's age. Always use this table in conjunction with Table 1 and the notes that follow. Minimum interval between doses. Minimum age for vaccine: dose 1 to dose 2 to dose 3 to dose 4 to dose 5. Hepatitis B at birth 4 weeks 8 weeks and at least 16 weeks after first dose. Minimum age for the final dose is 24 weeks. Rotavirus at 6 weeks, maximum 4 weeks. 4 weeks age for first dose is maximum age for 14 weeks, 6 days. Final dose is 8 months, 0 days. Diphtheria, 6 weeks 4 weeks 4 weeks 6 months 6 months. Tetanus, and a 5th dose is not acellular necessary if the pertussis at 4th dose was administered at age 4 years or older and at least 6 months after. 22 pounds, dose 3 2 pounds, 2 pounds. LT. Vaccine. Haemophilus influenza type Hep at. Minimum age for dose 1. 6 weeks. Dose 1 to dose 2. No further doses needed if first dose was administered at age 15 months or older. 4 weeks if first dose was administered before the 1-degree birthday. 8 weeks, as final dose, if first dose was administered at age 12 through 14 months. Minimum interval between doses. Dose 2 to dose 3. No further doses needed if previous dose was administered at age 15 months or older, 4 weeks if current age is younger than 12 months and first dose was administered at younger than age 7 months and at least one previous dose was PRPT, ACT-HIV registered, Pentacyl registered, Hybrix registered, Vaxilis registered, or unknown 8 weeks and age 12 through 59 months, as final dose, if current age is younger than 12 months and first dose was administered at age 7 through 11. Dose 3 to dose 4. 8 weeks, as final dose, this dose only necessary for children aged 12 through 59 months who received 3 doses before the 1-degree birthday. Dose 4 to dose 5. Vaccine minimum age for dose 1 to dose 2. Minimum interval between doses. Dose 2 to dose 3. Months, or if current age is 12 through 59 months and first dose was administered before the 1-degree birthday, and second dose was administered at younger than 15 months, or if both doses were PEDVAX HIV registered and were administered before the 1* birthday. Dose 3 to dose 4 to dose 5. Conjugate at. If first dose longer than 12 months with any pneumococcal 6 weeks, no further doses needed for healthy children if first dose was administered at age 24 months or older, 4 weeks. No further doses needed for healthy children if previous dose was administered at age 24 months or older, 4 weeks if current age is 8 weeks, as final dose. This dose is only necessary for children aged 12 through 59 months regardless of risk, or age 60 through 71. Vaccine. Conjugate at pneumococcal. Minimum age for dose 1. 6 weeks. Dose 1 to dose 2. No further doses needed for healthy children if first dose was administered at age 24 months or older, 4 weeks if first dose administered before the 1% birthday, 8 weeks, as final dose for healthy children, if first dose was administered at the 1% birthday or after. Minimum interval between doses. Saint dose 2 to dose 3. No further doses needed for healthy children if previous dose was administered at age 24 months or older, 4 weeks if current age is younger than 12 months and previous dose given at dose 3 to dose 4. 8 weeks, as final dose. This dose is only necessary for children aged 12 through 59 months regardless of risk, or age 60 through 71 months with any risk, who received 3 doses before age 12 months. Dose 4 to dose 5. Inactivated 6 weeks, 4 weeks, 4 weeks, 6 months poliovirus at if current age is measles, 12 months, 4 weeks, mumps, rubella at varicella at 12 months, 3 months, hepatitis A at 12 months, 6 months. Meningococcal 2 months, 8 weeks. See notes ACWY at MenacYCRM 2 years. Men ACWYTT. Children and adolescents age 7 through 18 years. Children and adolescents age 7 through 18 years. Minimum interval between doses. Vaccine minimum age for dose 1 to dose 2 to dose 3 to dose 4. Meningococcal not applicable, N/A, 8 weeks. ACWY at tetanus, 7 years, 4 weeks, 6 months. Diphtheria, if first dose of DTaP/DT. If first dose of DTaP/DT tetanus was administered before diphtheria, and the 1-degree birthday. The 1-degree birthday acellular 6 months, as final dose. Pertussis at if first dose of DTaP/DT or Tdap/TD was administered at or after the 1-degree birthday. Human 9 years. Routine dosing intervals are recommended. Papillomavirus at hepatitis A at N/A 6 months. Hepatitis B at N/A 4 weeks, 8 weeks and at least 16 weeks after first dose. Minimum interval between doses. Vaccine minimum age for dose 1 to dose 2 to dose 3 to dose 4. Inactivated N/A 4 weeks 6 months. A fourth dose of IPV is poliovirus. At a fourth dose is not indicated if all previous necessary if the third doses were administered at age 4 at measles, N/A 4 weeks mumps, rubella at varicella at N/A 3 months if younger than age 13 years. 4 weeks if age 13 years or older. Dengue at 9 years 6 months. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age, Table 1, by age. 2. Determine recommended interval for catch-up vaccination, Table 2, catch-up. 3. Assess need for additional recommended vaccines by medical. 4. Review vaccine types, frequencies, intervals, and considerations for special situations, notes. 5. Review contraindications and precautions for vaccine types, Appendix. XX26cdc.gov Adult Immunization Schedule by Age. Addendum updated February 29, 2024. Recommendations for ages 19 years or older, United States, 2024. Print. Euro back to Adult Immunization Schedule homepage. Vaccines in the Adult Immunization Schedule. WA get email updates. How to use the schedule. Download the schedule to make vaccination recommendations. Healthcare providers should print the schedule, color 1. Determine recommended vaccine by age, Table 1, by age. Print the schedule, black and white 2. Assess need for additional recommended vaccinations by medical condition or other indication, Table 2, by medical condition, in lead any 3. Review vaccine types, dosing frequencies and intervals, and considerations for special situations, notes. 4. Review contraindications and precautions for vaccine types, Appendix, compliant version of the Schedule 5. Review new or updated ACIP guidance, Addendum. IEC__I__A6, #EE. AS°/0. Recommended vaccination for adults who meet age requirement, LAC. Recommended vaccination for recommended vaccination. No recommendation/not adults with an additional risk based on shared clinical applicable factor or another indication. Decision-making documentation of vaccination, or lack evidence of immunity. Vaccine 19 to 26 years, 27 to 49 years, 50 to 64 years, 265 years. COVID-19 copyright. 1 or more doses of updated 2023 to 2024 formula, vaccine, see notes. Influenza inactivated, IIV4, or influenza recombinant, RIV4, at. Influenza live attenuated, LAIV4, at 1 dose annually. Of 1 dose annually. Virus, RSV, at seasonal administration during pregnancy. See notes, 260 years. Tetanus, diphtheria, pertussis, Tdap or TD, at 1 dose Tdap each pregnancy, 1 dose TD/Tdap for wound management, see notes. 1 dose Tdap, then TD or Tdap booster every 10 years. NEE. Measles, mumps, rubella, MMR, at. For healthcare personnel, see notes. 1 or 2 doses depending on indication, if born in 1957 or later. Varicella, VAR, at 2 doses, if born in 1980 or later. Zoster recombinant, RZV, at. Human papillomavirus, HPV, at 2 or 3 doses depending on age at initial vaccination or condition 27 through 45 years. Pneumococcal, PCV15, PCV20, PPSV23, I. Hepatitis A, HEPA, at. Hepatitis B, Hep B, at 2, 3, or 4 doses depending on vaccine or meningococcal A, C, W, yen, men ACWY, E. Meningococcal B, men B, at. Haemophilus influenza. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age, Table 1, by age, 3. Review vaccine types, frequencies, intervals, and considerations 2. Assess need for additional recommended vaccinations by for special situations, notes, medical condition or other indication, Table 2, by medical 4. Review contraindications and precautions for vaccine types condition, Appendix 5. Review new or updated ACIP guidance, Addendum. This schedule is recommended by the Advisory Committee on Immunization Practices, ACIP, and approved by the Centers for Disease Control and Prevention, CDC, American College of Physicians, ACP4, American Academy of Family Physicians, AAFP4, American College of Obstetricians and Gynecologists, ACOG4, American College of Nurse Midwives, ACNM4, American Academy of Physician Associates, AAPA4, American Pharmacists Association, APHA4, and Society for Health Care. Epidemiology of America, SHA4. The comprehensive summary of the ACIP recommended changes made to the adult immunization schedule can be found in the January 11, 2024 MMWR report. Suspected cases of reportable vaccine-preventable diseases or outbreaks to your state or local health department. CDC schedules home for healthcare providers adult immunization schedule. Adult immunization schedule by medical condition and other indication. Recommendations for ages 19 years or older, United States, 2024. Print. Back to Adult Immunization Schedule homepage. Vaccines in the Adult Immunization Schedule XA get email updates. How to use the schedule. Download the schedule to make vaccination recommendations. Healthcare providers should print the schedule, color 1. Determine recommended vaccine by age, Table 1, by age, print the schedule, black and white 2. Assess need for additional recommended vaccinations by medical condition or other indication, Table 2, by medical condition, download the mobile app 3. Review vaccine types, dosing frequencies and intervals, and considerations for special situations, notes, compliant version of the schedule 4. Review contraindications and precautions for vaccine types, Appendix 5. Review new or updated ACIP guidance, Addendum. A legend. Recommended for all adults who lack documentation of vaccination, or lack evidence of immunity. Not recommended for all adults, but recommended for some adults based on either age or increased risk for or severe outcomes from disease. Recommended based on shared clinical decision making. Recommended for precaution, all adults, and might be additional doses indicated if may be necessary. Benefit of based on medical protection condition or other indications. See notes. Outweighs risk of adverse reaction. Contraindicated or not recommended. No guidance / not applicable *. Vaccinate after pregnancy, if indicated. Always use this table in conjunction with Table 1 and the notes that follow. Medical conditions or indications are often not mutually exclusive. If multiple medical conditions or indications are present, refer to guidance in all relevant columns. See notes for medical conditions or indications not listed. Kidney HIV infection CD4_% and count end-stage immunorenal chronic compromised men who asplenia, heart disease liver, excluding COVID-19 at see notes. 144 at or RIV4 1 dose annually. 1 dose LAIV4 at annually if age 1 dose annually if age 19 to 49 years 19 to 49 years. Kidney HIV infection CD4 ILI percentage and count end stage immunorenal chronic compromised men who asplenia, heart disease. Liver, excluding. RSV at seasonal administration. See notes see notes see notes. Tdap or TD at Tdap, 1 dose each 1 dose Tdap, then TD or Tdap booster every 10 YRS pregnancy. MMR at 1 or 2 doses depending on indication. VAR at C notes. RAV at C notes. HPV at 3 dose series if indicated. Pneumococcal. HEPA at. Hep B sent. C notes PHE. A precaution for LAIV4 does not apply to alcoholism. B. C notes for influenza, hepatitis B, measles, mumps, and rubella, and varicella vaccinations. See hematopoietic stem cell transplant. To make vaccination recommendations, healthcare providers should 1. Determine recommended vaccine by age, Table 1, by age, 4. Review contraindications and precautions for vaccine types 2. Assess need for additional recommended vaccinations by medical, appendix, condition or other indication, Table 2, by medical condition, 5. Review new or updated ACIP guidance, Addendum. X. Measles. Measles, rubella, is a highly infectious disease that is caused by the measles virus. There are 2 phases of disease, a catarrhal, prodromal, stage and an exanthem stage. The catarrhal stage is characterized by a fever with conjunctivitis, coryza, cough, and pathognomonic colic spots on the buccal mucosa. The sudden development of a high fever, malaise, and exanthem represents the next phase. The exanthem stage is typically characterized by an erythematous maculopapular rash that originates behind the ears and spreads to the rest of the body towards the feet. Infection is usually self-limiting and followed by lifelong immunity. Disease management includes vitamin A supplementation, symptomatic treatment, and possible post-exposure prophylaxis, PEP. Measles causes transient immunosuppression and may lead to serious complications such as encephalitis, otitis, or pneumonia. A rare but lethal late complication of measles is subacute sclerosing panencephalitis, SSPE, which may also affect immunocompetent individuals. The prognosis is good in uncomplicated cases. However, newborns and immunocompromised patients are more likely to suffer from severe complications. The measles vaccine is a combination vaccine that protects against measles, mumps, and rubella, MMR vaccine. The MMRV vaccine also protects against varicella. Immunization is recommended for all children, in addition to adults without evidence of immunity to measles, mumps, and/or rubella. Why and epidemiology. Scent distribution. Measles typically occurs in regions with low vaccination rates and in resource-limited countries. I+ peak incidence. Risk factors for measles, mumps, and/or rubella. The following individuals are at increased risk of acquiring or transmitting measles, mumps, and/or rubella. ALTS. Copyright individuals with an immunocompromised state E household or close contacts of immunocompromised individuals. Copyright college students O healthcare personnel. Copyright international travelers. Epidemiological data refers to the U.S., unless otherwise specified. OS. AE. Etiology. Pathogen, measles virus, MV, an RNA virus of the morbillivirus genus belonging to the Paramyxoviridae family. Scent route of transmission, direct contact with or inhalation of virus-containing droplets. Phi. WA. OES. Clinical features. Incubation period. Scent duration, 2 weeks after infection. Prodromal stage, catarrhal stage, 4. Scent duration, 4 to 7 days. Scent presentation. Copyright coryza, cough, and conjunctivitis. O fever. 1 O colic spots. Pathognomonic in anthem of the buccal mucosa. Tiny white or bluish-gray spots on an irregular erythematous background that resemble grains of sand. 1 disappear by the second day of the exanthem stage. Exanthem stage 41. Scent duration, 7 days, develops 1 to 2 days after enanthem. Scent presentation. Degree high fever, malaise o generalized lymphadenopathy o erythematous maculopapular, blanching, partially confluent exanthem. Back collapse. Fine text outline. Equals begins behind the ears along the hairline. Equals disseminates to the rest of the body towards the feet, palm and sole. Involvement is rare. Equals fades after 5 days of onset, leaving a brown discoloration and desquamation in severely affected areas. I recovery stage. The cough may persist for another week and may be the last remaining symptom. And the most important findings of measles are the 3 Cs and 1 K, coryza, cough, conjunctivitis, and colic spots. 4. OO. CE. Diagnostics. Measles should be suspected in a patient with typical clinical findings. Laboratory tests are always necessary to confirm the diagnosis. 5 Scent CBC, leukocytes, platelets. Scent serology. Copyright gold standard, detection of measles-specific IgM antibodies. 1 Copyright IgG antibodies. 4 Plus identification of pathogen, direct virus detection via reverse transcriptase polymerase chain reaction, RT-PCR, possible scent biopsy. Affected lymph nodes show paracortical hyperplasia and Warthin-Finkelday cells, multinucleated giant cells formed by lymphocytic fusion. 7. ORU. Treatment. Symptomatic treatment. Ca. 6, plus vitamin A supplementation reduces morbidity and mortality, especially in malnourished children. 17 plus isolate patients with confirmed infection. 9 Copyright all patients, isolate for 4 days from the onset of rash, longer if immunocompromised. Copyright hospitalized patients, initiate airborne precautions. Measles is a nationally notifiable disease, report all cases to the appropriate health departments within 24 hours. WG, see prevention for post-exposure prophylaxis for exposed individuals. OO. CE. Complications. Subacute sclerosing panencephalitis, SSPE, LL111. Scent definition, a lethal, generalized, demyelinating inflammation of the brain caused by persistent measles virus infection. 12-13 Scent epidemiology. O primarily affects males between 8 and 11 years of age. O usually develops 7 years after measles infection. Scent clinical presentation, characterized by 4 clinical stages. Copyright stage, dementia, personality changes. Copyright stage IL, epilepsy, myoclonus, autonomic dysfunction. Copyright stage ill, decerebration, spasticity, extrapyramidal symptoms. Copyright stage 4, vegetative state, autonomic failure. Scent diagnosis. O electroencephalography. Back collapse. Fine text outline. Scent diagnosis. Copyright electroencephalography equals paroxysmal delta waves, very slow, 1-3/sec, equals periodic sharp and slow wave complexes. Copyright cerebrospinal fluid, T anti-measles IgG plus prognosis, SSPE leads to death within 1 to 3 years of diagnosis. 4. Other complications, 2LL1. Scent bacterial superinfection. Copyright otitis media. O pneumonia, most common cause of death. Copyright laryngotracheitis. Scent gastroenteritis. Scent meningitis. Acute encephalitis, frequency, 1:1000, 5. Copyright develops within days of infection. Copyright acute disseminated encephalomyelitis may develop within weeks. Scent giant cell pneumonia, viral, most commonly seen in immunosuppressed individuals. Complications are likely to occur when the fever does not subside after a few days after onset of the exanthem. We list the most important complications. The selection is not exhaustive. OSOIFO. Prognosis. The prognosis of measles infection is good in uncomplicated cases. Fatal courses are more likely in newborns and immunocompromised patients. High fatality rate in resource-limited countries due to secondary bacterial infections. 7-8. Prevention. Vaccination/LL16 LL2. Measles, mumps, rubella vaccine, MMR, measles, mumps, rubella, varicella vaccine, MMRV, 1 cent indications and schedule, see ACIP immunization schedule for details. Asterisk contraindications, 7. Copyright any contraindications to live vaccines, 18 LL17 Copyright history of anaphylaxis from neomycin- plus precautions, 7 Copyright history of thrombocytopenia Copyright tuberculin skin test, TST, within the preceding 4 to 6 weeks, 1, 17 IL-19 Copyright personal or family history of epilepsy, MMRV vaccine only, 120. Post-exposure prophylaxis, PEP, for measles, degree 1. Indication, negative or indeterminate serology methods Copyright active immunization, for immunocompetent individuals after direct exposure Copyright passive immunization for immunocompromised individuals further measures for exposed individuals, avoidance of communal facilities V. Back collapse. QL. Find text. O. Outline. Measles, 1/7. Overlay. Colic spots V. Colic spots, which are characteristic of measles infection, are visible on the buccal mucosa. These are white necrotic lesions, dashed line, on an erythematous base. This image is an adaptation. Source of original image, Centers for Disease Control and Prevention, CDC. Original title, ID #4500. Created by, CDC. Licensed under public domain. Modifications to original image, image turned. Measles rash VV. Generalized maculopapular exanthem is visible on this toddler's body. Source, Measles rash Phil, Centers for Disease Control and Prevention, Atlanta, USA, Centers for Disease Control and Prevention licensed. Under public domain. Measles, 3/7. Abdominal rash in measles VV. A widespread maculopapular rash is visible across the abdomen. Source, ID #3168, CDC/Heinz F. Eichenwald, MD, Centers for Disease Control and Prevention, CDC, licensed under public domain. Measles. Multiple maculopapular blanching and partially confluent patches are disseminated over the head, neck, and back of this young patient. These findings are consistent with a desquamating rash, which can occur after fading of the first erythematous exanthema, caused by an infection with the measles virus. Source, Figure 34, in Atlas of Pediatric HIV Infection by Regina E. Oladikan, Raniko J. Leloanya, Carol Hlila et.al., Open Books, licensed under CC by ND 4.0. Measles. A maculopapular exanthema, which is partially confluent, is visible on the trunk. In combination with the corresponding characteristic clinical features, these skin findings are suggestive of measles. Source, Measles in African Child 3, Mike Blythe, Wikimedia Commons licensed under public domain. Measles. A maculopapular rash on erythematous base is visible and appears partially confluent. This finding may be barely visible on darker skin. Source: Measles in African Child 2.jpg, Mike Blythe, Wikimedia Commons licensed under public domain. Measles first disease, morbilli. Pathogen paramyxovirus. Course improvement of exanthem with fine desquamation after 4 to 5 days. Complications FA-EPE_ananthem on palate and subacute sclerosing panencephalitis plus ear EEP, SSPE, IOESAE2 measles encephalitis ESAG SEGPO TS7, HEAESHI treatment me OE gate, symptomatic generalized HE, AESG. Yes pack /8xly SS, MH, erythematous, maculopapular, ye *23/EE%. UI blanching, partially confluent, VAEC8. Where FGG at, reduced general condition incubation period /a time /SE high fever, biphasic, contagious VAD, period KC barking cough F, exposure onset of exanthem. Measles fact sheet VV. Copyright Emboss. X chickenpox. Chickenpox, i.e., varicella, is an infection caused by the varicella zoster virus, VZV. The condition predominantly affects children. Transmission occurs via inhalation of airborne droplets and direct contact with respiratory secretions or skin lesion fluids. Chickenpox manifests with an intensely pruritic rash characterized by sequential clusters of papules, vesicles, and pustules in various stages of development. The rash may be preceded by a prodrome of constitutional symptoms. A clinical diagnosis is made based on the appearance of the rash. Confirmatory testing may be obtained for atypical rashes or severe infection. In immunocompetent individuals, chickenpox is self-limiting and managed symptomatically. Antiviral therapy is reserved for patients with severe infection or at high risk for complications, example bacterial. Superinfection, invasive infections. Following resolution, the virus remains latent in the sensory nerve root ganglia. It can reactivate, see shingles, during episodes of stress or immunosuppression. Prevention includes routine vaccination and, when indicated, post-exposure prophylaxis. WA. OS. Epidemiology. E primarily occurs in children sent before vaccines were widely introduced. 90% of all children had been infected by the age of 15. References. Epidemiological data refers to the U.S., unless otherwise specified. OC. CE. Etiology. Scent pathogen, varicella zoster virus, VZV, a human herpes virus type 3, HHV3, 2, plus transmission 2. Copyright airborne droplets. Copyright direct skin contact with VZV infected vesicle fluid O transplacental scent infectivity. Copyright highly contagious. Copyright 2 days before and up to 5 days after the onset of exanthem, or until all the lesions have formed crusts. 3 latency, can become latent after primary infection and reside inside the trigeminal and/or dorsal root ganglia 2. Risk factors for severe VZV infection /4 LLSII3. Individuals with any of the following factors are at risk of severe primary infection if they have no evidence of VZV immunity, age 12 years scent immunosuppression pregnancy * chronic skin or lung disease 1-3 long-term salicylate therapy, example aspirin, infancy. WA. ROOE. Clinical features. Plus incubation period, 2 weeks, 13 cent prodrome phase, rare in children, 7 copyright constitutional symptoms, example fever, malaise, headache, muscle or joint pain, copyright 2 to 3 days prior to the onset of exanthem scent exanthem phase, characterized by approximate 250 to 500 severely pruritic lesions in varying stages of development, its copyright lesion stages, Papule superficial vesicles filled with clear fluid on an erythematous base, dewdrop on rose petal appearance, umbilicated and crusted pustules. Scabs fall off after 1 to 3 weeks, often leaving a depressed base. Copyright skin involvement /IL71I8. Back collapse fine text outline. Copyright skin involvement, 27I8 lesions first manifest centrally, i.e., face, scalp, and trunk, and spread to the extremities. The rash is ultimately distributed across the body, with the highest concentration of lesions in the central areas. The oral and urogenital mucous membranes are affected. Ocular involvement may be present, see VZV conjunctivitis. Palms and solace are typically spared. Features of severe varicella infection may develop, e.g., 3 = prolonged high fever, 1 week, prolonged eruption of vesicles, 5 days, 2 = signs of thrombocytopenia, including hemorrhagic skin lesions = symptoms of visceral dissemination, example encephalitis, pneumonia, scent latent phase, following resolution of active skin infection, VZV remains latent in the sensory root ganglia, it can later reactivate, see shingles. M71, 3. Copyright severe varicella infection is characterized by the prolonged eruption of vesicles, which are sometimes hemorrhagic, high fever 1 week, and dissemination of VZV to the brain, encephalitis, liver, hepatitis, and/or lungs, pneumonia. 3. Your note. Subtypes and variants. Breakthrough varicella infection degree LL3. Definition, a wild-type VZV infection that occurs in individuals who have received 1 dose of the chickenpox vaccine 42 days prior to symptom onset. 1 Raldcytal scent infectivity, infectious to close contacts. 9 Scent clinical features, generally mild compared to typical chickenpox infection. 3 Scent treatment, usually supportive vaccine-associated chickenpox rash/LL131. 3. Definition, a vaccine-type VZV infection that occurs following chickenpox immunization. 1 LL14 plus incidence, manifests in 5 to 10% of healthy individuals following chickenpox immunization. FN scent infectivity, may rarely infect close contacts. 9 Scent clinical features. Copyright mold illness similar to breakthrough varicella infection. I9-IL11O lesions are often present at the immunization injection site. 3 Scent treatment, supportive. Word Mac. At shared note manage. Diagnostics. General principles. Scent typically diagnosed clinically based on characteristic clinical features plus confirmatory diagnostic studies are usually only considered in the following cases. 2 IL-15E suspected VZV infection in patients with no rash or uncharacteristic rash. Copyright vaccinated patients with suspected varicella, copyright patients with immunocompromised contacts. Additional studies may be required for patients with severe infections. Confirmatory studies, 15Li16. Plus PCR, preferred test for active infection detects VZV DNA, 1, 7-IL-2 Li8 plus serology, IgM and IgG detection, can identify primary infection and serologic immunity. 7I3I15 viral culture C2, 71I7 plus Zank smear, not specific for VZV, may also be positive in HSV infections. 19. Chickenpox is usually diagnosed clinically. Obtain laboratory testing in case of atypical rash or severe infections. 2. Back collapse fine text outline. Additional studies. Consider in severe varicella zoster infection, depending on clinical features. Scent bacterial superinfection of lesions, see diagnostics for sepsis. Plus pneumonia. 20 Copyright chest imaging, CT or X-ray chest, 1 millisecond meningoencephalitis. 21 OPCR of CSF. Copyright MRI brain. 221. Differential diagnoses. Chickenpox may be confused with other conditions that involve widespread vesicles and/or crusting lesions, e.g., its scent disseminated herpes zoster, i.e., shingles, scent herpes simplex virus, disseminated HSV, eczema herpeticum plus enterovirus infection, atypical hand, foot and mouth disease, 241L25 plus widespread bullous impetigo * monkeypox 1171 plus adverse reaction to smallpox vaccination, eczema vaccinatum, disseminated vaccinia, 7L26LL271 See also infectious rashes in childhood. Treatment. Approach 2. Scent start supportive treatment for all patients. 1. Scent assess for indications for antiviral therapy for varicella, if present, determine duration of symptoms. O. Symptom duration. Treat fever and pain with acetaminophen, 1 plus pruritus 128 O. General advice for caregivers equals apply cool compresses. Equals take lukewarm oatmeal baths. Trim fingernails or wear mitts to prevent scratching. Degree medications equals topical, calamine lotion, Pramoxine gel 28 equals oral antihistamines. Registered avoid use of aspirin and other salicylates, example bismuth subsalicylate, in children with chickenpox because of the risk of Reye syndrome. 3. Antiviral therapy for VZV infection, high-risk patients only. Indications for antiviral therapy Copyright severe VZV infection Copyright risk factors for severe VZV infection. Back collapse Find text outline. Recommended treatment, begin antiviral therapy as soon as possible, ideally within 24 hours of rash onset. A30 immunocompromised individuals, neonates, and/or those with severe infection, 4 acyclovir S2, copyright immunocompetent individuals, individuals with non-severe infection, oral acyclovir or valacyclovir S0LL8I, S. Copyright patients with non-severe infections and no risk factors for severe VZV infection do not require antiviral therapy and can be managed with supportive treatment only. 2. PIVU. OQOR. Complications. Adults have higher rates of complications from varicella compared to children. 2. Skin 1. Plus bacterial superinfection, including impetigo, phlegmon, necrotizing fasciitis, which often leads to scarring land is managed with antibiotics. Reactivation of latent VZV results in shingles, herpes zoster. Scent scarring central nervous system, 2813. Acute cerebellar ataxia, good prognosis, mainly self-limiting after several weeks. 1. Scent encephalitis, very rare cramps, coma, poor prognosis. Lung/3. Scent pneumonia, viral or bacterial, fetus, chickenpox during pregnancy. 3. Scent congenital varicella syndrome. We list the most important complications. The selection is not exhaustive. Assir. Prognosis. Scent in healthy children, chickenpox infection generally has a benign course and heals without any consequences. Residual scarring may occur because of excessive scratching or bacterial superinfection. Immunosuppressed individuals are at a greater risk of the disease taking a generalized or even fatal course. References to 7 OE. Prevention. Most U.S. states mandate reporting cases of chickenpox to local and/or state health departments. 32. Evidence of VZV immunity, degree I328. Any of the following constitutes evidence of immunity to chickenpox: scent documentation of age-appropriate varicella immunization, scent laboratory findings that confirm prior wild-type disease or serologic evidence of immunity, attestation of past varicella or herpes zoster infection by a healthcare provider, varicella vaccine/241 I35136. Scent general principles. Copyright consists of 2 doses of a live attenuated vaccine. Copyright available vaccines include A single antigen varicella vaccine A combined measles, mumps, rubella, varicella, MMRV, vaccine 8A recommended for all individuals without evidence of VZV immunity who have no contraindications to live vaccine schedule. See ACIP immunization schedule for details on routine and catch-up schedules. Back collapse find text outline. Evidence of VZV immunity 7 ## degree. Any of the following constitutes evidence of immunity to chickenpox. Sent documentation of age-appropriate varicella immunization laboratory findings that confirm prior wild-type disease or serologic evidence of immunity. Sent attestation of past varicella or herpes zoster infection by a healthcare provider. Varicella vaccine 341I 35136. Sent general principles. Copyright consists of 2 doses of a live attenuated vaccine. Copyright available vaccines include a single antigen varicella vaccine a combined measles, mumps, rubella, varicella, MMRV, vaccine 8A recommended for all individuals without evidence of VZV immunity who have no contraindications to live vaccines. Sent schedule. See ACIP immunization schedule for details on routine and catch-up schedules. Plus adverse effects. If MMRV is given at 12-23 months of age, increased risk of febrile seizures. Copyright vaccine associated chickenpox rash post-exposure prophylaxis for chickenpox/LL41. Sent post-exposure prophylaxis is recommended for non-immune individuals exposed to chickenpox or shingles to prevent disease onset or mitigate disease course. 340 If symptoms develop following exposure, initiate treatment for varicella infection regardless of whether the patient received post-exposure prophylaxis. Determining post-exposure prophylaxis. 3191141 Evidence of VZV immunity. No evidence of VZV immunity. Sent post-exposure prophylaxis required, usually with active immunization. Immunocompetent * post-exposure prophylaxis not recommended. * prophylaxis only required for patients who have received a bone marrow. Sent post-exposure prophylaxis required, usually with passive immunocompromised transplant. 69. OSU-PH immunization. Passive immunization is recommended. Active immunization. Sent indications. Immunocompetent patients equals 12 months of age with no evidence of VZV immunity. 3. Recommended prophylaxis. Copyright chickenpox immunization. Copyright give within 5 days following exposure, ideally within 3 days. 9. Prophylaxis is not recommended for healthy individuals who are either too young for vaccination or who were exposed to VZV 5 days prior to evaluation. 3. Passive immunization. Sent indications. Copyright individuals with no evidence of VZV immunity who are, immunocompromised pregnant neonates, if the mother was symptomatic 5 days before or up to 2 days after birth. 10 Copyright hospitalized premature babies if, born. OG-XCE. Tips and links. Sources. Last updated August 4, 2023. Back collapse find text outline. 5N. Mine. Chickenpox. A diffuse rash is seen in various stages of lesion evolution, starry sky appearance, with mainly ruptured vesicles and crusted erosion seen here. These findings are typical for chickenpox. This image is an adaptation. Source of original image, Wikimedia Commons. Original title, Waterpocken. Created by, Poster Jack. Licensed under public domain. Modifications to original image, pixelation of the orbital area. Facial rash in chickenpox VV. The face of the girl shows macules, vesicles, and papules on an erythematous base, as well as erupted vesicles and crusted papules. The simultaneous occurrence of various stages of rash is sometimes described as starry sky and is typical of chickenpox. Source, ID #10486, CDC/Dr. John Noble, Jr., Centers for Disease Control and Prevention, CDC, licensed under public domain. Euro chickenpox, 1/9. Chickenpox VV. A vesicle filled with clear fluid on an erythematous base is seen on the skin of this patient. This appearance is referred to as a dewdrop on a rose petal and, in combination with other skin lesions, indicates infection with varicella zoster virus, chickenpox. Source, courtesy of Dr. Gary M. White MD. Enanthem of oral mucous membrane in chickenpox VV. A vesicle on an erythematous base, located on the right side of the hard palate. Source, ID hashtag 3176, CDC/Heinz F. Eichenwald, MD, Centers for Disease Control and Prevention, CDC, licensed under public domain. AFV-VV. Two small AFV are visible at the tip of the tongue and one on the right side. AFV are nonspecific. In this case, they were associated with varicella infection. Source, courtesy of Dr. Gary M. White MD. AE, Pests EEA. STNC. Chickenpox, varicella, upper body of a young boy with exanthem showing the simultaneous occurrence of various stages of rash, mainly vesicles and pustules, no crusted erosions. This clinical finding is also referred to as starry sky and is typical of chickenpox. Source, Varicella aranzales, Camelorenzales, Wikimedia Commons licensed under public domain. Euro chickenpox, 7/9. Chickenpox VV. Two papules and a vesicle, center, are visible. The cloudy appearance of the vesicle fluid indicates that it is in the course of transitioning into a pustule. The development of a rash manifesting with various stages simultaneously is typical of chickenpox. Source, courtesy of Dr. Gary M. White MD. Euro chickenpox, 8/9. Chickenpox VV. Chest of a child. Multiple vesicles filled with clear fluid on an erythematous base are visible. This clinical finding is called dewdrops on a rose petal, and it is classically seen in varicella, chickenpox. Source, courtesy of Dr. Gary M. White MD. Chickenpox. Multiple disseminated papules and vesicles on an erythematous base are visible on this patient's face. Numerous vesicles in the preauricular region appear umbilicated. These lesions are caused by an infection with varicella zoster virus, VZV. Source, Varicella impertant chickenpox by Group de Ogre, Wikimedia Commons, licensed under CC by SA 4.0. Overlay. Multiple pulmonary nodules VV. CT chest, lung window, axial plane, of a patient with acute respiratory failure, fever, and a skin rash typical of varicella. Numerous small non-calcified pulmonary nodules are present throughout both lungs, examples indicated by green overlay. Some nodules are circumscribed while others are ill-defined and accompanied by ground glass opacification, examples indicated by red overlay. The radiographic appearance is compatible with acute varicella pneumonia in this patient with clinical signs and symptoms of varicella. In contrast, healed varicella pneumonia is characterized by the presence of numerous small calcified pulmonary nodules. Yellow overlay, examples of thickened interlobular septa. Source, Fig 1, in severe varicella zoster virus pneumonia, a multi-center cohort study by Morales A., Vignon P., Perrin PETAL, BMC, licensed under CC by 4.0. Overlay. Multiple pulmonary nodules VV. CT chest, lung window, axial plane, of a patient with acute respiratory failure, fever, and a skin rash typical of varicella. Numerous small non-calcified pulmonary nodules are present throughout both lungs, examples indicated by green overlay. Some nodules are circumscribed while others are ill-defined and accompanied by ground glass opacification, examples indicated by red overlay. The radiographic appearance is compatible with acute varicella pneumonia in this patient with clinical signs and symptoms of varicella. In contrast, healed varicella pneumonia is characterized by the presence of numerous small calcified pulmonary nodules. Yellow overlay, examples of thickened interlobular septa source, Fig 1, in severe varicella-zoster virus pneumonia, a multi-center cohort study by Morouse A., Vignon P., Perrin PETAL, BMC, licensed under CC by 4.0. Euro chickenpox, 2/3. Copyright. Overlay. Multiple small calcified pulmonary nodules VV. X-ray chest, A, PA view, B, lateral view, of a patient with a remote history of varicella. Numerous small calcified nodules in both lungs, examples indicated by arrowheads, are the sequela of healed varicella pneumonia. The differential diagnosis of widely distributed small calcified pulmonary nodules includes various types of infection, pneumoconioses, metastases, and deposition diseases. Source, Fig 7a and b, in Pulmonal Rundherd und Pneumonie ein Diagnostiker Leitfaden by Frauenfelder T., Landsmann A., Springer Medicine, licensed under CC by 4.0. Modifications, image cropped and replacement of lowercase letters with uppercase letters. Euro chickenpox, 3/3. Overlay. Multinucleated giant cells with Cowdery type A inclusions VV. Microscopic image of lung tissue, H&E stain, several multinucleated giant cells, syncytial macrophages, can be seen in the center of the image, examples indicated by green overlay, surrounded by inflammatory infiltrate. The giant cells feature characteristic eosinophilic nuclear inclusions, Cowdery type A, blue overlay. Giant cells with Cowdery type A inclusions are a characteristic histopathological finding in infections with varicella-zoster virus, herpes simplex virus, and cytomegalovirus. Source, herpes simplex infection case 160 by Yale Rosen, Flickr, licensed under CC by SA 2.0. Euro chickenpox, 3/3. Overlay. Multinucleated giant cells with Cowdery type A inclusions VV. Microscopic image of lung tissue, H&E stain, several multinucleated giant cells, syncytial macrophages, can be seen in the center of the image, examples indicated by green overlay, surrounded by inflammatory infiltrate. The giant cells feature characteristic eosinophilic nuclear inclusions, Cowdery type A, blue overlay. Giant cells with Cowdery type A inclusions are a characteristic histopathological finding in infections with varicella-zoster virus, herpes simplex virus, and cytomegalovirus. Source, herpes simplex infection case 160 by Yale Rosen, Flickr, licensed under CC by SA 2.0. Measles, scarlet fever, rubella, erythema infectiosum, roseola, varicella, German measles, 5th disease, 6th disease, chicken pox. Classic pediatric exanthem diseases VV. Many infectious diseases in children present with a rash, exanthem. The distribution and morphological characteristics of the exanthem allow the diseases to be differentiated from one another. Measles, patients present with a dark red, erythematous, maculopapular, partially confluent exanthem, which spreads from behind the ears to the rest of the body. Scarlet fever, patients present with a fine, light red, maculopapular rash. The exanthem begins on the neck and disseminates to the whole body. The patient's face may be red with perioral sparring. After 1 to 2 days, the exanthem becomes scarlet-colored, and partially confluent. The rash is most pronounced in the axilla and groin. Non-blinking petechiae, pastia lines, may be present. Rubella, German measles patients typically present with a non-confluent, pink, maculopapular exanthem, which, like measles, extends from behind the ears to the rest of the body. Measles, scarlet fever, rubella, erythema infectiosum, roseola, varicella, German measles, fifth disease, sixth disease, chicken pox. Classic pediatric exanthem diseases VV. Erythema infectiosum, fifth disease, a confluent, maculopapular rash appears only in % of patients. It may take on a lace-like, reticular appearance over time. Additionally, patients present with diffuse redness of the face with perioral sparing, slap cheek rash. Roseola infantum, sixth disease, 3 days of high fever are followed by a sudden decrease in temperature and development of a patchy, rose-pink, macular exanthem. The rash originates on the trunk and neck, and may spread to the face and extremities in some cases. Varicella, chickenpox. The exanthem affects the whole body, typically spreading to the scalp as well. Various stages of the rash occur simultaneously, which leads to the characteristic clinical finding known as starry sky. Copyright Emboss. X. Roseola infantum. Roseola infantum, exanthem subidum, 3-day fever, is a viral exanthematous infection caused by the human herpes virus 6, HHV6, in rare cases, HHV7, that mainly affects infants and toddlers. Infection is characterized by high fever, which ends abruptly after 3 to 5 days, followed by the sudden appearance of a maculopapular rash. The rash generally appears mainly on the trunk, but sometimes spreads to the face and extremities, and fades within 2 days. Roseola infantum is a self-limiting condition that is only treated symptomatically. Febrile seizures are a possible complication of infection, however, most patients recover from these seizures without any adverse outcome. WA. A6. Epidemiology. Most frequent in infants and young children. Peak incidence, 6 months to 2 years. References LL2. Epidemiological data refers to the U.S., unless otherwise specified. C. And. Etiology. E-pathogen OHHV6, and in rare cases HHV7, O. Humans are the sole hosts. Route of transmission, droplet infection, example saliva, incubation period, 5 to 15 days. References, IL3I. OO. CE. Clinical features. Febrile phase. Scent duration, 3 to 5 days. Fever O. Abrupt onset of high fever, in some cases 40 degrees Celsius 104 degrees Fahrenheit. Copyright. Febrile seizures are a potential complication of roseola, see complications below. Cervical, postauricular, and/or occipital lymphadenopathy. Inflamed tympanic membranes. Nagayama spots, papular enanthem on the uvula and soft palate scent. Other possible symptoms, copyright. Mild upper and lower respiratory symptoms, pharyngitis, cough, etc. Copyright. Vomiting and/or diarrhea. Copyright. Conjunctivitis and edema of the eyelid. Exanthem phase. Scent duration, 1 to 3 days. Characteristic presentation, subsequent sudden decrease in temperature and development of a patchy, maculopapular exanthem. Copyright. Rose pink in color, blanches upon pressure. Copyright. Non-pruritic, in contrast to the drug allergy rash. Copyright. Originates on the trunk, sometimes spreads to the face and extremities. Q. The names of the disease reflect its 2 phases. 3-day fever refers to 3 days of high fever. Exanthem subidum, from Latin, subitus equals sudden, describes a sudden exanthem, upon fever cessation. Equals QL. Collapse. Fine text outline. Diagnostics. Usually a clinical diagnosis. Sent laboratory tests, copyright. Antibody testing, HHV6 IgM detection is possible. Copyright. Viral DNA testing, pathogen DNA detection via PCR, possible detection using blood, urine, cerebrospinal fluid, or saliva samples. References /1. OC wrote shared notes. Differential diagnoses. Scent other infectious rashes in childhood. Scent drug reactions * meningitis 7. References /1 The differential diagnoses listed here are not exhaustive. GF VU. Treatment. Symptomatic treatment, example fluids and possibly acetaminophen to reduce fever. Pete, Rastvan 2 references, /1. A shared notes. Complications. Febrile seizures, in up to 15% of cases, usually without sequelae. Meningoencephalitis, very rare, references 5. We list the most important complications. The selection is not exhaustive. Prognosis. Very good prognosis, self-limiting disease. The virus persists lifelong in its host, and reactivation of latent virus or reinfection may occur later in life, especially if individuals become immunocompromised, references 5. OVCCE. Tips and links =AO collapse. Find text outline. Exanthem subidum, Rosella infantum, VV. A 1-year-old child with a recent febrile illness who developed a non-pruritic, blanching, erythematous maculopapular rash beginning on the trunk and spreading peripherally 1 day after the fever subsided. The pictured rash and history are consistent with exanthem subidum, also known as Rosella infantum or sixth disease. This benign disease is usually caused by HHV6 and may also cause a cough, runny nose, and or diarrhea. Source: Sestimalatia, Emiliano Berzagli, Wikimedia Commons licensed under public domain. Rosella infantum sixth disease, exanthem subidum F== Human herpes virus 6 and 7 SSSAA = HHV6, HHV7, = 4 dp. Vera RFF course edematous eyelids, acanvical symptoms resolve within hours to maximum 3 days. 8 cf vical lymphadenopathy. Complications number 3% febrile seizures. TI-BS. Encephalitis = Treatment. Symptomatic exanthem, pale red, blanching vaccine macular or maculopapular nun rash, especially on trunk. Copyright, good general condition. High fever. For 3 days before onset of exanthem incubation period. Time EYCB cough contagious unknown I period lay and rhinorrhea. Exposure onset of exanthem /4 I abdominal pain. Rosella infantum, sixth disease, fact sheet VV. Copyright Embellished. Rosella infantum, 1/1. Wet. Measles scarlet fever rubella erythema infectiosum Rosella varicella German measles fifth disease sixth disease chicken pox. Classic pediatric exanthem diseases VV. Many infectious diseases in children present with the rash, exanthem. The distribution and morphological characteristics of the exanthem allow the diseases to be differentiated from one another. Measles, patients present with a dark red, erythematous, maculopapular, partially confluent exanthem, which spreads from behind the ears to the rest of the body. Scarlet fever, patients present with a fine, light red, maculopapular rash. The exanthem begins on the neck and disseminates to the whole body. The patient's face may be red with perioral sparring. After 1 to 2 days, the exanthem becomes scarlet-colored, and partially confluent. The rash is most pronounced in the axilla and groin. Non-blinking petechiae, pastia lines, may be present. Rubella, German measles patients typically present with a non-confluent, pink, maculopapular exanthem, which, like measles, extends from behind the ears to the rest of the body. 4 on 4 RIX, ZA/. 4L. Q \\y \\PA, Q, YKQ = BT ****, and, smiley face, and FJ. //////AUPI. Measles, scarlet fever, rubella, erythema infectiosum, roseola, varicella, German measles, 5th disease, 6th disease, chicken pox. Classic pediatric exanthem diseases v. Rubella, German measles, patients typically present with a non-confluent, pink, maculopapular exanthem, which, like measles, extends from behind the ears to the rest of the body. Erythema infectiosum, 5th disease, a confluent, maculopapular rash appears only in % of patients. It may take on a lace-like, reticular appearance over time. Additionally, patients present with diffuse redness of the face with perioral sparing, slap cheek rash. Roseola infantum, 6th disease, 3 days of high fever are followed by a sudden decrease in temperature and development of a patchy, rose-pink, macular exanthem. The rash originates on the trunk and neck, and may spread to the face and extremities in some cases. Varicella, chickenpox, the exanthem affects the whole body, typically spreading to the scalp as well. Various stages of the rash occur simultaneously, which leads to the characteristic clinical finding known as starry sky. 5th disease. Erythema infectiosum, 5th disease, is one of the clinical syndromes caused by human parvovirus B19 infection. The virus is transmitted by respiratory droplets and primarily affects children between the ages of 5 and 15. Erythema infectiosum begins with a mild febrile illness followed 2 to 5 days later by a maculopapular rash that is especially noticeable on the cheeks, i.e., slap cheek rash, and may be pruritic. Once the rash has appeared, the infected individual is no longer contagious and usually feels well again. Erythema infectiosum is self-limited, and the rash usually resolves within 7 to 10 days, but may be recurrent over several weeks. Whereas adult infection is characterized much more by arthritic symptoms and less by a rash, parvovirus B19 infection also manifests with joint symptoms in a minority of children. There is no specific vaccine or treatment for parvovirus B19 infection, though symptomatic treatment for arthralgias or pruritus can be used. Previous parvovirus B19 infection results in lifelong immunity against the virus. Because of its ability to infect erythrocyte progenitor cells, parvovirus B19 can cause transient anemia in infected patients, as well as complications such as a transient aplastic crisis in patients with chronic hemolytic diseases, example sickle cell disease, and chronic pure red cell aplasia in the immunocompromised. Infection with parvovirus B19, one of the torch congenital infections, during pregnancy may also have serious consequences for the fetus. WAEE-SHAR. Epidemiology. Cent peak incidence, 5 to 15 years IU, prevalence of seropositivity copyright 10% in preschool children 70% in adults. Epidemiological data refers to the U.S., unless otherwise specified. OOA. Etiology. Pathogen. Human parvovirus B19, the smallest of the DNA viruses, O family, Parvoviridae copyright single-stranded DNA virus, linear, EO non-enveloped humans are the only reservoir for parvovirus B19. Route of transmission. Main route, aerosol scent. Other routes OE hematogenous transmission copyright transplacental transmission, in seronegative pregnant women, transmission to the unborn fetus may occur, in up to 30% of cases. References to IL-3. Y. OE. Pathophysiology. Parvovirus B19 binds to the P antigen, globoside, on erythroid progenitor cells. Cellular invasion. Viral DNA enters the nucleus of erythroid cells. Viral DNA replication. Cytotoxicity. Clinical manifestations plus transient cessation of erythropoiesis. Alst. Parvovirus B19 can also bind to and infect endothelial cells via the P antigen, potentially causing cardiovascular complications. 7L8. OSCE. Clinical features. Back collapse fine text outline. Clinical features. Disease course. Incubation period, 4 to 14 days. Infectivity, only contagious before onset of rash. Asymptomatic in 25% of cases. Clinical symptoms. Mild cold-like symptoms, scent exanthem, 2 to 5 days following the onset of cold-like symptoms. 1-0 initial diffuse redness of the face with perioral sparing, slapped cheek rash. 0 spread of exanthem to the extremities and trunk equals initially confluent and maculopapular, adopts a lace-like, reticular appearance over time as it clears. Associated with mild pruritus, in 50% of cases, equals fades after 7 to 10 days, can be recurrent over several weeks, becoming more pronounced after exposure to sunlight or heat. Copyright third phase with rash that varies with exposure to sun or heat and resolves spontaneously after several weeks. Parvovirus B19 associated arthritis. Scent epidemiology, affects percent, infected with parvovirus B19. 1 scent clinical findings. O arthralgia with symmetrical, non-destructive polyarthritis, particularly in small joints, fingers, hand, ankle, and knee. O usually resolves after 3 to 4 weeks. Complications, in some cases, persistent arthritis may develop. See complications below. References, 9 IL 10 LL 1 111121. WA. CE. Diagnostics. The diagnostic approach for parvovirus B19 infection varies by patient group. However, all groups may be affected by transient normocytic anemia with a low reticulocyte count because of the ability of the virus to infect erythrocyte progenitor cells. Immunocompetent children. Erythema infectiosum is typically a clinical diagnosis, i.e., slapped cheek or lace-like appearance of rash, in children. Immunocompetent adults. Lab tests only if the diagnosis is unclear. Antibody testing. Copyright IgM antibody equals appears within 10 days of initial exposure, indicating acute illness. Equals remains positive for 2 to 3 months. Copyright IgG antibody equals appears approximate 2 weeks following infection. Equals remains positive for life. Differentiating between parvovirus B19 associated arthritis and acute rheumatoid arthritis may require additional tests. See diagnostics section of rheumatoid arthritis. 1. Patients with transient aplastic crisis and immunocompromised patients. Scent CBC with reticulocytes. OJ reticulocytes. O hemoglobin below patient's baseline by equals 2G/DL, aplastic crisis, or C. Parvovirus B19 infection during pregnancy. References, 14. Back collapse fine text outline. Initial diagnostic test, viral DNA testing, nucleic acid amplification testing, NAAT, such as PCR of blood or bone marrow, adjunctive diagnostic test, serologic antibody testing, in immunocompetent adults. Pregnant women C. Parvovirus B19 infection during pregnancy. References, 14. WACE. Differential diagnoses. Scent other infectious rashes in childhood. Scent drug hypersensitivity reaction. The differential diagnoses listed here are not exhaustive. OOCE. Treatment. Treatment is not necessary in most cases, as the disease is often self-limited. Analgesics and nonsteroidal anti-inflammatory drugs, NSAIDs, scent short course of low-dose prednisone for parvovirus B19 associated arthritis. For treatment of parvovirus infection in pregnancy, see parvovirus B19 infection during pregnancy. Complications. Scent transient aplastic crisis in patients with chronic hemolytic diseases, example sickle cell disease, hereditary spherocytosis, thalassemia, pyruvate kinase deficiency, autoimmune hemolytic anemia. Copyright pathophysiology, parvovirus B19 infection of stem cells. Copyright treatment, blood transfusions if anemia is symptomatic. Sent chronic pure red cell aplasia in immunocompromised patients. Copyright pathophysiology, parvovirus B19 infection of proerythroblasts. Copyright treatment, blood transfusions for severe anemia. Intravenous immunoglobulin, IVIG, against parvovirus B19. Sent eye drops. Fetalis, fetal death, and miscarriage. Parvovirus B19 is a torch infection. See parvovirus B19 infection during pregnancy. Hepatitis, myocarditis, and aseptic meningitis/encephalitis, rare, references. We list the most important complications. The selection is not exhaustive. OOAGI. Tips and links. Sources. Last updated June 14, 2023. Erythema infectiosum, a fifth disease. SSOT, pathogen T. Parvovirus B19, hashtag reddened cheeks 4 * coarse slap cheek rash / exanthem in only 15 to 20% of cases, infection often asymptomatic, alternating fading and recurrence possible for months. _J. Complications. Parvovirus B19 associated arthritis. Exanthem, aplastic crisis, initially maculopapular, confluent, hydrops fetalis / lace-like in further course. Treatment. Symptomatic. F. Vaccine U. None. Copyright, good general condition. Incubation period 14 days. Vora. Time, mild fever. Contagious period. Exposure. Onset of exanthem. Erythema infectiosum, fifth disease, fact sheet v. Copyright Embellished. Euro. Fifth disease, 1/3. Fifth disease, parvovirus B19. There are bright red cheeks, slap cheek appearance, and a diffuse, red, confluent maculopapular rash visible over the body of the 16-month-old infant. This is the characteristic cutaneous appearance of fifth disease, erythema infectiosum, caused by infection with parvovirus B19. This image is an adaptation. Source of original image, Wikimedia Commons. Original title, Fifth Disease. Created by Andrew Kerr. Licensed under public domain. Modifications to original image, pixelated eyes. Euro. Fifth disease, 2/3. Fifth disease. Multiple erythematous, partially confluent macules and papules extend over the upper arm in a reticular pattern. This is the typical appearance of the exanthem associated with fifth disease. Image. Source of original image, www.pediatry-in-builder-n.de. Created by Dr. Thomas Rotten-Strock. Euro. Fifth disease, 3/3. Exanthema of fifth disease VV. A bilateral lace-like macular exanthema is visible over the dorsal aspects of both hands. This is the characteristic appearance of the exanthema of fifth disease, due to infection with parvovirus B19. Source, ID #4511, CDC, Centers for Disease Control and Prevention, licensed under public domain. Fifth disease, 1/1. Wet. Measles, scarlet fever, rubella, erythema infectiosum, roseola, varicella, German measles. Fifth disease, sixth disease, chicken pox. Classic pediatric exanthem diseases VV. Many infectious diseases in children present with a rash, exanthem. The distribution and morphological characteristics of the exanthem allow the diseases to be differentiated from one another. Measles, patients present with a dark red, erythematous, maculopapular, partially confluent exanthem, which spreads from behind the ears to the rest of the body. Scarlet fever, patients present with a fine, light red, maculopapular rash. The exanthem begins on the neck and disseminates to the whole body. The patient's face may be red with perioral sparring. After 1 to 2 days, the exanthem becomes scarlet-colored, and partially confluent. The rash is most pronounced in the axilla and groin. Non-blinking petechiae, pastia lines, may be present. Rubella, German measles patients typically present with a non-confluent, pink, maculopapular exanthem, which, like measles, extends from behind the ears to the rest of the body. Euro. And J. Slash, if backslash slash 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 up it. Measles, scarlet fever, rubella, erythema infectiosum, roseola, varicella, German measles, fifth disease, sixth disease, chicken pox. Classic pediatric exanthem diseases v. Erythema infectiosum, fifth disease, a confluent, maculopapular rash appears only in % of patients. It may take on a lace-like, reticular appearance over time. Additionally, patients present with diffuse redness of the face with perioral sparing, slap cheek rash. Roseola infantum, sixth disease, 3 days of high fever are followed by a sudden decrease in temperature and development of a patchy, rose-pink, macular exanthem. The rash originates on the trunk and neck, and may spread to the face and extremities in some cases. Varicella, chickenpox, the exanthem affects the whole body, typically spreading to the scalp as well. Various stages of the rash occur simultaneously, which leads to the characteristic clinical finding known as starry sky. Copyright Emboss. X. Scarlet fever. Scarlet fever is a syndrome caused by infection with toxin-producing group of B hemolytic streptococci, Streptococcus pyogenes, gas, and primarily affects children between the ages of 5 and 15. The syndrome occurs in less than 10% of cases of streptococcal tonsillopharyngitis and classically presents with fever, pharyngeal erythema with tonsillar exudates, and a fine, scarlet-colored rash that is most pronounced in the groin, underarm, and elbow creases. After approximately a week, the skin begins to desquamate on the face, trunk, hands, fingers, and toes. Antibiotic treatment with penicillin is recommended, as scarlet fever may progress to severe disease and other complications associated with streptococcus infection, example rheumatic fever and post-streptococcal glomerulonephritis. Scarlet fever is caused by various types of erythrogenic scarlet fever toxins, secreted by S. pyogenes, and as such, recurrent infection with other types of toxins is possible. VA 4 of Epidemiology. Asterisk peak incidence, 5 to 15 years, although it may affect individuals of any age, generally occurs in association with streptococcal cases of tonsillopharyngitis. Epidemiological data refers to the U.S., unless otherwise specified. WAOSE shared notes. Etiology. Pathogen. O group of B hemolytic streptococci, Streptococcus pyogenes, produce erythrogenic exotoxin A, B, or CIA. Copyright. Previous infection does not rule out additional episodes of the disease, as there are several different types of scarlet fever toxin. Route of transmission, aerosol references 21. Agu oe Sharad nights. Clinical features. Incubation period. Degree 2 to 5 days. Initial phase, acute tonsillitis, scent fever, malaise, headache, chills, and myalgias. Tonsillopharyngitis. Copyright. Sore throat and difficulty swallowing. O white coating on the tongue. O enlarged cervical lymph nodes. Gastrointestinal symptoms, possible in young children. F. O abdominal pain. E. O nausea and vomiting. Exanthem phase. Rash appears 12 to 48 hours after the onset of fever. 3. Scarlet-colored maculopapular exanthem, rash. Scarlet-colored maculopapular exanthem, rash. Scent presentation. Copyright. Fine, erythematous, sandpaper-like texture. O blanches with pressure. Copyright. Non-blinking petechiae are often additionally present. O may be pruritic. Copyright. Pastia lines equals a key sign of scarlet fever. Linear, petechial appearance equals most pronounced in the groin, underarm, and elbow creases, i.e., flexural areas. Elocation. Copyright begins on the neck. O disseminates to the trunk and extremities. Plus duration, 7 days I. Copyright. The characteristic scarlet fever rash is said to resemble goosebumps with a sunburn. Tonsillopharyngitis. Pharyngeal erythema, possibly with tonsillar exudate, strawberry tongue, bright red tongue color with papillary hyperplasia, which is revealed once the white coating has sloughed off. A plus typical red, flushed appearance of the cheeks with perioral pallor. Desquamation phase. Appears 7 to 10 days after resolution of rash. 4. Skin desquamation. Desquamation of the skin in flakes. A affects face, trunk, hands, fingers, and toes. Copyright. Findings like coryza, rhinorrhea, cough, hoarseness, anterior stomatitis, conjunctivitis, and ulcerative lesions are atypical for scarlet fever and warrant further investigation. WA9 Chat. Diagnostics. Scarlet fever is primarily a clinical diagnosis that should be confirmed with additional testing. Pathogen detection. Copyright. Throat culture 1.0 Rapid antigen detection testing, rapid strep test, 1 cent blood and urine studies. Copyright. Complete blood cell, CBC, count shows leukocytosis with a left shift and possibly eosinophilia over the course of the disease. Degree. Urinalysis and liver function tests may indicate complications of scarlet fever. See complications below. Degree 7. Inflammatory markers, CRP-ESR sent other tests. Copyright. During the course of disease, elevated anti-streptolysin 0, ASO, and antideoxyribonuclease B, ADB, titers. Copyright. Positive tourniquet test, Rumpel lead capillary fragility test, 5. POS and GOO. Back collapse. Fine text outline. Differential diagnoses. Scent. Other infectious rashes in childhood. Drug hypersensitivity reaction. Chickenpox, varicella, Kawasaki disease. Scent. Viral tonsillitis, infectious mononucleosis, herpes angina. Registered. The differential diagnoses listed here are not exhaustive. VA. OSO. Treatment. Indication: all cases of scarlet fever should be treated with antibiotics, both to prevent complications and to prevent transmission. Scent. Drug of choice, oral penicillin V. Scent. Alternative antibiotics. Copyright. In patients allergic to penicillin, macrolides. Copyright. In cases of recurrence due to antibiotic resistance, cephalosporin. Scent. After 24 hours of antibiotic treatment, the patient is no longer infectious and may return to daycare or school. U1. The aim of antibiotic treatment is to prevent complications and shorten the period of infectivity. Complications. Scarlet fever is considered one of the non-suppurative, i.e., non-pus forming, complications of streptococcal tonsillopharyngitis. Other complications of gas infection may also occur during or following scarlet fever, especially in patients who did not receive antibiotic treatment. Non-suppurative. Scent. Post-strep glomerulonephritis. Acute rheumatic fever, rare, Sydenham chorea. Pediatric immune neuropsychiatric disorders associated with streptococcal infections, PANDAS. 6. Copyright definition: a rare disorder that is characterized by sudden onset or exacerbation of obsessive-compulsive disorder, OCD, and/or a tic disorder following infection with S. pyogenes. Copyright. Pathophysiology equals not fully understood. Preceding gas infection results in an abnormal immune response with development of cross-reactive, antineuronal antibodies. M7. Copyright. Clinical features equals abrupt onset or exacerbation of symptoms of OCD and/or a tic disorder equals possible additional behavioral changes, enuresis, separation anxiety disorder, regression in learning and handwriting ability. Copyright. Diagnostic criteria, 8, equals presence of OCD and/or a tic disorder equals onset during childhood equals acute onset and episodic course equals temporal association with streptococcal infection. FA equals neurological abnormalities during episodes, example motoric hyperactivity, choreiform movements of fingers/toes. O treatment equals antibiotic eradication of gas equals cognitive behavioral therapy and pharmacologic treatment for OCD and tic disorder suppurative, i.e., pus forming. Back collapse fine text outline. CE. Treatment. Indication: all cases of scarlet fever should be treated with antibiotics, both to prevent complications and to prevent transmission. Scent drug of choice: oral penicillin v. Scent alternative antibiotics. Copyright in patients allergic to penicillin. Macrolides. Copyright in cases of recurrence due to antibiotic resistance. Cephalosporin. Scent after 24 hours of antibiotic treatment, the patient is no longer infectious and may return to daycare or school. 6. The aim of antibiotic treatment is to prevent complications and shorten the period of infectivity. FO, and complications. Scarlet fever is considered one of the non-suppurative, i.e., non-pus forming, complications of streptococcal tonsillopharyngitis. Other complications of gas infection may also occur during or following scarlet fever, especially in patients who did not receive antibiotic treatment. Non-suppurative. Scent post-streptococcal glomerulonephritis. Acute rheumatic fever, rare, Sydenham chorea. Pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections, PANDAS. 6. Copyright definition: a rare disorder that is characterized by sudden onset or exacerbation of obsessive-compulsive disorder, OCD, and/or a tic disorder following infection with S. pyogenes. O pathophysiology equals not fully understood. Preceding gas infection results in an abnormal immune response, with development of cross-reactive, antineuronal antibodies. 7. Degree clinical features: abrupt onset or exacerbation of symptoms of OCD and/or a tic disorder. Possible additional behavioral changes: enuresis, separation anxiety disorder, regression in learning and handwriting ability. Copyright diagnostic criteria. 6. Equals presence of OCD and/or a tic disorder equals onset during childhood equals acute onset and episodic course. Temporal association with streptococcal infection. Neurological abnormalities during episodes, example motoric hyperactivity. Choreiform movements of fingers/toes. O treatment equals antibiotic eradication of gas equals cognitive behavioral therapy and pharmacologic treatment for OCD and tic disorder suppurative, i.e., pus forming. Cervical lymphadenitis, retropharyngeal or peritonsillar abscess. Scent otitis media. Scent sinusitis, mastoiditis. We list the most important complications. The selection is not exhaustive. OSRO, IEEE. Tips and links. Sources. Last updated January 5, 2022. Back collapse fine text outline. Scarlet fever, 1/1. Scarlet fever second disease, scarlatina. Pathogen group A, beta hemolytic, streptococcus, exotoxins, 4_. Law. Complications: acute rheumatic fever post-streptococcal glomerulonephritis. Treatment: antibiotics, example penicillin. Vaccine: none. Incubation period: PMENS. Contagious period with antibiotics: without antibiotics exposure. Onset of exanthem. Scarlet fever fact sheet. Copyright Embellished. Phi C8. Exanthem / initially pale red, Weox maculopapular, BVN. Small spots, at AF equals. Cervical 4E lymphadenopathy and EA. Pasty lines. Time. Flushed face with perioral pallor. Enanthem of soft palate, initially white coating on tongue, strawberry tongue in further course. G. Reduced general condition. I. High fever. #Y. Abdominal pain. I. Nausea. Acute tonsillopharyngitis VV. There is tonsillar erythema and edema bilaterally and a petechial enanthem of the soft palate. Source, ID hashtag, 3183, CDC/Heinz F. Eichenwald, MD, Centers for Disease Control and Prevention licensed under public domain. Euro scarlet fever, 2/7. Scarlet fever. Upper body of a child showing an elevated, maculopapular, fine exanthem, which is spread evenly over the patient's torso. Combined with characteristic findings such as tonsillopharyngitis, flushed cheeks with perioral pallor, and a strawberry tongue, this finding indicates scarlet fever. The disease is caused by exotoxins produced by group A B hemolytic streptococci. Source, courtesy of Dr. Gary M. White MD. Scarlet fever, 3/7. Skin manifestations in scarlet fever VV. The typical scarlet-colored, fine, maculopapular exanthem of scarlet fever is seen on the right arm. Flushed cheeks and perioral pallor are also evident. Source, Scarlet Fever by Beto Badop, Wikimedia Commons, licensed under CC by SA 3.0. Modifications, pixelated eyes. Strawberry tongue VV. Bright red tongue with papillary hyperplasia. Strawberry tongue may be seen in various conditions, example scarlet fever, Kawasaki disease, and toxic shock syndrome. Source, Scarlatina tongue by SYNT Grisha, Wikimedia Commons, licensed under CC by SA 4.0. White strawberry tongue VV. Enlarged, reddened papillae resembling a strawberry protrude through a white coating of keratinized epithelium. A white strawberry tongue is commonly seen in patients with group A streptococcal pharyngitis, scarlet fever, toxic shock syndrome, Kawasaki disease, and MIS-C. Source, Scarlatina biofag-azizova, Wikimedia Commons, licensed under CC by SA 3.0. Perioral pallor in scarlet fever VV. Typical red, flushed cheeks with perioral pallor in a child with scarlet fever. Source, Scarlet Fever by Alicia Williams, Istria, Wikimedia Commons, licensed under CC by SA 2.5. Modifications, pixelated eyes. Desquamation in scarlet fever VV. Palms showing lamellar desquamation of the skin, skin glove. Desquamation typically occurs in the 2 and D4th week of the disease. The face and trunk typically show pityriaciform scales. Source, Charlach, Yasmin Feth, Wikimedia Commons licensed under public domain. Scarlet fever, 1/1. Wet. Measles, scarlet fever, rubella, erythema, infectiosum, roseola, varicella, German measles, 5th disease, 6th disease, chicken pox. Classic pediatric exanthem diseases VV. Many infectious diseases in children present with a rash, exanthem. The distribution and morphological characteristics of the exanthem allow the diseases to be differentiated from one another. Measles, patients present with a dark red, erythematous, maculopapular, partially confluent exanthem, which spreads from behind the ears to the rest of the body. Scarlet fever, patients present with a fine, light red, maculopapular rash. The exanthem begins on the neck and disseminates to the whole body. The patient's face may be red with perioral sparring. After 1 to 2 days, the exanthem becomes scarlet-colored, and partially confluent. The rash is most pronounced in the axilla and groin. Non-blinking petechiae, pastia lines, may be present. Rubella, German measles patients typically present with a non-confluent, pink, maculopapular exanthem, which, like measles, extends from behind the ears to the rest of the body. Phi F F is R /IE1 IPY4 key F /me F foot yen et yen, x yabia *= degree. And J. slash, AUPI. Measles, scarlet fever, rubella, erythema infectiosum, roseola, varicella, German measles, 5th disease, 6th disease, chicken pox. Classic pediatric exanthem diseases VV. Erythema infectiosum, 5th disease, a confluent, maculopapular rash appears only in % of patients. It may take on a lace-like, reticular appearance over time. Additionally, patients present with diffuse redness of the face with perioral sparing, slapped cheek rash. Roseola infantum, 6th disease, 3 days of high fever are followed by a sudden decrease in temperature and development of a patchy, rose-pink, macular exanthem. The rash originates on the trunk and neck, and may spread to the face and extremities in some cases. Varicella, chickenpox. The exanthem affects the whole body, typically spreading to the scalp as well. Various stages of the rash occur simultaneously, which leads to the characteristic clinical finding known as starry sky. Copyright Embellished. X. Coxsackie virus infections. Coxsackie viruses are a group of RNA viruses with over 20 serotypes. Depending on specific viral characteristics, these serotypes are further divided into groups A and B. Infection is associated with a wide range of symptoms, which are dependent on the exact serotype. Hand, foot, and mouth disease, HFMD, and herpangina are commonly caused by group A Coxsackie viruses, while pleurodynia and myocarditis are caused by group B Coxsackie viruses. Both groups may cause viral meningitis, conjunctivitis, or pneumonia. Diagnostic procedures and treatment should be tailored to the specific disease manifestation. Epidemiology. Worldwide distribution. Occur in all age groups. Highest incidence in infants and young children. 7 VO. OES. Etiology. Pathogen, Coxsackie virus. Degree, genus, Enterovirus. O family, P. cornaviridae. Copyright over 20 serotypes, divided into Group A and Group B Coxsackie viruses. O. Single-stranded RNA virus. Route of transmission. Copyright airborne droplets. O. Fecal oral route. 7a. Disease manifestations. Coxsackie A virus infection, 3. Herpangina. Definition, seasonal acute infection that manifests with fever, sore throat, and herpes-like lesions on the posterior oropharynx and tonsils. Epidemiology. EO most common in children between the age of 3 to 10 years. Copyright occurs predominantly in summer and fall. Clinical features. Copyright high fever, sore throat. O herpes-like oral lesions. Pharyngeal and tonsillar redness. Later stages, fibrin-covered ulceration. Diagnosis, based on clinical features. Treatment, supportive care, example ibuprofen for pain relief, parenteral rehydration in dehydration, since the condition is typically self-limiting. FM. Hand, foot, and mouth disease. Definition, highly contagious infection that manifests with a characteristic maculopapular/partially vesicular rash on hands and feet. Clinical features. Back collapse. Fine text outline. Multiple 1 mm vesicles located on the posterior oropharynx and tonsils. NA pharyngeal and tonsillar redness. Later stages, fibrin-covered ulceration. Diagnosis, based on clinical features. Treatment, supportive care, example ibuprofen for pain relief, parenteral rehydration in dehydration, since the condition is typically self-limiting. Hand, foot, and mouth disease. Definition, highly contagious infection that manifests with a characteristic maculopapular/partially vesicular rash on hands and feet. Clinical features. O fever, malaise. Copyright maculopapular and partially vesicular rash on the hands and feet, can also involve the buttocks. M. Copyright oral ulcers. Copyright anorexia, oral pain. Diagnosis, based on clinical features. Treatment, symptomatic. Prognosis, almost always self-limiting. 1e. Other manifestations. Conjunctivitis. Coxsackie B virus infection, degree. Pleurodynia 41. Scent definition: acute illness characterized by fever and/or other flu-like symptoms and painful spasms of the chest and upper abdomen due to irritation of the pleura and muscles. Clinical features: flu-like symptoms, sudden thoracic and upper abdominal pain caused by irritation of the pleura and muscles. Scent diagnosis degree: clinical copyright viral culture or PCR, throat or stool sample. Serological testing copyright creatine kinase may be elevated. 5 Scent treatment: symptomatic scent prognosis, self-limiting. Other manifestations: myocarditis, scent pericarditis, scent dilated cardiomyopathy. Coxsackie B is the most common cause of viral myocarditis. Coxsackie A and B virus infection. Scent viral meningitis, encephalitis, pneumonia. GAO. Tips and links. Sources: last updated October 27, 2021. Back collapse, fine text outline. Herpangina. Several small vesicles and partially confluent yellow-white ulcers with an erythematous rim are visible on the inflamed soft palate. This is the typical appearance of herpangina, an infection caused by the Coxsackie A virus. The ananthem typically starts as painful, herpes-like vesicles on the oropharynx that then break down to form shallow, painful ulcers. Source: copyright IMPP. Herpangina VV. Oral cavity of a female with fever and odynophagia. Multiple white vesicles 1 to 2 mm in diameter and an erythematous rim can be seen on the uvula, soft palate, and tonsillar pillars. These herpes-like vesicles on the posterior oropharynx are characteristic of herpangina, a Coxsackie virus infection mostly seen in young children. Source: Herpangina 2016 by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 4.0. Coxsackie virus infections, 3/6. Hand, foot, and mouth disease VV. Solace of the feet of a child. Macular, vesicular lesions on an erythematous base are visible on the toes and the solace of the feet. This rash is typical in hand, foot, and mouth disease. Source: hand, foot, and mouth disease on child feet by Engafra, Wikimedia Commons, licensed under CC by SA 3.0. Coxsackie virus infections, 4/6. Skin lesions in hand, foot, and mouth disease VV. 12-month-old infant. Typical white-gray blisters with a diameter of approximate 3 to 5 mm surrounded by an erythematous halo are seen on the fingers. Top images. Another common finding, as seen here, is a disseminated maculopapular rash on the upper and lower legs, bottom left. In addition, there is a partially crusted papulovesicular rash in the perioral region, bottom right. However, the eponymous involvement of the mouth refers to the typically painful aphthous ananthem of the oral mucosa, which is not shown here. Copyright Emboss. Hand, foot, and mouth disease VV. Hands and feet of a 36-year-old male patient. Maculopapular lesions are visible on the inner surface of the hands and feet. The localization in conjunction with the ananthem of the mucous membranes is typical of hand, foot, and mouth disease. The characteristic vesicles are not frequently formed in adulthood. Source: hand-foot-mouth disease adult 36 years by Klatchmanacker, Wikimedia Commons, licensed under CC by SA 3.0. Hand, foot, and mouth disease VV. Mouth and the tongue of a child. There is an ulcer on the tip of the tongue, which is uncommon in hand, foot, and mouth disease, which usually manifests with lesions around the lips and/or the back of the throat besides the hands and feet. Source: courtesy of Dr. Gary M. White MD. Impetigo. Impetigo is an infectious, predominantly pediatric skin disease caused by the bacteria Staphylococcus aureus or, less commonly, Streptococcus pyogenes. There are both bullous and non-bullous variants. The disease causes honey-colored, crusted lesions with surrounding erythema and typically affects the face, but may also manifest on the extremities. While the diagnosis is usually made based on clinical findings, it can be confirmed with a bacterial culture. The first-line treatment for mild impetigo is a topical antibiotic, mupirocin, which typically resolves the infection without complications. An additional systemic antibiotic may be indicated in more severe cases. VA. OE. Epidemiology. Age copyright primarily affects children, especially between 2 to 6 years of age. Impetigo is highly contagious and can cause epidemics in preschools or schools. 2% prevalence, high in resource-limited countries. And impetigo is the most common bacterial skin infection among children. Epidemiological data refers to the U.S., unless otherwise specified. ELCO. Etiology. Pathogens, superficial bacterial skin infection. Copyright Staphylococcus aureus, 80% of cases equals causes both bullous impetigo and non-bullous impetigo equals S. aureus strains that produce exfoliative toxins A and B are responsible for bullous impetigo. 3L4 Copyright Streptococcus pyogenes, gas 10% of cases, causes non-bullous impetigo only O. aureus and gas co-infection, 10% of cases scent predisposing factors O. warm and humid climate. Copyright crowded, unsanitary living conditions. Copyright poor personal hygiene O. medical conditions pre-existing skin lesions, example atopic dermatitis, scabies, insect bites, abrasions, eczema, equals diabetes mellitus. Scent route of infection. Copyright primary impetigo, bacterial infection of previously healthy skin. Copyright secondary impetigo, impetigenization secondary infection of pre-existing skin lesions. OO. And clinical features. Most effects of impetigo, non-bullous impetigo WS bullous impetigo MS. Epidemiology, 7_+70% of cases *30% of cases. Papules, which turn into small vesicles surrounded by erythema, and /or pustules. Degree vesicles and pustules can rupture scent vesicles that grow to form large, flaccid bullae, which go on to rupture and form thin lesions. Copyright oozing secretion that dries forms honey-colored crusts that heal without brown crusts. Scarring *- Nikolsky sign. Back collapse. Fine text outline. Clinical features. Most I of impetigo SLL6, non-bullous impetigo AE bullous impetigo MW. Epidemiology 1+70% of cases *30% of cases. Scent papules, which turn into small vesicles surrounded by erythema Ca and /or pustules. Copyright vesicles and pustules can rupture plus vesicles that grow to form large, flaccid bullae, which go on to rupture and form thin lesions. Copyright oozing secretion that dries forms honey-colored crusts that heal without brown crusts. Scarring *- Nikolsky sign may be pruritic, especially pustules, but is rarely painful. 8, *- Nikolsky sign 9. Face, most common, especially around the nose and mouth. Distribution, on, ESPY scent trunk and upper extremities. Pattern extremities. Other findings regional lymphadenopathy systemic signs, example fever, malaise, weakness, in severe cases. Rare manifestation, ecthyma. A copyright ulcerative impetigo that extends into the dermis. Copyright manifests as a coin-sized, superficial ulcer with a punched-out appearance. Impetigo should be suspected in children presenting with honey-colored crusts around the mouth and nose. Diagnostics. Scent generally diagnosed based on clinical presentation *, microbiological culture. 4 Copyright assists with detection of the causative pathogen. Copyright indications, inconclusive diagnosis, recurrence despite treatment. Differential diagnoses. See differential diagnosis of scaling. I11. See blistering skin diseases. Scent conditions that cause localized inflammation. Degree: atopic dermatitis, contact dermatitis, seborrheic dermatitis, cutaneous candidiasis, tinea I, herpes simplex virus infection, erysipelas folliculitis. Degree: scent conditions that cause Bullia pemphigus vulgaris and Bullous pemphigoid. Copyright Bullous drug reactions. Copyright insect bites or burns. Copyright varicella. The differential diagnoses listed here are not exhaustive. OB. SN. Back collapse. Fine text outline. WA. And. Differential diagnoses. C. Differential diagnosis of scaling, 5IL11C. Blistering skin diseases. Asterisk: conditions that cause localized inflammation. O. Atopic dermatitis. Copyright contact dermatitis. Copyright seborrheic dermatitis. O. Cutaneous candidiasis. O. Tinea I. O. Herpes simplex virus infection. O. Erysipelas. Copyright folliculitis. Scent conditions that cause Bullia pemphigus vulgaris and Bullous pemphigoid. Copyright Bullous drug reactions. Copyright insect bites or burns. Copyright varicella. The differential diagnoses listed here are not exhaustive. Vis. OCs. Treatment. Scent: general, wound cleansing with antibacterial washes, example chlorhexidine, mild non-bullous impetigo, single lesions or small areas affected. Topical antibiotics, mupirocin, retopimulin. Scent: bullous impetigo, ecthyma, or severe non-bullous impetigo, widespread dispersion, numerous lesions, and or fever. O. First-line treatment: 1. First-generation cephalosporins, example cephalexin or dicloxacillin 10N21E. Alternative, amoxicillin clavulinate, macrolides. Copyright if MRSA infection is confirmed or suspected. 4:1, clindamycin, trimethoprim sulfamethoxazole, doxycycline 10. 7 CE. Complications. Scent in gas infections, acute post-streptococcal glomerulonephritis, PSGN, very rarely, staphylococcal scalded skin syndrome, SSSS, superinfection. 9. We list the most important complications. The selection is not exhaustive. GCE. Prevention. Advise patients and caregivers to wash hands regularly. Scent: to prevent the spread of the disease, children should receive antibiotic treatment for at least 24 hours before returning to daycare or school. FOOE. Tips and links. Sources. Last updated August 5, 2022. Back collapse. Fine text. Al. Outline. 4 cents *EL and F. WY. Non-bullous impetigo. Confluent erosions and honey-colored crusts with an erythematous base are visible on the face, forehead, temporal region, and part of the neck. As in this photo, vesicles may not always be present or noticeable. Source: copyright IMPP. Non-bullous impetigo VV. Confluent erosions with honey-colored crusts are visible on the left foot of this patient. Source: Impetigo pied by Group Ogre, Wikimedia Commons, licensed under CC by SA 3.0. Non-bullous impetigo. A round, well-demarcated erythematous plaque with yellowish crusts is visible on the child's chin. Source: Impetigo new photo for help diagnoses.jpg by Masrai, Wikimedia Commons, licensed under CC by SA 4.0. Impetigo. Confluent scabbed erosions and honey-colored crusts are visible in the perioral region. This appearance is typical of impetigo, which, in this patient, developed secondary to pre-existing eczema and immunosuppression caused by HIV infection. Source: Figure 3, in Atlas of Pediatric HIV Infection by R.E. Oladikan, R.J. Leloania, C. Halila et al., Open Books, University of Cape Town, licensed under CC by ND 4.0. O in impetigo, 5/7. Bullous impetigo VB. Multiple vesicles, some of which have already ruptured and formed brown crusts, are visible on the gluteal region of this infant. The lesions in bullous impetigo are easily confused with the polymorphic rash of secondary syphilis. Source, ID #5154, CDC, Centers for Disease Control and Prevention licensed under public domain. Bullous impetigo VB. Multiple vesicles and bullae are visible on the arm of this patient. In bullous impetigo, staphylococci in the epidermis release an exotoxin, which causes acantholysis and results in blister formation in the upper epidermis. Source, Impetigo contagiousum bulbus impetigo new photo for diagnosis.jpg by Mass Rai, Wikimedia Commons, licensed under CC by SA 4.0. Ecthyma VV. The right leg of an adolescent male patient, multiple superficial, coin-sized ulcers with a punched-out appearance and surrounding erythema are visible. This is the typical appearance of ecthyma, an ulcerative type of impetigo that extends into the dermis. Source, courtesy of Dr. Gary M. White MD. X. Staphylococcal scalded skin syndrome. Staphylococcal scalded skin syndrome, SSSS, is a potentially serious acute skin condition caused by the exfoliative toxins of Staphylococcus aureus and typically affects infants and young children. It is usually preceded by a mucocutaneous staphylococcal infection, such as pharyngitis or bullous impetigo, though this preceding infection may go unnoticed by patients and other caregivers. Following systemic dissemination of toxins from the local infection, SSSS itself typically begins with skin tenderness, erythema, and fever. This is followed a day or two later by flaccid blisters and sloughing off of the superficial layer of skin to reveal moist, red tissue underneath, giving the area a scalded-looking appearance. Mucous membranes are spared. A presumptive diagnosis of SSSS is based on clinical findings. Biopsy is only performed in unclear cases and shows separation of the epidermis at the granular layer. Treatment involves the administration of antibiotics and potential intensive care. Monitoring. The prognosis is generally good, and blisters heal without significant scarring. WA. CE. Epidemiology. * rare condition, 8 per 1 million children, J-cent primarily affects infants and young children between 6 months and 5 years of age, peak incidence, 2 to 3 years, 2, rare in adults, may occur in adults with predisposing conditions, example impaired renal function or immunosuppression. 3 epidemiological data refers to the U.S., unless otherwise specified. O2SI. Etiology. E-pathogen E. Staphylococcus aureus strains that produce exfoliative toxins O. Exfoliative toxin A and B have been shown to cleave desmoglein 1 in the granular layer of the epidermis. Disruption of keratinocyte attachments 4% route of infection, dissemination of toxins from a local infection. Copyright following a staphylococcal infection elsewhere, example skin, mouth, nose, throat, GI tract, umbilicus. The initial infection may also be completely undetected. Copyright following bullous impetigo. SSSS belongs to the spectrum of diseases mediated by specific staphylococcal toxins, which also includes bullous impetigo, toxic shock syndrome, TSS, and Staphylococcus aureus food poisoning. Unlike TSS, SSSS does not have systemic manifestations, involvement of, example liver, kidney, bone marrow, CNS. WA. And. Clinical features. Initially 51. Scent fever, malaise, and irritability. Scent skin tenderness. Scent diffuse or localized erythema, often beginning periorally, after 24 to 48 hours. 5. Plus flaccid, easily ruptured blisters that break to reveal moist, red skin beneath, i.e., with a scalded appearance, widespread sloughing of epidermal skin scent Nikolsky sign is positive scent no mucosal involvement scent cracking, and crusting is common signs of shock, hypotension, tachycardia. At Stevens-Johnson syndrome and toxic epidermal necrolysis manifest with mucosal involvement, SSSS does not. Back collapse fine text outline. XX staphylococcal scalded skin syndrome. Diagnostics. The presumptive diagnosis of SSSS is made based on clinical findings. Cultures, example blood or nasopharynx, are usually taken for confirming the diagnosis, and a biopsy may be performed to exclude suspected differential diagnoses but is usually not required. Scent history, localized staphylococcal infection, example pharyngitis, bullous impetigo, scent laboratory tests, to confirm the diagnosis. 6. OTWBC's OTES are copyright cultures of potential sites of preceding infection, blood, urine, abnormal skin, nasopharynx, umbilicus, or any other suspected focus, scent biopsy, indicated in unclear cases, especially when Stevens-Johnson syndrome, SJS, or toxic epidermal necrolysis. 10. Are suspected copyright intraepidermal fissure and blister formation at the granular layer copyright lack of inflammatory cell infiltrate scent imaging, such as chest X-ray to rule out pneumonia as an original source of infection. OCE. Differential diagnoses. Diff-EL diagram. Of severe GADV skin conditions, SSSS Stevens-Johnson syndrome, SJS, toxic epidermal necrolysis. 10. Age of typical OM. OO patient children. Infectious, exfoliative toxins, S. Etiology adverse drug reaction aureus. Scent sloughing of skin sloughing of skin sloughing of skin scent positive Nikolsky sign scent positive Nikolsky sign scent positive Nikolsky sign clinical features IFI, scent perioral erythema and crusting degree M22 no BI typically 30% of total body surface area is affected. Eosinophilic full thickness epidermal necrosis involvement of the dermal epidermal degeneration and blistering of stratum basale of epidermis subepidermal intraepidermal blistering blister Rs lack of inflammatory infiltrate, 5,5p junction eosinophils and mononuclear infiltrate in the papillary dermis, cell pore infiltrate, sparse, and with lymphocytes. Biopsy. The differential diagnoses listed here are not exhaustive. WI. CE. Treatment. Scent hospital admission 5.0 necessary in most cases copyright isolation recommended copyright severe cases, example large areas of sloughed off skin, may be treated in the burn unit or intensive care unit. Copyright outpatient treatment is possible in older children who are eating and drinking well and have minimal skin involvement. Scent for antibiotic copyright penicillinase-resistant penicillins are the drug of choice, nafcillin, oxacillin copyright vancomycin, in areas with high community-acquired MRSA prevalence, or in patients who do not respond to treatment. Scent supportive care copyright fluid rehydration as indicated supportive skin care, emollients, covering sloughed off skin ONSAIDS as indicated for pain and fever. Steroids are contraindicated, as the etiology of SSSS is infectious. OOE equals QL. Collapse fine text outline. X staphylococcal scalded skin syndrome. Differential diagnoses. Differential diagram. Of severe eye skin conditions, SSSS Stevens-Johnson syndrome, SJS, toxic epidermal necrolysis. 10. Age of typical, M. Patient scent children. Infectious, exfoliative toxins, S7 etiology scent adverse drug reaction aureus. Asterisk sloughing of skin, asterisk sloughing of skin, scent positive Nikolsky sign, scent positive Nikolsky sign, scent positive Nikolsky sign. Clinical features equals equals scent perioral erythema and crusting. Degree 22 no I asterisk typically 30% of total body surface area is affected. Eosinophilic full thickness epidermal necrosis. Scent degeneration and blistering of stratum basale of epidermis subepidermal. Biscent intraepidermal blistering and Grayer's asterisk involvement of the dermal epidermal iopsule asterisk lack of inflammatory infiltrate junction eosinophils and mononuclear infiltrate in the papillary dermis cell poor infiltrate, sparse, and with lymphocytes. The differential diagnoses listed here are not exhaustive. OO. OE. Treatment. Scent hospital admission 5.0 necessary in most cases copyright isolation recommended copyright severe cases, example large areas of sloughed off skin, may be treated in the burn unit or intensive care unit. Copyright outpatient treatment is possible in older children who are eating and drinking well and have minimal skin involvement. Scent for antibiotic copyright penicillinase resistant penicillins are the drug of choice, nafcillin, oxacillin copyright vancomycin, in areas with high community-acquired MRSA prevalence, or in patients who do not respond to treatment. Scent supportive care copyright fluid rehydration as indicated O supportive skin care, emollients, covering sloughed off skin ONSAIDs as indicated for pain and fever. Copyright steroids are contraindicated, as the etiology of SSSS is infectious. EO. CE. Complications. The complications faced by SSSS patients are similar to those of patients with burns, as both have a compromised skin barrier, scent fluid and electrolyte imbalances, scent thermal dysregulation, secondary infections, example pneumonia, sepsis. We list the most important complications. The selection is not exhaustive. WA. FO. Cs. Prognosis. Asterisk mortality rate 7 copyright in children, 60% scent blisters heal completely, without scarring, as skin cleavage is intraepidermal. Back collapse fine text outline. Urostaphylococcal scalded skin syndrome, 1/4. Staphylococcal scalded skin syndrome. Perioral, cervical, and axillary reddening of the skin is visible, resulting in a scalded appearance on this child's face. In some areas, the superficial epidermal layer is detached, example on the chin. On the right side of the neck, several flaccid blisters can be seen. The lips appear dry, with several regades in the corners of the mouth. Source, courtesy of Dr. Gary M. White MD. Urostaphylococcal scalded skin syndrome, 2/4. EESE. Staphylococcal scalded skin syndrome, perioral involvement. Perioral region of a boy presenting with fever and painful blisters on his skin. There is diffuse erythema of the perioral region, skin, and neck. Evidence of ruptured blisters is visible on the chin, angles of the mouth, the right perinasal region, and below the right eye. Erythema and painful superficial blisters are the characteristic features of staphylococcal scalded skin syndrome, a condition caused by the exfoliative toxins of S. aureus that cleave the desmoglein 1 complex responsible for anchoring skin cells. Source, courtesy of Dr. Gary M. White MD. Urostaphylococcal scalded skin syndrome, 3/4. Staphylococcal scalded skin syndrome. Axillary region of a 2-month-old infant with a 2-day history of fever, irritability, and diffuse erythema. There is diffuse erythema of all visible skin. A large ruptured superficial blister is visible on the medial aspect of the arm. A flaccid blister and numerous vesicles can be seen on the lateral chest wall. On palpation, the superficial epidermis is easily separated from the underlying skin, with minimal lateral traction. These features are characteristic of staphylococcal scalded skin syndrome, a condition that is typically seen in infants or young children and often preceded by an infection, example URTI. It is caused by the exfoliative toxins of S. aureus that cleave the desmoglein 1 complex responsible for anchoring skin cells. Source: courtesy of Dr. Gary M. White MD. Urostaphylococcal scalded skin syndrome, 4/4. Staphylococcal scalded skin syndrome, SSSS, VV. There is diffuse erythema of all visible skin. Large ruptured blisters are visible on the left lower leg, and a large flaccid unruptured blister can be seen on the left buttock. Source: Figure 1, in Staphylococcal scalded skin syndrome in neonate by K. Kauka, M. E. Daingai, K. Cassie, Case Reports in Dermatological Medicine, licensed under CC by 3.0. X. Molluscum contagiosum. Molluscum contagiosum is a common localized skin infection caused by the Molluscum contagiosum virus that often occurs on the trunk, face, and genitalia. It is more common in childhood as well as early adolescence, particularly in males, and is usually transmitted at this age via skin contact and auto-inoculation. In adults, it is considered a sexually transmitted infection. Lesions appear as smooth, dome-shaped papules with central umbilication. In healthy patients, molluscum contagiosum is generally self-limiting and heals spontaneously after several months. However, in immunosuppressed individuals, lesions can be very large, widespread, and persistent. If treatment is indicated, example for sexually transmitted molluscum contagiosum, cryotherapy with liquid nitrogen is usually the first treatment option. OO. OE. Epidemiology. Degree sex, $7 age, most common in childhood, peak incidence. OS. CE. Etiology. Pathogen, a DNA poxvirus, molluscum contagiosum virus, scent transmission, copyright direct skin contact, contact sports, sexually transmitted, copyright auto-inoculation, scratching or touching lesion, example while shaving, ophomites, example on bath sponges/towels, plus risk factors, immunosuppression, active atopic dermatitis, in children, hot and humid climates, crowded living conditions, 2. 6. Suspect AIDS if large, persistent, widespread lesions appear on an adult. Clinical features. Scent incubation period, 2 to 6 weeks. Physical examination, single or multiple lesions in healthy patients, especially widespread in immunocompromised patients. 3. Non-tender, skin-colored, pearly, dome-shaped papules with central umbilication. Individual lesions may also be painful or pruritic. Copyright usually 2 to 5 mm in diameter. Giant lesions, 15 mm, are encountered in immunocompromised patients. Copyright papules contain a caseous plug. Predilection sites, copyright in children, face copyright, trunk copyright, and extremities, example axilla, antecubital and popliteal fossa, copyright in adults, lower abdomen, groin, genitalia, and proximal thighs. Copyright. Chronic follicular conjunctivitis may occur as molluscum contagiosum viral particles spread into the conjunctiva of the eye. See molluscum contagiosum conjunctivitis. 4. IS. DS. Diagnostics. Clinical diagnosis. 5. Seek out underlying etiologies, i.e., HIV testing, if lesions in adults and/or widespread RRSNA. Back collapse. Find text outline. Diagnostics. Clinical diagnosis. 5. Seek out underlying etiologies, i.e., HIV testing, if lesions in adults and/or widespread. A biopsy is usually not necessary, but consider in cases of immunosuppression, as the diagnostic differential is wide. See differential diagnosis below. Pathology. Histology. Scent localized to the epidermis. Scent H and E stained sections demonstrate the following: copyright acanthosis, thickened epidermis, copyright cup-shaped invagination, the epidermis invaginates into the dermis, O molluscum bodies, keratinocytes with eosinophilic intracytoplasmic inclusion, bodies containing viral particles. Differential diagnoses. Cutaneous cryptococcosis, cutaneous histoplasmosis, cutaneous aspergillosis, condyloma acuminatum, condyloma dilata, keratoacanthoma verruca vulgaris. Scent flat warts. The differential diagnoses listed here are not exhaustive. Treatment. Spontaneous remission of the lesions usually happens within a few months, thus, treatment is often unnecessary. SILS. Scent. Consider treatment for copyright sexually transmitted molluscum contagiosum, copyright immunocompromised individuals, O immunocompetent children upon parental request. Scent. Treatment modalities. O physical equals cryotherapy is often the first-line treatment for adolescents and adults as it is better tolerated than in children. Curettage 1. O pharmacological equals topical cantharidin equals podophyllitoxin equals topical imicamod CJ have been used to successfully treat immunocompromised patients with refractory disease, in some cases copyright for immunocompromised individuals with severe and/or refractory disease equals cidofovir equals interferon A. Back collapse. Find text outline. X molluscum contagiosum. Histology 31. Scent localized to the epidermis. Scent H and E stained sections demonstrate the following: copyright acanthosis, thickened epidermis, copyright cup-shaped invagination, the epidermis invaginates into the dermis, O molluscum bodies, keratinocytes with eosinophilic intracytoplasmic inclusion, bodies containing viral particles. Differential diagnoses. Cutaneous cryptococcosis, cutaneous histoplasmosis, cutaneous aspergillosis, condyloma acuminatum, condyloma dilata, keratoacanthoma verruca vulgaris. Scent flat warts. The differential diagnoses listed here are not exhaustive. 6. Row shared notes. Manage. Treatment. Spontaneous remission of the lesions usually happens within a few months, thus, treatment is often unnecessary. 3I5 Consider treatment for OM copyright sexually transmitted molluscum contagiosum, copyright immunocompromised individuals, O immunocompetent children upon parental request. Scent treatment modalities. O physical equals cryotherapy is often the first line treatment for adolescents and adults as it is better tolerated than in children. Equals curettage. O pharmacological equals topical cantharidin 1 equals podophyllitoxin equals topical imicamod CJ have been used to successfully treat immunocompromised patients with refractory disease, in some cases copyright for immunocompromised individuals with severe and/or refractory disease equals cidofovir equals interferon A. OG. Root of. Complications. Scarring, hypopigmentation * secondary bacterial infections. We list the most important complications. The selection is not exhaustive. 224. Back collapse. Find text outline. Molluscum contagiosum VV. Several singular and partially confluent papules with central umbilication are visible at the lateral orbital rim. These features are characteristic of molluscum contagiosum due to infection with molluscum contagiosum virus, Poxvirus. Source: copyright IMPP. Molluscum contagiosum and oral candidiasis VV. Molluscum contagiosum, multiple singular and partially confluent encrusted papules with central umbilication are visible, primarily on the right cheek and periorbital region. Oral candidiasis, white plagues are visible on the tongue. The combination of these conditions, along with the severity of the molluscum contagiosum, are likely secondary to immunosuppression in this HIV-positive patient. Source: Figure 2, in Ophthalmic Manifestations of HIV Patients in a Rural Area of Western Maharashtra, India by Pratik Y. Gogri, Somen L. Misra, Raghunandan and Kothari 3, Akshay J. Bhandari 2 and Hitesh V. Gidwani 4, International Scholarly Research Notices, licensed under CC by 3.0. Molluscum contagiosum, 3/7. Molluscum contagiosum in a child. Abdomen and groin of a young girl showing grouped, skin-colored papules with central umbilication. Source: copyright IMPP. Molluscum contagiosum, 4/7. Molluscum contagiosum VV. Left anterior thigh of a young girl. Several individual papules with central umbilication can be seen. Source: Molluscum contagiosum by GZZZ, Wikimedia Commons, licensed under CC by SA 4.0. Overlay. Molluscum contagiosum with concomitant conjunctivitis VV. Right eye several papules, green overlay, with central umbilication are visible on the eyelid and in the periocular region. Conjunctival injection is also present. These findings are consistent with molluscum contagiosum with concurrent conjunctivitis. Source: copyright IMPP. Molluscum contagiosum, 6/7. Disseminated molluscum contagiosum infection. Skin-colored papules with central indentation are visible above this patient's left eye. Source: copyright IMPP. Molluscum contagiosum VV. Multiple small, pearl-like and dome-shaped lesions with central umbilication are disseminated around lips and chin of this 6-year-old girl. Source: Figure 38, in Atlas of Pediatric HIV Infection by Regina E. Oladican, Raniko J. Leloania, Carol Hlila et.al., Oakpen Books, licensed under CC by ND 4.0. Overlay. Molluscum contagiosum virus VV. Photomicrograph of a skin tissue sample, H&E stain, low magnification. An infection with the molluscum contagiosum virus may result in thickened stratified, squamous epithelium, example indicated by blue overlay, with cup-shaped invaginations of the epidermis into the dermis, examples indicated by yellow overlay. As seen here, invaginations can appear detached from the surface, examples indicated by dashed outline. Invaginations include keratinocytes with eosinophilic intracytoplasmic inclusion bodies containing viral particles, examples indicated by dashed blue overlay. Source: copyright IMPP. Overlay. Molluscum contagiosum, epidermis VV. Photomicrograph of a skin tissue sample, H&E stain, very high magnification. Epidermal changes seen in infection with the molluscum contagiosum virus are displayed. The stratum granulosum, yellow overlay, and stratum corneum, blue overlay, contain the characteristic eosinophilic intracytoplasmic inclusion bodies, molluscum bodies or Henderson-Patterson bodies, examples indicated by blue dashed overlay, containing viral particles. Source: copyright IMPP. Overlay. Molluscum contagiosum, epidermis VV. Photomicrograph of a skin tissue sample, H&E stain, very high magnification. Epidermal changes seen in infection with the molluscum contagiosum virus are displayed. The stratum granulosum, yellow overlay, and stratum corneum, blue overlay, contain the characteristic eosinophilic intracytoplasmic inclusion bodies, molluscum bodies or Henderson-Patterson bodies, examples indicated by blue dashed overlay, containing viral particles. Source: copyright IMPP. X. Herpes simplex virus infections. Herpes simplex virus infections may be caused by two virus genotypes, herpes simplex virus type 1, HSV1, and herpes simplex virus type 2, HSV2. Worldwide seroprevalence is high, with antibodies detectable in over 90% of the population. Of these cases, approximate 60% are caused by HSV1. The most common infections are labial and genital herpes, which present with painful ulcerations. Two further conditions, seen especially in children, are herpetic gingivostomatitis and herpetic whitlow. While herpetic gingivostomatitis is characterized by painful lesions of the oral and pharyngeal mucosa, herpetic Whitlow causes blisters on the fingers with pronounced regional lymphadenopathy. In individuals with underlying dermatological conditions, infection with HSV can cause eczema herpeticum, resulting in painful erosions spread diffusely over the head and upper body. However, the majority of primary infections remain asymptomatic, while recurrent infections present with the typical manifestations. The diagnosis of HSV infections is usually confirmed through viral cultures, but may also be based on detection of HSV DNA in PCR, or multinucleated giant cells in zinc smears. Treatment consists mainly of topical or oral acyclovir, for administration may be needed in critical cases, such as HSV infection in immunocompromised patients. OS. General information. Scent prevalence. More than 90% of the world's population over the age of 40 years carries HSV. 1 Scent types: O. herpes simplex virus type 1, HSV1, human herpes virus type 1, HHV1, O. herpes simplex virus type 2, HSV2, human herpes virus type 2, HHV2. Scent transmission. Copyright: direct contact with mucosal tissue or secretions of another infected person. Copyright: infection with HSV1 usually is acquired in childhood via saliva. HSV2 is mostly spread through genital contact and should, therefore, raise suspicion for sexual abuse if found in children. Copyright: perinatal transmission, example during childbirth if the mother is symptomatic, is more common for HSV2. Scent type of infection. Copyright: primary infection mostly asymptomatic, up to 80% of cases, but virus is still shed, equals if symptomatic, the infection is often sudden and severe with systemic symptoms, example fever, malaise, myalgias, and headaches. Copyright: reactivation of infection. Equals frequency and severity vary individually, symptoms are usually less severe than in primary infection. Equals often at the same site as primary infection. WA. CE. Pathophysiology. Scent inoculation. The virus enters the body through mucosal surfaces or small dermal lesions. Scent neurovirulence. The virus invades, spreads, and replicates in nerve cells. Scent latency. After primary infection, the virus remains dormant in the ganglion neurons. Copyright: trigeminal ganglion, HSV1. Copyright: sacral ganglion, HSV2. Scent reactivation, triggered by various factors, example immunodeficiency, stress, trauma, clinical manifestations. Scent dissemination. Copyright: infection spreads to unusual sites, example lungs, gastrointestinal tract, eyes. May occur in pregnant patients or patients with severe immunodeficiency, example malnutrition, recipients of organ transplants, patients with AIDS. VA. And. Labial herpes, herpes labialis. Pathogen: E. mostly HSV1, HSV2 in 10 to 20% of cases. EO most common recurrent HSV1 infection in adults. Scent clinical features. Copyright: prodromal symptoms, 24 hours pain, tingling, burning. Recurring, erythematous vesicles that turn into painful ulcerations, also known as cold sores, primarily affecting the oral mucosa and lip borders. Scent differential diagnoses. 2 Copyright: shingles, herpes zoster, E. aphthous ulcers. O. herpangina. Back collapse. Fine text outline. Asterisk differential diagnoses. 2 Copyright: shingles, herpes zoster, copyright: aphthous ulcers. E. O. herpangina. E. hand, foot, and mouth disease. E. candidiasis. Copyright: syphilitic chancre or chancroid. Scent diagnostics and treatment. See diagnostics and treatment below. Genital herpes, herpes genitalis. Pathogen: HSV2, HSV1, less common, E. incubation period, 2 to 12 days. Asterisk clinical findings. 3. EO most patients are asymptomatic. Copyright: skin lesions. Equals initially, redness, swelling, tingling, pain. Pruritus equals lesions with a punched out appearance that ulcerate after several days in the anogenital area equals lesions may appear as single or disseminated, painful red bumps or white vesicles. O initial infection equals nonspecific symptoms, fever, headache, malaise, myalgia, painful lymphadenopathy in the groin area, lesions in the anogenital area, see above, urinary tract, dysuria, urethritis, cervicities, urinary retention, rarely, equals white, thick, and slash or foul-smelling vaginal discharge. Copyright recurrent infection equals prodromal symptoms, hours to days prior to appearance of lesions, pain or tingling in the genitals, legs, buttocks, or hips equals genital and slash or perianal lesions, see above. Lesions are usually unilateral, less painful, and of shorter duration than during initial infection. Scent diagnostics and treatment, see diagnostics and treatment below. Scent special patient groups, for genital herpes during pregnancy, see herpes simplex virus infection in the newborn. Herpetic gingivostomatitis. Epidemiology, mainly in children, 1 to 6 years, but also immunocompromised patients, example agranulocytosis, HIV, etiology, severe manifestation of an, often primary, HSV-1 infection. Clinical features. Copyright prodrome, fever, malaise, often mistaken for teething in children. Copyright pharyngitis, cervical lymphadenopathy. Copyright gingivostomatitis, erythema and painful ulcerations on perioral skin and oral mucosa, especially on the inner cheek, soft palate, and tongue. Differential diagnoses. Copyright the same as for labial herpes. O herpetic pharyngotonsillitis, pharyngitis and tonsillitis caused by HSV-1 equals predominantly affects adults equals severe pharyngitis. Other clinical findings similar to herpetic gingivostomatitis equals ulcerations on the tonsils and pharynx, fewer on the oral mucosa. Diagnostics and treatment, see diagnostics and treatment below. Back collapse. Fine text outline. Eczema herpeticum. Synonym, also known as kappa C. varicella-form eruption, KVE, scent pathogen, most commonly HSV-1 and HSV-2. Etiology, associated with pre-existing skin conditions, most often atopic dermatitis. Scent clinical features. O fever, malaise, lymphadenopathy, extensive disseminated and painful eruptions on the head and upper body, erythematous skin with multiple, round, umbilicated vesicles that may progress to punched out erosions. Scent diagnostics and treatment, see diagnostics and treatment below. Eczema herpeticum is considered a dermatological emergency and treatment with oral or for acyclovir must be initiated quickly. CE. Herpetic Whitlow. Pathogen, HSV-1 in 60% of cases, HSV-2 in 40% of cases, in the adult population. Etiology. Copyright direct contact with infected secretions through a break in the skin, example torn cuticle. Main groups, children, via sucking of thumb/fingers, may have a history of labial herpes, healthcare workers exposed to oral secretions, example dentists, incubation period, 2 to 20 days. Scent clinical features. Copyright possibly history of fever and malaise. Copyright infection of the dermal and subcutaneous tissue. Copyright one or more fingers involved, especially the thumb and index fingers, mostly found on terminal phalanx. Copyright pain, tingling, and burning in infected finger. O finger edema. Copyright grouped, non-purulent vesicles on an erythematous base for up to 10 days. O vesicles may rupture or ulcerate. Copyright axillary and epitrochlear lymphadenopathy. Scent differential diagnoses, paronychia, cellulitis, felon. Scent diagnostics and treatment, see diagnostics and treatment below. Surgical treatment is not indicated because it may cause severe complications, example bacterial superinfection, systemic spread, herpes encephalitis. Other HSV infections. HSV-1. Scent herpes simplex encephalitis. O HSV-1 is the most common pathogen causing sporadic encephalitis in the U.S. Copyright most commonly involves the temporal lobe or manifests with altered mental status and focal neurologic deficits, example seizures, aphasia, scent viral keratitis, scent herpes esophagitis. O epidemiology, typically occurs in patients who are immunocompromised. Degree clinical features, odynophagia, dysphagia, and retrosternal chest pain. Copyright diagnostics equals endoscopy shows superficial ulcers in the mid and distal esophagus in the absence of plagues. M4. Back collapse. Find text. Outline. Copyright diagnostics endoscopy shows superficial ulcers in the mid and distal esophagus in the absence of plagues. See diagnostics and treatment below. Plus herpes gladiatorum, registered LEL. Copyright epidemiology, typically occurs in athletes that participate in close contact sports, example wrestling, rugby. Copyright incubation period, 4 to 11 days. Copyright etiology, skin lesions exposed to infected oral secretions during close contact or auto-inoculation. Copyright clinical features, multiple vesicles on an erythematous base located mainly on the head, neck, arms, and or trunk. Copyright complications, ocular manifestations, example follicular conjunctivitis, viral keratitis. HSV2. Congenital herpes simplex, neonatal herpes simplex. Scent benign recurrent lymphocytic meningitis, rare benign recurrent aseptic meningitis caused by HSV2. Affected patients have recurrent episodes of meningitis, headache, meningismus, with transient neurological symptoms, in 50% of cases. Copyright most patients have spontaneous remission of symptoms and no permanent neurological sequelae. Both. Scent HSV conjunctivitis, including neonatal HSV conjunctivitis, viral meningitis, more commonly caused by HSV2 than HSV1, scent erythema multiforme. OC. ROTS. Diagnostics. Diagnosis is primarily based on clinical features, with confirmation through the following tests. Light microscopy findings on a Zank smear. Copyright detects multinucleated giant cells, nonspecific. Copyright eosinophilic intranuclear Cowdrey A inclusion bodies, nonspecific. O results available within 1 hour. O unable to differentiate between HSV1 and HSV2, also commonly positive in VZV scent viral culture. Copyright can be used to confirm the diagnosis in skin and or mucosal HSV infections. O results are available in 48 hours. Copyright the culture should be taken from a fresh vesicle, either from skin or genitals. PCR copyright detects HSV DNA, identification of virus genotype, O method of choice for CNS infections, meningitis, encephalitis, as well as for skin and mucosal lesions. CSF sample is used in patients with suspected herpes encephalitis or meningitis. Direct fluorescent antibody test, identification of the virus genotype. Serum antibody testing, shows primary seroconversion, useful in the following. Copyright diagnosis of patients with a history of genital lesions who had no prior diagnostic workup or a negative HSV culture or PCR result. Assessment of infection status in individuals who have sexual partners with a documented genital HSV infection. O assessment of risk of vertical transmission from mother with HSV infection to child. 1. CE, smeared my herpes all over the tank. Herpes is detected by TZANCK smear. Resources, 7IL8. L. Back collapse. Find text outline. OS. CE. Treatment. Depending on the site, type, and severity of HSV1 infection, antiviral drugs are administered either topically or systemically. In most cases of recurrent infection, topical and or symptomatic treatment is sufficient. Antiviral treatment. Scent effect. Copyright decrease in duration and severity of infection, most effective if therapy is initiated within 72 hours of onset of infection. Copyright reduction of viral shedding. However, recurrence cannot be prevented. Agents. Copyright first line, orally cyclovir equals immunocompetent patients, Oral acyclovir for 7 to 10 days equals immunocompromised patients. Oral acyclovir for 14 to 21 days equals severe odynophagia or dysphagia. For acyclovir topical may be helpful if used early. I degree in case of acyclovir-resistant HSV1. Foscarnet copyright valacyclovir prodrug of acyclovir equals more expensive equals oral application copyright penciclovir equals topical application equals effective against HSV1, HSV2, VZV, and EBV ofamciclovir equals prodrug of penciclovir equals oral application scent prophylaxis, indicated in the case of frequent or severe relapses, in patients with prodromal symptoms copyright long-term suppressive therapy with VAL, acyclovir copyright variable results in studies copyright costly. Early treatment of herpes infections is essential to prevent complications because antiviral drugs only inhibit the virus during its replication phase. Symptomatic treatment. *4 fluids 5 cent barrier creams to avoid lip adhesion in cases of lesions on the lips scent pain relief, oral or 4, antipyretics scent antibiotics for bacterial superinfection, example amoxicillin, clindamycin. Prevention. Use of condoms, gloves consider isolation of hospitalized patients with shedding lesions. OS. CE. Related 1-minute telegram. Sent 1-minute telegram 70-2023-2/3, USP affirms, do not screen asymptomatic patients for HSV. Interested in the newest medical research, distilled down to just 1 minute? Sign up for the 1-minute telegram in tips and links below. G. CE. Tips and links. Sources. Last updated September 5, 2023. Back collapse fine text outline. Herpes labialis VV. Classical presentation of herpes labialis, multiple vesicles on an erythematous base located on the lower lip. Source, ID #1573, CDC/Dr. Herman, Centers for Disease Control and Prevention, CDC, licensed under public domain. Genital herpes VV. The entire genital area appears erythematous with an inflamed vaginal vestibule and urinary meatus. Solitary erythematous papules are visible inside the labia minora. Furthermore, there are white purulent lesions in the vaginal introitus. These findings are consistent with genital herpes, most likely caused by infection with herpes simplex virus type 2. Source, #16968, CDC/Dr. Wiesner, Public Health Image Library licensed under public domain. Genital herpes. Penile shaft and glands. 2 ulcerated blisters with erythematous margins are visible proximal to the corona of the glands. Source, #15822, CDC/Susan Lindsley, CDC licensed under public domain. Herpetic gingivostomatitis V. Typical clinical presentation of herpetic gingivostomatitis with multiple red erosions on the lower lip. Intact vesicles with surrounding erythema are found on the tongue. Source, ID #12616, CDC/Robert E. Sumter, Centers for Disease Control and Prevention, CDC, licensed under public domain. Uroherpes simplex virus infections, 1/2. Eczema herpeticum VV. A vesicular eruption with multiple monomorphic, circular, partially confluent lesions, many of which show central umbilication, is seen on the right shoulder of a patient with atopic dermatitis. This appearance is suggestive of eczema herpeticum. Source, copyright IMPP. Uroherpes simplex virus infections, 2/2. Eczema herpeticum V. The neck of a child with HIV and HSV infection, multiple painful vesicles and pustules, and flat punched-out ulcers with rolled edges, are visible. These findings are typical of eczema herpeticum. Source, Figure 22, in Atlas of Pediatric HIV Infection by Regina E. Olodican, Raniko J. Leloania, caregivers, Open Books, licensed under CC by ND 4.0. Euroherpes simplex virus infections, 1/2. Herpetic whitlow. The finger appears swollen and erythematous with blisters. This is a typical finding in herpetic whitlow, which is caused by infection with HSV1 or HSV2. Source: Herpetic Whitlow in Young Child by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Cutaneous manifestation of HSV infection VV. Multiple grouped, non-purulent and partly confluent vesicles on an erythematous base are visible on this patient's hands. These findings represent one possible skin involvement of HSV infection besides labial and genital manifestations. Source: Figure 15a, in Atlas of Pediatric HIV Infection by Regina E. Oladikan, Raniko J. Leloanya, caregivers, Open Books, licensed under CC by ND 4.0. Euroherpes simplex virus infections, 1/3. STL Ontal. 7 cents. Overlay. Herpes esophagitis endoscopy VV. Endoscopic view of the esophagus. Multiple well-circumscribed confluent ulcers, examples indicated by green overlay, are visible in the distal, lower, esophagus. These findings are consistent with herpes esophagitis. Histopathology is necessary to confirm the diagnosis. Source: Fig 1, in Epigastric pain associated with herpes esophagitis, case report by Antaki N, Al-Jaradzi, Dabas H, Haddad W, Akil Ma, Tarabishi as, BMC Infectious Diseases, licensed under CC by 4.0. Modifications, arrows removed. Euroherpes simplex virus infections, 1/3. STL Ontal. Overlay. Herpes esophagitis endoscopy VV. Endoscopic view of the esophagus. Multiple well-circumscribed confluent ulcers, examples indicated by green overlay, are visible in the distal, lower, esophagus. These findings are consistent with herpes esophagitis. Histopathology is necessary to confirm the diagnosis. Source: Fig 1, in Epigastric pain associated with herpes esophagitis, case report by Antaki N, Al-Jaradzi, Dabas H, Haddad W, Akil Ma, Tarabishi as, BMC Infectious Diseases, licensed under CC by 4.0. Modifications, arrows removed. Euroherpes simplex virus infections, 2/3. Overlay. Herpes esophagitis. Endoscopic view of the esophagus. Multiple ulcers with whitish-yellow exudates, green overlay, are visible almost circumferentially in the esophageal mucosa. In patients at high risk for herpes simplex virus infection, example due to immunodeficiency, these findings suggest herpes simplex esophagitis. The diagnosis should be confirmed by biopsy and immunohistochemical staining of the sample. Source: Herpes esophagitis.jpg by Donald E. Mansell, Wikimedia Commons, licensed under CC by SA 3.0. Euroherpes simplex virus infections, 2/3, be sent. Copyright. Overlay. Herpes esophagitis. Endoscopic view of the esophagus. Multiple ulcers with whitish-yellow exudates, green overlay, are visible almost circumferentially in the esophageal mucosa. In patients at high risk for herpes simplex virus infection, example due to immunodeficiency, these findings suggest herpes simplex esophagitis. The diagnosis should be confirmed by biopsy and immunohistochemical staining of the sample. Source: Herpes esophagitis.jpg by Donald E. Mansell, Wikimedia Commons, licensed under CC by SA 3.0. Herpes simplex virus infections, 3/3. Neonatal herpes simplex. Scalp of a 9-day-old newborn. Multiple partially confluent vesicles on an erythematous base are visible on the right frontotemporal aspect of the scalp. Further erythematous patches can be seen over the right temple and forehead. Source: Herpes neonatal herpes simplex by Kapitein Cavern, Wikimedia Commons, licensed under CC by SA 4.0. Euro herpes simplex virus infections, 1/1. Zancell VV. This smear from the base of a herpetic gingivostomatitis lesion shows a multinucleated giant cell, Pappenheim stain. This finding indicates a positive Zanc test. Herpetic gingivostomatitis is caused by HSV1. Source: Copyright IMPP. Rhyoamnionitis, neonatal infection, and omphalitis. Chorioamnionitis is defined as an intrauterine infection of the fetal membranes and amniotic fluid caused by bacteria ascending from the vagina. The most common pathogens are ureaplasma and mycoplasma species. Infected women typically present with fever, purulent vaginal discharge, and malodorous amniotic fluid. The combination of maternal, 120/min, and fetal tachycardia, 160/min, is highly indicative of intrauterine infection, and the condition should be managed promptly with antibiotics, supportive care, and possibly early delivery. Chorioamnionitis, as well as colonization of the maternal genital tract with group B streptococcus, may also be the cause of dangerous infections in the newborn. These include pneumonia, meningitis, and sepsis, and may be difficult to differentiate because symptoms in neonates are often nonspecific. Common findings include irritability, lethargy, temperature changes, dyspnea, and signs of cardiocirculatory distress, example hypotension. If neonatal infection is suspected, diagnostic procedures should be initiated immediately to identify the pathogen and source of infection, example blood and urine cultures. Management consists mainly of swift initiation of broad-spectrum empiric antibiotic therapy. Without proper treatment, systemic neonatal infections are associated with a high risk of complications and increased mortality rates. Newborns are also commonly affected by localized infections such as omphalitis, an infection of the umbilical stump. The condition is most often caused by Staphylococcus aureus and group A streptococcus and occurs 3 to 9 days after delivery. Clinical features include localized inflammation, swelling, and purulent discharge, which may progress to complications like sepsis and necrotizing fasciitis if not treated adequately with antibiotics, example ampicillin, gentamicin. WA. CE. Chorioamnionitis. Etiology. Scent infection of the amniotic fluid, fetal membranes, and placenta, most commonly due to ascending cervicovaginal bacteria. Common bacteria, Ureaplasma ureolyticum, up to 50% of cases, Mycoplasma hominis, up to 30% of cases, Gardnerella vaginalis, Bacteroides, Group B streptococcus, E. coli. Risk factors: prolonged labor or premature rupture of membranes, PROM, copyright pathological bacterial colonization of vaginal tract, example STDs, frequent UTIs, copyright latrogenic, multiple digital. Vaginal exams, invasive procedures, example amniocentesis, clinical features. Maternal O fever, 38 degrees Celsius or 100 degrees Fahrenheit, copyright tachycardia 120/min. O uterine tenderness, pelvic pain. O malodorous and purulent amniotic fluid, vaginal discharge. O premature contractions, PROM. Scent fetal tachycardia 160/min. in cardiotocography. Diagnosis. Chorioamnionitis is a clinical diagnosis, fever plus equals one additional symptom. Tests support or confirm diagnosis if the clinical presentation is ambiguous, example in subclinical chorioamnionitis. Scent maternal blood tests. O leukocytosis 15,000 cells/PL, 70 to 90% of cases, OTCRP. Scent bacterial cultures. O urogenital secretions. E amniotic fluid, most reliable, but rarely conducted, * group B streptococcus screening, cervicovaginal and rectal swabs management. Scent maternal antibiotic therapy. O vaginal delivery, 4 ampicillin plus gentamicin, broad coverage, 1 copyright cesarean delivery, 4 ampicillin and gentamicin, plus clindamycin, anaerobe coverage to minimize post-cesarean complications, example endometritis, scent delivery. Swift delivery is generally indicated to minimize both maternal and fetal complications. Cesarean delivery is not generally indicated, but is often necessary because of obstetrical complications, example insufficient contractions. Scent for treatment of newborns, see neonatal infection below. Complications. Scent maternal uterine atony, postpartum hemorrhage, endometritis. Copyright septic shock, DIC, venous thrombosis, pulmonary embolism, death. Scent fetal/neonatal. Back collapse. Find text outline. Scent fetal/neonatal. Fetal death, premature birth. Copyright asphyxia, intraventricular hemorrhage, cerebral palsy. Copyright neonatal infection, see below. References, 22 SII 4I. WA. OES. Neonatal infection. Etiology. Scent early onset infection/sepsis. Copyright. And Streptococcus agalactiae and Escherichia coli are the most common causes of both early and late onset neonatal sepsis. Symptoms. General presentation. Nonspecific, scent irritability, lethargy, poor feeding. Temperature changes, fever and hypothermia both possible. Scent cardiocirculatory, tachycardia, hypotension, poor perfusion and delayed capillary refill. 3 SEC respiratory, tachypnea, dyspnea, example expiratory grunting, apnea, more common in preterm infants. Scent skin tone, jaundiced and/or bluish gray, indicates poor perfusion. Specific symptoms. Scent neonatal meningitis. Copyright often no signs of meningism. Early phase, general symptoms, see above, vomiting. Late phase, bulging fontanelles, shrill crying, seizures, stupor. Neonatal pneumonia. Copyright tachypnea with intercostal/sternal retractions and nasal flaring. Reduced oxygen saturation with cyanosis. Diagnosis. Scent blood cultures or urine culture for suspected UTI. Copyright in GBS. Sepsis, blood agar plate reveals B hemolytic, gram-positive cocci that enlarge the area of hemolysis formed by S. aureus. Scent blood tests. Leukocytopenia or leukocytosis, thrombocytopenia. OTT-CRP. Scent lumbar puncture, tests cerebrospinal fluid for possible meningitis. Scent chest X-ray, may reveal clear signs of pneumonia, example segmental infiltrates, but more often nonspecific with diffuse opacities. Management. Supportive care, cardiopulmonary monitoring and support. Scent broad-spectrum antibiotics, LV ampicillin and gentamicin. Back collapse. Find text outline. Scent blood tests. See leukocytopenia or leukocytosis, thrombocytopenia. OTCRP. Scent lumbar puncture, tests cerebrospinal fluid for possible meningitis. Scent chest X-ray, may reveal clear signs of pneumonia, example segmental infiltrates, but more often nonspecific with diffuse opacities. Management. Scent supportive care, cardiopulmonary monitoring and support. Scent broad-spectrum antibiotics, for ampicillin and gentamicin. Copyright indications, clinical suspicion, confirmed or suspected maternal infection, example chorioamnionitis, adapt therapy according to antibiotic sensitivities. Prevention. Prophylaxis for neonatal GBS infection, see prenatal care. Prognosis. May cause septic shock within hours if treatment is inadequate, mortality rate up to 50%. Scent the longer symptoms are present, the higher the risk of developing meningitis. References 6 Lee 7 Islesold 11112. OOES. Omphalitis. Etiology. Scent bacterial infection of the umbilical stump occurring 3 to 9 days after delivery. Scent pathogens, Staphylococcus aureus, Group A. Streptococcus, E. coli, Klebsiella pneumoniae. Copyright Clostridium tetani, common cause of omphalitis and neonatal tetanus in developing countries. Risk factors, low birth weight, prolonged labor, maternal infection. Symptoms. Periumbilical redness, tenderness, swelling, and hardening. Purulent discharge. Signs of systemic infection, See neonatal infection above. Diagnosis. Scent generally a clinical diagnosis, although cultures should be conducted. Scent bacterial cultures, pathogen identification and antibiotic sensitivity testing, sample of discharge, in systemic infection, blood and cerebrospinal fluid cultures, detection of sepsis and meningitis, management. Scent broad spectrum for antibiotics, anti-staphylococcal penicillin, example oxacillin, plus aminoglycoside, example gentamicin. Scent surgery, complete debridement if complications arise. Complications. Scent sepsis, scent necrotizing fasciitis and myonecrosis, infectious muscle involvement rare, associated with high mortality rates. Prevention. Keep the navel dry, frequent diaper change, scent. Observe general hygiene measures. OFO. References, 13, L141I15. Sources. Last updated January 11, 2024. A. Find text. O. Outline. Omphalitis in a newborn. Ventral view on the umbilical region of a newborn, 5 days old, the umbilicus and surrounding tissue appear erythematous. The umbilicus is edematous and still connected to a necrotic, reddish-black umbilical stump. These features likely indicate omphalitis, which may progress to sepsis and should therefore be treated with systemic antibiotics. The blue clamp remains in place for 48-72H after birth for the umbilical cord to dry out. Source, copyright IMPP. X. Tinea versicolor. Tinea versicolor, pityriasis versicolor, is a benign superficial skin infection that occurs most often in young adults during hot and humid weather and is most commonly caused by the fungi Malassezia globosa and Malassezia furfura. The infection is characterized by finely scaling, hypopigmented or hyperpigmented macules on the trunk and slash or chest. Patients often become aware of the disease after sun exposure because the lesions do not tan and become more visible against the recently tanned surrounding skin. Diagnosis is commonly made clinically but can be confirmed with the spaghetti and meatballs pattern of the hyphae and spores on KOH preparation of skin scrapings. Antifungal topical medications such as selenium sulfide and ketoconazole are considered first-line treatment. Oral fluconazole and intricacies may be considered for those with severe, widespread, or refractory disease. Lesions will resolve completely over time, but recurrences are common. Tinea versicolor, despite its name, is not caused by dermatophytes. See dermatophyte infections for more information. 07 Fe, Lo. Epidemiology. Scent occurs worldwide, with a higher incidence in tropical climates. Scent more prevalent in healthy individuals 21 to 30 years of age. 1 Epidemiological data refers to the U.S., unless otherwise specified. 6x. Etiology. E. Pathogens. O. Malassezia species, previously known as Pityrosporum, most commonly Malia glob and Malia furfur. Copyright dimorphic, lipophilic yeast-like fungi that are part of normal skin flora. E. Not contagious. Scent risk factors. O. Warm and humid climates, 2230. Excessive sweating, seborrhea, and oily skin. O. E. Immunosuppression. E. O. Cushing's syndrome. Copyright genetic predisposition. OCES. Pathophysiology. Scent Malassezia species infect the stratum corneum equals lipid degradation, production of acids that inhibit tyrosinase and damage melanocytes. Hypopigmentation. Scent inflammatory response to pathogens. Hyperpigmentation. OOE. Clinical features. Scent round, well-demarcated macules that reveal a fine, subtle scale with gentle scraping that can coalesce into patches, which may have irregular shapes. Scent colors vary, hypopigmented, hyperpigmented, or erythematous skin lesions, plus lesions do not tan in the sunlight, because of which they are more commonly noticed in the summer. Milder pruritus, compared to dermatophyte infections, common sites are the trunk and chest, but the neck, abdomen, upper arms, and thighs may also be affected. Copyright patients often become more aware of the lesions after exposure to sunlight because the surrounding skin tans while the lesions do not. Back collapse fine text outline. IAST. Diagnostics. Sent usually a clinical diagnosis * confirmatory test, potassium hydroxide, KOH, preparation of skin scrapings reveals a spaghetti and meatballs pattern. 1A ultraviolet light, wood lamp, may reveal a coppery orange or yellow fluorescence, 30% of cases, FALTA. Differential diagnoses. Vitiligo, 2 seborrheic dermatitis, pityriasis rosea. Sent pityrosporum folliculitis, an infection of hair follicles caused by Malassezia species that typically manifests as pruritic, papulopustular eruptions. Tall copyright usually occurs in immunocompromised patients, example HIV, immunosuppressive therapy, stress, diabetes, steroid therapy. Copyright is often difficult to distinguish from acne vulgaris, and may also occur concurrently with it. The differential diagnoses listed here are not exhaustive. Treatment. See treatment of tinea versicolor for agents and dosages. Sent topical antifungals, first-line therapy, copyright selenium sulfide or zinc pyrithium in form of lotion or shampoo, copyright azoles, miconazole or ketoconazole, or allylamines, terbinafine, in form of cream. Sent oral antifungals are reserved for infections that are severe, widespread, or unresponsive to topical therapy to reduce the possible risks of systemic medication, not typically used in children. Copyright oral fluconazole or itraconazole are the preferred oral agents. G. Your notes at shared note. Prognosis. Sent the lesions will resolve without any permanent changes within 1 to 2 months of therapy. Recurrences are common and treatment may need to be repeated intermittently. OU. Sources. Last updated December 13, 2022. Tinea versicolor, 1/7. Pityriasis versicolor alba. Multiple hypopigmented macules, after UV exposure, are visible on this patient's back. This appearance is suggestive of pityriasis versicolor alba. Source, copyright IMPP. Tinea versicolor, 2/7. Tinea versicolor VV. Numerous hypopigmented, well-demarcated macules are visible on the patient's back. They coalesce in some regions and the lesions show fine scaling. This is the typical appearance of tinea versicolor, more specifically, pityriasis versicolor alba. Source, ID #17273, CDC/Dr. Gavin Hart, Public Health Image Library licensed under public domain. Les Olegiosides Zol believe in Jatha Faithfulness FT birthday calls M. Pityriasis versicolor. There are multiple round, well-demarcated, confluent, light brown macules visible on this patient's back. This finding indicates pityriasis versicolor, caused by Malassezia species. Source, ID #12534, CDC/Dr. Lucille K. George, Centers for Disease Control and Prevention, CDC, licensed under public domain. Tinea versicolor, 4/7. Les Stolioisois Zol believe in faithfulness of the God that calls me. Pityriasis versicolor rubra. There are several groups of red-brown, irregularly colored, coin-sized macula on the upper back of this 16-year-old female. The lesions and their localization are typical for pityriasis versicolor rubra. Image source of original image, www.pediatry-in-builder-n.de. Created by Dr. Thomas Rotten-Strock. R7 equals LSRD ses Wes Whale equals 1. Don't know what these plans are inkling me. Tinea versicolor alba, pityriasis versicolor alba, VV. Macular lesions with depigmentation and fine scaling are visible on this patient's forehead. Source, Pityriasis versicolor frontal original by Gupta Ogre, Wikimedia Commons, licensed under CC by SA 3.0. Tinea versicolor, 6/7. Argod reigns, Argodirans, Tinea versicolor alba, pityriasis versicolor alba. Macular lesions with complete depigmentation are visible along this patient's knees. Although the localization is atypical, this appearance is suggestive of tinea versicolor alba. Source: Figure 2, Macules achromiques de pityriasis versicolor de membres inférieurs chez l'homme sur terrain de depigmentation artificielle Observation 1, by Pauline Dias, Fatimata Lee, Mariam Abamo et al., Pan-African Medical Journal, licensed under CC by 4.0. Tinea versicolor, 7/7. Fors for tinea versicolor, alba, equals easy equals cabin argod rains well demarcated hypopigmented macules, that partly coalesce into bigger patches, as well as a fine brany scaling, are visible on the forehead of this child. This appearance is typical of tinea versicolor. Source: Figure 48a, sharply demarcated macule with fine brany scaling, in Atlas of Pediatric HIV Infection by Regina Eoloticon, Ranakoje. Leloania, Carol Halila et al., Penbooks, licensed under CC by ND 4.0. Tinea versicolor, 1/1. Malassezia furfur. Photomicrograph of a skin scraping. Throughout the image, there are multiple short, septated hyphae, filamentous structures, and spherical spores. These different morphological forms are responsible for the spaghetti and meatballs pattern, hyphae being the spaghetti and yeast being the meatballs, which is a typical finding of Malassezia furfur. Source: This photomicrograph of a skin scale reveals the presence of the fungus Malassezia furfur, CDC/Dr. Lucille K. George, Centers for Disease Control and Prevention, Atlanta, USA, licensed under public domain. Cables. Scabies is a parasitic skin infestation caused by the Sarcoptes scabii var. Hominis, S. scabii, mite, which is primarily transmitted via direct human-to-human contact. The female scabies mite burrows into the superficial skin layer, causing severe pruritus, particularly at night. Primary lesions commonly include erythematous papules, vesicles, or burrows. Treatment involves topical medical therapy, example permethrin, and decontamination of all clothing and textiles. W.A. Ooso. Etiology. Scent pathogen, Sarcoptes scabii var. Hominis scent transmission. Highly contagious. Copyright typically via direct physical, skin-to-skin or sexual, contact. Copyright rarely indirect transmission, example sharing textiles such as bedding, towels, or clothes. EO commonly affects children and individuals living closely with other people, example in nursing homes or jails. Scent risk factors, crowded living conditions, example institutions such as nursing homes, child care facilities, and prisons, TI. AE. Al, T/WW. References, 2LL3. CE. Pathophysiology. Scent. The fertilized, female mite tunnels into the superficial skin layer, stratum corneum, forming burrows in which she lays her eggs and deposits feces, sibylla. Scent. After 2 months, the female parasite dies on site. Scent. Following a period of 3 weeks, the larvae mature into adult mites, maintaining the infestation cycle. The excretions of the mites and their decomposing bodies contain antigens which cause an immunological response, see type 4 hypersensitivity reaction, presenting as severe pruritus and excoriations. References for OCE. Clinical features. Incubation period, approximately 3 to 6 weeks following infestation. Intense pruritus that increases at night. 5 scent burning sensation. Scent skin lesions. Degree elongated, erythematous papules burrows of 2 to 10 mm in length. Scattered vesicles filled with clear or cloudy fluid. Degree excoriations, pustules, and secondary infection. Degree bullous or nodular formation, especially in children, formation of crusts. Post-inflammatory hyperpigmentation. Degree scent predilection sites. Degree wrists, flexor surface, medial aspect of fingers, interdigital folds, hands and feet, male genitalia, example scrotum, penis, all other intertriginous areas of the skin, anterior axillary fold, buttocks, areas surrounding the nipple, mammillary region, periumbilical area or waist, knees, flexor surface, elbows, feet, dorsal and lateral aspect. Additionally, in children, elderly persons, and immunosuppressed patients, scalp, face, neck, under the nail, palms of hands, and soles of feet. Back collapse, fine text outline. Degree. References 6L. OS. OE. Subtypes and variants. Crusted scabies, Norwegian scabies. Scent definition: a rare, severe, and highly contagious form of scabies that presents with a large number of scabies mites and eggs on the skin. Scent epidemiology: typically occurs in immunosuppressed, example HIV, debilitated, or elderly patients. Scent clinical features: copyright slightly pronounced or absent pruritus. O lesions equals thick crusts or scales on an erythematous base with irregular borders equals may have a wart-like appearance and fissures. Nail changes, i.e., dystrophic, thick. Copyright location equals typical areas include the scalp, hands, and feet equals may involve the whole integument, especially if left untreated. Scent treatment: rapid and aggressive medical therapy with a scabicidal agent to prevent an outbreak. Diagnostics: scent typical history and skin lesions on clinical examination. See symptoms/clinical findings above. Scent environmental diagnosis: direct contact with infected persons. Scent detection of mites, larvae, ova, or mite feces O revealed in dermoscopic. Copyright microscopic examination of the skin O skin scraping and histology. And scabies may be mistaken for eczema, especially as the topical use of glucocorticoids initially alleviates symptoms. Differential diagnoses. Scent definition: ectoparasitic arthropods of the Simidae family that feed on blood, typically at night, while individuals are asleep, and whose bite leaves a painless papule that typically becomes pruritic over time. Pathogen: Cymex lectularia. Scent transmission: direct contact with infested beds and other furniture and/or travelers who bring home bed bugs or their eggs, example on clothes, in luggage, from stays in infested residences. Scent risk factors: crowded, unsanitary living conditions. Scent clinical features. Back collapse, fine text. Outline. Scent clinical features: asymptomatic red punctum at the site of the bed bug bite. Copyright localized skin reactions on exposed skin equals painless. Erythematous papules with hemorrhagic punctum in the middle equals size 2 to 5 mm equals often appear in a linear pattern equals pruritus is common equals resolve spontaneously within 1 to 2 weeks. Diagnostics: copyright consult a pest control service. Copyright detection of bed bugs in the patient's environment confirms the diagnosis. Treatment: management of pruritus, oral antihistamines and/or topical corticosteroids eradicate infestation, insecticides or heat treatment. Copyright antibiotic therapy in event of secondary bacterial infection. Copyright if necessary, treat cohabit ants with similar symptoms. Prognosis: bites usually resolve spontaneously within 7 days. The differential diagnoses listed here are not exhaustive. MA-RA5. Treatment: scent medical therapy, topical application of a scabicidal agent. 1. Copyright drug of choice, permethrin 5% lotion. 1 equals mechanism of action, inhibition of voltage-gated sodium channels in the mite, delayed repolarization of neurons, paralysis and death of the mite. Alternatives: lindane 1% lotion, in the case of treatment failure or side effects. 1 mechanism of action, blocks GABA channels. Neurotoxicity in the mite. Oral ivermectin, especially indicated in large outbreaks or severe forms of scabies equals others. Crotamycin 10% cream or lotion, sulfur ointment. Symptomatic treatment of pruritus equals oral antihistamines. Possible topical corticosteroid, example hydrocortisone, If severe, all close contacts should receive prophylactic treatment. Scent general measures: wash all textiles, example clothing and bedding, day 1 and day 8 post-treatment. All contacts within the household should be treated for scabies infestation, even if asymptomatic. A6. Complications. Plus bacterial superinfection can lead to post-streptococcal glomerulonephritis, generalized involvement, degree eczema, ACO MASH, copyright pyoderma BSST0/Bruolymphadenitis. Back collapse. Find text. At A. Outline. Treatment. Asterisk medical therapy, topical application of a scabicidal agent. 1. Copyright drug of choice, permethrin 5% lotion. 1 equals mechanism of action, inhibition of voltage-gated sodium channels in the mite, delayed repolarization of neurons, paralysis and death of the mite. Degree alternatives: lindane 1% lotion, in the case of treatment failure or side effects. 1 equals mechanism of action, blocks GABA channels. Neurotoxicity in the mite equals oral ivermectin, especially indicated in large outbreaks or severe forms of scabies. Equals others, crotamycin 10% cream or lotion, sulfur ointment. Symptomatic treatment of pruritus equals oral antihistamines. Equals possible topical corticosteroid, example hydrocortisone. If severe OE, all close contacts should receive prophylactic treatment. Scent general measures: wash all textiles, example clothing and bedding, day 1 and day 8 post-treatment. All contacts within the household should be treated for scabies infestation, even if asymptomatic. WA. OROS. Complications. Scent bacterial superinfection can lead to post-streptococcal glomerulonephritis. Scent generalized involvement: eczema, pyoderma, lymphadenitis. We list the most important complications. The selection is not exhaustive. OIOE. Prevention. The local healthcare department should be notified of a suspected threat of community outbreak of scabies and the following measures implemented for scent: single non-crusted case. Copyright following direct contact with the skin or a patient with scabies, hands should be thoroughly washed, also underneath the nails, then disinfected with an agent that is effective against scabies mites. Copyright appropriate identification and treatment of scabies in the affected individual, with adequate follow-up. All contacts, including within the hospital, should receive prophylactic treatment. Copyright avoid skin-to-skin contact for 8 hours after initial treatment. Copyright increase surveillance for new cases. Scent multiple non-crusted cases. Copyright in addition to the above, an institution-based awareness and education program. Adequate recording of epidemiological data. Scent crusted scabies case, same as above, but more rapid and aggressive approach. References: OC. Fay. Tips and links. Sources: last updated July 11, 2022 v. Back collapse. Find text outline. Copyright. Overlay. Scabies mite, Sarcoptes scabii ivar hominis. Photomicrograph of a human itch mite, Sarcoptes scabii ivar hominis, Sarcoptes scabii ivar hominis. The mite that causes scabies has a round body and 4 pairs of legs. Green overlay. The front legs end in suckers, while the hind legs end in long bristles. Between the medial front legs, the scabies mite has a mouth part, red overlay, that it uses for burrowing into the host's skin. Between the medial posterior pairs of legs, the anus of the mite is visible, yellow overlay, from which the female mites lay eggs in the skin stratum corneum. Source: ID #6301, World Health Organization, Geneva, Switzerland. Centers for Disease Control and Prevention, CDC, licensed under public domain. DATH. And AASLEHSS Betfed A equals TSBFed. Skin lesion in scabies VV. Localization: peri-umbilical region lesion, papules, erythema, excoriations. Description: elongated, erythematous papules, inflamed nodules, and excoriations. Source: Copyright IMPP. Scabies, 2/7. HJICAI sal os olei shaley scabies skin lesions. Multiple erythematous papules, partially excoriated, are visible in the interdigital folds and on the dorsal aspect of the hand and fingers. Copyright Emboss. Interdigital skin lesions in scabies. Multiple erythematous papules can be seen in the interdigital folds between the index and middle finger. Interdigital folds are a common site for scabies, as the scabies mite prefers warmer skin regions with a thin keratinous layer. Source, ID #15831, CDC/J Centers for Disease Control and Prevention, CDC, licensed under public domain. Co-scabies, 4/7. Penile skin lesion in scabies. Multiple, elongated, erythematous papules are visible. Because of scratching, central crusts have formed on the papules. This appearance is suggestive of scabies. Source, IG #15383, CDC/MRAIN, MD, University of Virginia, Susan Lindsley, Centers for Disease Control and Prevention, CDC, licensed under public domain. Scabies, 5/7. AEF3AI4 fly equals 7EE care, 7 Otis. \FEE, LF4, _AP. As equals a CIEOE pompous cent INEYGA. A.S4. Scabies. Multiple erythematous, partly excoriated papules and burrows are visible on the back of the hand, the fingers, and the intertriginous area. Source, Figure 1, in Scabies-infested pregnant women, a critical therapeutic challenge by A. Wild, C. Bernigod, M. Moni et al., plus, neglected tropical diseases, licensed under CC by 4.0. Scabies, 6/7. Sons equals OL scabies by Z01S2SHLI. Multiple papules with excoriation are visible on this patient's trunk, ESP around the umbilicus, around which the skin appears lichenified. These findings together with pruritus are suggestive of scabies. Copyright Emboss. Scabies. Multiple papules, diffuse erythema, and excoriations, likely with secondary bacterial infection, are visible on the buttocks. These findings, together with a history of severe itching, are suggestive of scabies infection. Source, Figure 9, in The Spectrum of Skin Diseases in a Rural Setting in Cameroon, Sub-Saharan Africa, by Anne-Cécile Zaunkanyi Bisek, Ernest Njitaba, Emmanuel Kouatou et al., BMC Dermatology, licensed under CC by 2.0. Crusted scabies, Norwegian scabies. Lesion, papules, nodules. Description, multiple, brown papules and maculopapular erythrodermia. Source, copyright IMPP. Scabies, 2/2. ASEH crusted scabies, Norwegian scabies, Deci 0, BSH. Thick crusts, scaling, and fissures are visible on both hands and the left arm of this patient with AIDS. This is a severe case of crusted scabies, a highly contagious form of scabies that typically occurs in immunosuppressed or debilitated patients. Source, Norwegian scabies, Uxter 1, Wikimedia Commons licensed under public domain. Scabies, 1/1. Lieslav trace Saint crusted scabies, Norwegian scabies. Photomicrograph of skin tissue, H&E stain, mites are visible in the horny layer, stratum corneum, of the epidermis. Source, copyright IMPP. Scabies, 1/1. Falls as APEAASEOSS0 tet bed bug bites. Numerous macules and papules, both isolated and in clusters, are visible on the back. While this finding is typical of bed bug bites, they can appear in a wide variety of cutaneous reactions. Source, Bedbug 2 by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. PEC-AVA. Malayak20, Lissi Sohaye bacterial superinfection of a scabies skin lesion. Photograph of the left arm of a young patient after treatment for scabies. A circular, well-demarcated scar with a central crust is visible on this patient's forearm. Scarring here occurred after bacterial superinfection of a scabies lesion. Copyright Embellished. Scabies, 2/4. 21 KXIOMISA of S9 Lis Neghale bacterial superinfection in scabies. Lower leg with multiple papules, vesicles filled with cloudy fluid, excoriations, local inflammation, and crusts, suggesting bacterial superinfection of scabies lesions. Copyright Embellished. Scabies, 3/4. Bacterial superinfection in scabies. Leclo telophyst epto-ia left lower leg of a 10-year-old boy with scabies LEBs, multiple excoriated papules and patches are visible on this patient's foot. An ulcerated lesion with paralesional yellow-brownish crusts is visible on the lower leg. The findings on the foot are consistent with scabies, whereas the findings on the lower leg indicate a bacterial superinfection in an excoriated area. Copyright Embellished. As OI. Cellulitis in superinfected scabies 711 SREAAE diffuse, poorly demarcated erythema and edema associated with small, crusted red patches are visible over the left leg. These findings are consistent with cellulitis due to scabies infection. Copyright Embellished. XX lice infestation. There are 3 species of lice that affect humans: Pediculus humanus capitis, head louse, Pediculus humanus corporis, body louse, and Thyrus pubis, pubic or crab louse. All are obligate, stationary ectoparasites that feed solely on human blood. Affected individuals most commonly present with pruritus, although early stages of infestation and mild cases may be asymptomatic. Detection of lice or nits, louse eggs, on the body or clothes usually confirms the diagnosis. Treatment includes topical pediculicides as well as non-pharmacologic measures, example machine washing and drying contaminated clothing/sheets. Secondary skin infections from scratching may occur in all forms of pediculosis, lice infestation. The body louse acts as a vector for louse-borne diseases, including epidemic typhus, trench fever, and relapsing fever. Overview. Parasite. Transmission. Location of nits. Clinical manifestation. Epidemiology. Diagnosis. Treatment. Complications/other considerations. Head lice infestation. Pediculosis humanus capitis. Direct head-to-head contact. Scent head hair. Asymptomatic, or scalp/neck pruritus. Asterisk most common in children, affects 1% of school-aged children in North America. Detection of nymphs and adult lice on hair shafts. The presence of nits alone does not indicate active infestation. 10-minute topical application of pediculicides, example 1% permethrin or pyrethrin. Repeat application 10 days later. Children with head lice should receive prompt treatment but can continue attending school. Machine wash and dry bedding, clothes, etc., equals 55 degrees Celsius to 131 degrees Fahrenheit, for 30 minutes, alternatively, dry clean or store in a sealed plastic bag for 2 weeks. People in close contact should be screened for infestation. Scent. Secondary skin infections from scratching and skin breakdown. Pediculosis capitis, head lice infestation. Body lice infestation. Pediculosis humanus corporis. Direct contact or fomite transmission, example clothes. Threads of clothing. Asymptomatic intense pruritus, linear excoriations, post-inflammatory hyperpigmentation, puncta from fresh bites. Most common in areas of poverty, crowding, and poor personal hygiene. Detection of lice or nits in the seams of clothing. Lice are uncommonly found on the skin itself. Warm bathing and changing into new clothes. Machine wash and dry bedding, clothes, etc., equals 55 degrees Celsius to 131 degrees Fahrenheit, for 30 minutes, alternatively, dry clean or store in a sealed plastic bag for 2 weeks. Topical pediculicides may also be needed for patients when nits are identified on body hair. Secondary skin infections from scratching and skin breakdown can be a vector for epidemic typhus, trench fever, and relapsing fever. Pubic lice infestation, crabs. Thyrus pubis. Usually sexual contact. Pubic hair can also occur on axillary or facial hair, including eyelashes. Intense pruritus in pubic, perianal, or axilla area, maculae ceruleae, pale blue-purple macules, in patients with chronic infection. Most common in teenagers and young adults. Detection of lice or nits on hair shafts. 10-minute topical application of pediculicides, example 1% permethrin cream or pyrethrin, re-evaluate after 9 to 10 days, and repeat treatment if lice are found. Machine wash and dry bedding, clothes, etc., equals 55 degrees Celsius to 131 degrees Fahrenheit, for 30 minutes, alternatively, dry clean or store in a sealed plastic bag for 2 weeks. Screen for other STIs. Many patients have another STI, and treat sexual partners to prevent reinfestation. LIQ. Otildyl St. Brio LHBE Saruol. Scent epidemiology, most common in children, affects 1% of school-aged children in North America. Scent parasite, Pediculus humanus capitis, 3 mm in length. Scent transmission, direct head-to-head contact or sharing hair accessories, bedding, or clothing. Scent clinical features may be asymptomatic initially and in mild cases copyright scalp/neck pruritus and excoriation. Scent diagnostics copyright detection of nymphs and adult lice on the scalp or hair, often visible with the naked eye. Copyright confirmation with microscopy of a hair shaft or Wood's lamp examination. Nits fluoresce and appear pale blue. Scent treatment copyright 10-minute topical application of pediculicides followed by mechanical removal of lice and nits with a fine-toothed comb. Repeat application after 10 days. CE pad collapse. A. Fine text. O. Outline. X lice infestation. Scent treatment copyright 10-minute topical application of pediculicides followed by mechanical removal of lice and nits with a fine-toothed comb. Repeat application after 10 days. First line, 1% permethrin shampoo or pyrethrin alternatives, i.e., in permethrin-resistant areas malathion shampoo, topical ivermectin, benzyl alcohol, and spinosad. Copyright clean combs, hair brushes, and hair accessories of lice and nits, i.e., soak in hot water for 5 to 10 minutes, comb machine wash and dry bedding. Clothes, etc., 55 degrees Celsius, equals 131 degrees Fahrenheit, for 30 minutes, alternatively, dry clean or store in a sealed plastic bag for 2 weeks. Copyright children with head lice should receive prompt treatment but can continue attending school. Copyright people in close contact with affected individuals should be screened for infestation. Complications, secondary skin infections from scratching and skin breakdown. Add, the presence of nits alone does not indicate an active infestation. References. W.A. O.E. Pediculosis corporis, body lice infestation. Parasite, Pediculus humanus corporis, 3 to 5 mm in length. Transmission, direct head-to-head contact or sharing hair accessories, bedding, or clothing. Epidemiology, most common in people living in crowded, unsanitary living conditions, example homeless. Clinical features, pruritus is the chief complaint, puncta from fresh bites, linear excoriations, and post-inflammatory hyperpigmentation, typically at the waist, axilla, and neck. Diagnosis, detection of lice or nits in clothing, especially at the seams, with the naked eye, on microscopy, or wood lamp examination. 1. Treatment: warm bathing and changing into new clothes. Copyright topical pediculicides when nits are detected on body hair, example permethrin, machine wash and dry bedding, clothes, etc. 255 degrees Celsius, equals 131 degrees Fahrenheit, for 30 minutes, alternatively, dry clean or store in a sealed plastic bag for 2 weeks. Complications: secondary skin infections. Copyright possible transmission of one of the following: Rickettsia prowazekii, epidemic typhus, Borrelia recurrentis, relapsing fever, Bartonella quintana, trench fever. References: LL2 Oesazole equals 0 L2TNNO. So pediculosis pubis, pubic lice infestation. Plus parasite, Thyrus pubis, also known as the crab louse, often referred to as crabs because of its crab-like appearance, 1.5 mm in length. Transmission, usually sexual contact, can also be transmitted via infested towels or bedding. Scent epidemiology, most common in teenagers and young adults. Scent clinical features. Copyright pruritus and excoriations in the pubic area are common, can also occur in the perianal and axillary region. Maculae cerulei, pale blue-purple macules. 4, in patients with chronic infection. Diagnosis, identification of louse or nits in pubic hair with the naked eye during microscopy or wood lamp examination. Scent treatment. Copyright 10-minute topical application of pediculicides, example 1% permethrin cream or pyrethrin, re-evaluate after 9 to 10 days, and repeat treatment if lice are found. Copyright machine wash and dry bedding, clothes, etc., equals 55 degrees Celsius, equals 131 degrees Fahrenheit, for 30 minutes, alternatively, dry clean, or store in a sealed plastic bag for 2 weeks. Screen for other STIs and treat sexual partners to prevent reinfection. Back collapse. Find text outline. And pediculosis pubis, pubic lice infestation. Scent parasite, Thyrus pubis, also known as the crab louse, often referred to as crabs because of its crab-like appearance, 1.5 mm in length. Copyright scent transmission, usually sexual contact, can also be transmitted via infested towels or bedding. Scent epidemiology, most common in teenagers and young adults. Scent clinical features: pruritus and excoriations in the pubic area are common, can also occur in the perianal and axillary region. Maculae cerulei, pale blue-purple macules, in patients with chronic infection. Plus diagnosis, identification of louse or nits in pubic hair with the naked eye during microscopy or wood lamp examination. Scent treatment. Copyright 10-minute topical application of pediculicides, example 1% permethrin cream or pyrethrin, re-evaluate after 9 to 10 days, and repeat treatment if lice are found. Copyright machine wash and dry bedding, clothes, etc., equals 55 degrees Celsius, to 131 degrees Fahrenheit, for 30 minutes, alternatively, dry clean or store in a sealed plastic bag for 2 weeks. Copyright screen for other STIs and treat sexual partners to prevent reinfection. References: LL3 Oso Pediculosis ciliaris. Scent parasite, Thyrus pubis, same as in pediculosis pubis. Scent transmission, direct contact with infested individuals, towels, or bedding. Scent epidemiology, most common in teenagers and young adults, may occur in children in close contact with infested adults. Scent clinical features: pruritus or irritation, usually bilateral. Copyright crusted eyelashes. Features of conjunctivitis. Diagnosis, detection of lice or nits close to eyelash base, may also be seen in the eyebrows or hairline. Scent Treatment copyright mechanical removal of lice and nits after applying petroleum jelly to eyelids copyright treat associated conjunctivitis copyright local pediculicide treatment for persistent cases if the above therapy fails. Jezorzol. References. 3. IEEE, ASES 0/0 I at A equals source B at ectoparasiticides. Said general measures or physical measures, example mosquito nets long clothing, repellents, degree legal measures, example insecticide sprays 1 electric insect killers, said ectoparasiticidal drugs, see overview of ectoparasiticides. OC degree IEEE. Sources. Last updated August 10, 2021. Back collapse bind text. Outline. 3H16 YEAD of lice infestation, 1/3. James ABEEI irrational. Louse eggs under magnification man hair on the scalp. Transverse. Magnified image of asingle who owns the louse. IR shaft. The 2 red points indicate the eyes copyright the louse egg IS attached to the HANISB terrain Centers for Disease Control and Prevention, CDO, licensed under ID hashtag 378, CDC/Dr. Den public domain. Telio H4STSH SFT, SCE STS equals 010. Developmental stages of the body louse. Different developmental stages of the body louse are shown. The nymph stages can be seen from N1 N3, followed by the adult male and adult female louse. Source, ID hashtag 10854, CDC/Joseph Strickhartz, PhD, Kyung Sup-yoon, PhD, Frank Collins, PhD, Centers for Disease Control and Prevention CDC, licensed under public domain. Lice infestation, 3/3. TAS. Herschel SFT, FIL4S01 of Thyrus pubis, crab louse, VV. The crab louse is small, 1.3 to 1.6 mm in length, with a wide body and 3 pairs of legs. Source, copyright IMPP. Lice infestation, 4 halves. UD equals 0Z0 Il May 0 E0 Tet. Louse eggs under magnification and hair on the scalp, transverse, magnified image of asingle hum F the louse. IR shaft. The 2 red points indicate the eyes copyright a louse egg IS attached to the